topic which is the management of early GDM. So personalized approach. So when I was a resident in 2010, these things were very simple. So we were told that gestational diabetes, you have to do a universal screening at 24 to 28 weeks. There was not much confusion. Only the gap was implementation. We have to accomplish the universal screening and then institute the appropriate management to improve outcomes. But after 2010, there has been a major change, and the change is basically continuously evolving and has led to very in-depth understanding of GDM also, some controversies also, confusion also, and a need for further research. So basically in 2010, what IADPSC did, that it provided the IADPSC criteria for diagnosis of gestational diabetes, which was basically validated in terms of maternal and neonatal outcomes. But given the rise in age and obesity at conception, there were many women who were entering pregnancy as undiagnosed diabetes. So they introduced the term overt diabetes in pregnancy and asked for universal screening to detect these undiagnosed cases of diabetes during pregnancy. The new term came into existence, which was called the overt diabetes in pregnancy. That was to be detected before 20 weeks. But when you screen for overt diabetes, there may be some scenarios where the women will not have any normoglycemia, women is not having overt diabetes in pregnancy, but there are some intermediate hyperglycemia which needs some attention or management. So that term then was coined with, was early gestational diabetes. So early gestational diabetes is basically when you screen women and found intermediate hyperglycemia before 20 weeks of gestation. So from simple, normal and late GDM at 24 to 28 weeks, these two new terms were introduced in 2010. But now over the last 5 to 7 years, with the evolving understanding of early GDM, it has been realized that not all cases of intermediate hyperglycemia, which are labeled as early GDM, behave as GDM. So many women which have elevated values in the early pregnancy, if you do nothing to them, they will regress to normal. So that new phenotype has come that is called the regressors. Means the early GDM on the basis of diagnostic threshold, by time, even without any intervention, regressing to normal at 24 to 28 weeks, that calls the regressors. So basically we have a genuine early GDM and we have a regressor phenotype, and then there is a concept where there are some abnormal elevated values which are not classified as early GDM, but these patients can have late GDM later on at 24 to 28 weeks. So basically even with the early GDM, there are multiple phenotypes data embedded in this one single entity. So basically the focus of my talk will be to give you some understanding of these 4 different phenotypes of early hyperglycemia and how we approach them during antenatal period. So I will discuss these 4 phenotypes with each with a case scenario so that you understand better and how to tailor your management plan according to the individual phenotype. So let's start with the case 1. It's a 32-year-old female, primary gravida, 9 weeks of gestation, BMI of 28 kg per meter square, family history of diabetes, history of PCOS, and has not been evaluated for glycemia in the last 1 year. So the first question comes, should we screen for hyperglycemia in pregnancy before 24 weeks of gestation? The answer is yes. So any women in the Indian context, because South Asian ethnicity is a high risk ethnicity, so the Ministry of Health and Family Welfare guidelines also says that we have to do a universal screening at first antenatal visit to detect overt diabetes in pregnancy and early gestational diabetes. So there is no doubt. So any women you see in the first antenatal visit, universal screening has to be done for these women. And since this women has additional multiple risk factors, there is no point of not screening these women in the early antenatal visit. The second question comes, if yes, what should be our approach for our screening, right? So what we do at AIMS, if it is a high risk phenotype, how we define? if there is any additional risk factors apart from South Asian ethnicity, like for example, this women had PCOS, overt diabetes, PCOS, high BMI, so there are multiple risk factors. If you have like additional risk factors, what we do is 75 gram GTT and A1C for such a women. If women has no risk factors, then we screen for fasting plasma glucose and A1C. So this women had multiple risk factors. So this women need a 75 gram GTT and A1C. If the cutoffs on screening exceeds the non-pregnant diagnostic cutoff for diabetes, then the women is labeled to have overt diabetes in pregnancy. The second thing what need to be kept in mind that if you are employing A1C for screening for hyperglycemia in pregnancy, it has to be used only for less than 15 weeks of gestation. So A1C in screening in pregnancy has value if employed before 15 weeks of gestation. After that, it has no diagnostic role in hyperglycemia in pregnancy. So two main points: high risk, screen with a 75 gram GTT and A1C. If it is low risk, at least fasting plasma glucose. If facilities are available, maybe A1C can be combined, and A1C not to be used for screening after 15 weeks of gestation, though it can be used as a management guide. So this women had a test of 128 milligram fasting glucose, A1C of 6.7. So clear cut, this patient exceeds the cutoff of overt diabetes in pregnancy and is labeled to has overt diabetes in pregnancy. So there is a fundamental change in definition. Initially in 2009, it was labeled as gestational diabetes. So if this women get screened and these were the cutoffs, so these women were used to called as gestational diabetes, which was defined as any degree of glucose intolerance with onset or first recognition during pregnancy. Now with the revised definition, these women have overt diabetes in pregnancy, not gestational diabetes. So this is one fundamental change that has happened for the last 15 years back. How this lady is different from a gestational diabetes and what additional need to be done? So since most of these women will have pre-existing diabetes, it needs workup for complication, means nephropathy, retinopathy, and from history for macrovascular complication. Intensive monitoring. So we asked these women to do a 6-point blood glucose monitoring and show up in 2 to 5 or 2 to 7 days to see what is a response on diet, exercise, and or initial therapy, intensive follow-up. It is better to use multiple subcutaneous insulin injection for such a women because these women are at high risk of adverse pregnancy outcomes. We need to do early gynae referral because these women are prone to congenital malformation because they have entered unprepared and with a high glucose levels in the pregnancy. So chances of congenital malformation are maximum in the overt diabetes in pregnancy detected early in pregnancy because they have received no preconception care and are detected first time in pregnancy. So early gynae referral is required so that whatever the ultrasound or additional test can be done. These women may be candidate for prophylaxis for preeclampsia. Again, the early gynae referrals are required. And most of the women will progress to overt diabetes or frank diabetes in the early postpartum years. So intensive lifestyle modification, testing, and close follow-up is required for such women during the postpartum period. So these are the fundamental differences of overt diabetes in pregnancy compared to early gestational diabetes or gestational diabetes as such as a whole. So this is the most adverse phenotype out of these 4 phenotypes, which needs very close attention and monitoring and follow-up. Now coming to the case 2 scenario, a similar women, BMI 28, family history of diabetes, history of PCOS. So the test results are not normal and neither diagnostic of overt diabetes in pregnancy. So the values are 0 are 105, 1 are 208, 2 are 160. So the normal cutoffs as per 75 gram GTT and IATPSC criteria is 92, 180, 153. So these women are clearly having elevated blood glucose levels compared to the normal. So this will classify as early gestational diabetes. So what is a revised definition of gestational diabetes? Now it is classically been defined as maternal hyperglycemia, which is first discovered in pregnancy, but that does not meet the threshold for overt diabetes in pregnancy. So this clause is must for the revised definition of gestational diabetes. So this woman is labeled as early gestational diabetes. Now the question comes, what why early gestational diabetes is important and how it is different from the late gestational diabetes. Late gestational diabetes means diagnosed after 20 weeks of gestation. So this is a data from St. Stephen's, Delhi from Dr. Punos et al., which clearly shows that early gestational diabetes is having more adverse pregnancy outcomes compared to the late GDM and normoglycemia. So if you see the red figures, so they are clearly more compared to the late gestational diabetes or the normoglycemia, clearly indicated that early gestational diabetes is associated with poor pregnancy outcomes. This is data from our own study which suggests that if patient is diagnosed as an early gestational diabetes, the postpartum rates of diabetes is 22%. And if the woman was diagnosed as a late gestational diabetes, means after 20 weeks of gestation, the postpartum diabetes rate was 12%. So early gestational diabetes is not only associated with the poor pregnancy outcome, but is also having a poor postpartum outcomes. Now with the publication of TOBOGM study in the 2023, so it clearly suggested that women, if treated before 20 weeks of gestation, so you can improve the outcomes. So there is a level 1 evidence which now shows that treatment of early gestational diabetes can help in improving the pregnancy outcomes. So now it is important to detect and treat early gestational diabetes in pregnancy to improve the maternal and neonatal outcomes. There is further clause from the TOBOGM study. It is not that all women diagnosed with the early gestational diabetes will get benefited from the treatment. So what the TOBOGM study showed that women who had higher glycemic range, means when you do a 75 gram GTT, there is a lower glycemic band, 92 to 94, 0R, 1R, 180 to 190, 2R, 153 to 161, then there is a higher glycemic band, which is depicted in this slide, much more than 95, 1R more than 191, 2R more than 162. So if the glycemic thresholds are higher, so these women are likely to be more benefited from the intervention. And the benefit is maximum if you detect and treat women before 14 weeks of gestation. So what the key message comes in this regard, that if you want to improve the pregnancy outcomes in early gestational diabetes, you have to screen women before 14 weeks of gestation. If women is detected early, then you institute treatment, especially in the higher glycemic band, then the pregnancy outcomes will improve. If we do a later screening later than 14 weeks, the benefit will not be that much as compared to the early screening before 14 weeks of gestation. So one clear message or one clear figure that should be in the brain, that we have to accomplish diagnostic screening and management before 14 weeks of gestation. That is key message from all these studies that have come. So the second phenotype is a genuine early gestational diabetes with a higher glycemic thresholds detected at a right time. Then there is a third case scenario, if like you have a similar women, but there is no risk factors. One is a women with the risk factors, second is a women without any risk factors. So what should be our approach? So what we do for a low risk women, do a fasting plasma glucose and A1C for screening for such a women with a low risk phenotype. So after screening, the test result come out to be 94. Normal for IADPH is 92 milligram per deciliter and A1C is 5.3%. So the patient doesn't have any pre-existing pre-diabetes or overt diabetes in pregnancy, but the fasting value is a little bit elevated. So if you see the cutoffs of WHO 2013 criteria, so by cutoff these women will be labeled as early gestational diabetes. But by behavior or evidence, these women actually do not behave like a true GDM. So there has been a studies which shows that in pregnancy there is a physiological fall in fasting plasma glucose. So if the woman is having, for example, 89 milligram per deciliter to start with at 4 to 6 weeks, and if you do nothing, there is a physiological dip of 10 milligram per deciliter during pregnancy in fasting plasma glucose. This means that 94 milligram per deciliter, which looks abnormal to start with, by time it will go less than 90 milligram per deciliter. That is called the regression, right? So this is the physiological dip which occurs during pregnancy, and it has been seen that if the fasting plasma glucose is between 92 to 99 milligram per deciliter, 67% of the women, if subjected to repeat GTT at 24 to 28 weeks, will come out to be normal. So 92 to 99 milligram per deciliter isolated fasting plasma glucose, 70% of the women are actually not GDM. They will be normal at 24 to 28 weeks. Even between 100 to 109 milligram per deciliter, 50% of the women will behave as true GDM, 50% will regress to normoglycemia. And in more than fasting, more than 110, there are high chances that women has gestational diabetes. So what's the key message from this study is that 92 to 99 milligram per deciliter, if you are using IADPSC criteria in early pregnancy, be very skeptical. These women, 70% chances are not GDM. If you treat these women as GDM, you are actually resulting more harm than good. That is a key message. Even from the Tobugium study, where the 75 gram GTT was done in the early pregnancy, what they have observed that if the values were in the lower glycemic band, means IADPSC criteria was satisfied, but the values were like 92 to 94, 1 are 180 to 191, 2 are 153 to 161. If this was the values, 50% of the women regressed to normoglycemia without any intervention. And in higher glycemic band, 20% of the women regressed to normoglycemia. So I reinforce regression. Regression is that when you have higher values in the early screening, you do nothing and do a repeat screening at 24 to 28 weeks, it is turning out to be normoglycemia. That is called regression. That is one phenomena which is newer in the last couple of years and which needs attention while managing such women. And now this is a evidence that if you treat women with a lower glycemic band, means the women who are prone to have a regression, if you treat, you are actually resulting more harm. So this study shows that there is a 75% more odds of having small for gestational age in women with a lower glycemic band. So this is a third phenotype which is early GDM but could regress in the subsequent time period. So what should be the management pathway of a low risk women? For example, if you have a lower glycemic band, fasting plasma glucose isolated, elevated, it is better not to treat aggressively. Just advise lifestyle modification. Have a less frequent follow-up, like every 4 weeks till 24 weeks, maybe with a fasting plasma glucose or 2 RPP. If the values progresses, then treat as a standard GDM. If it doesn't progresses, just manage with a lifestyle modification and then repeat 75 gram GTT at 24 to 28 weeks to ascertain the fresh status. So these are the phenotypes which need attention and less aggressive approach. The second path is keep a watch on gestational weight gain for such a women and fetal growth parameters. If you see that inadequate gestational weight gain and the fetal growth is not adequate, don't be aggressive. If you have been aggressive, just down escalate your management path. The second point that fetal growth which we use in the clinical practice, especially when we have ultrasounds at 24 to 28 weeks or 32 weeks, if the fetal centiles are going down and especially less than 25 centile, again we de-escalate the treatment. Especially if the woman is on metformin, we switch to insulin or decreases the dose of metformin because metformin can further decelerate the centiles. So the fetal ultrasound parameters can be used for the decision protocol for changing the treatment plan. Again, this should be the point that should be kept in the clinical practice, that metformin is associated with small for gestational age. If there is a low level of hyperglycemia, most likely these women will be on metformin therapy. And if they are wrongly treated, metformin will just increases the chances of for small for gestational age. So again, we need to be very careful. If it is a low glycemic band, we should not be aggressive. If patient is on metformin, we should follow with the gestational weight gain and fetal growth parameters. If they are adversely impacted, we should consider decreasing the dose of metformin or changing the plan to insulin therapy. The last case scenario is that when you do a testing, you have a normal GTT or normal fasting plasma glucose, but your A1C value is elevated. So what is the role of A1C in the first antenatal visit? This is a study from Chennai Dr. Mohan's group, which suggests that if A1C is more than 5.4%, it is likely that women will behave as late GDM. So the chances of developing GDM is more if early A1C is more than 5.4%. So if you see that A1C is more, institute lifestyle measures so that we can reduce the chances of subsequent GDM. And fasting plasma glucose can be done every 4 weeks before 24 weeks of GTT to just see whether the woman is developing GDM later on. So summarizing my talk so far. So basically from the original definition of normal or a gestational diabetes, the current understanding is that we are having multiple phenotypes of hyperglycemia in pregnancy. It is not two phenotypes. One is now overt diabetes, which is a high risk phenotypes, need to be treated with a pre-existing diabetes. Second is a genuine early gestational diabetes, where we need to institute early and proper management protocols to improve the outcomes. Third is a low risk phenotype, which may be genuine GDM or factitious GDM, which we called as a regressors. We need to be careful that we don't harm such women. Then the fourth phenotype is at risk phenotype, where A1C is more than 5.4%, but glucose values are normal. So these women need to be channeled into the preventive pathway to prevent late GDM, and then there is a subsequently standard late gestational diabetes. So these are the different phenotypes as per the current understanding, and we have to individualize care after understanding the patient so that we do provide maximum benefit without doing minimum harm. This is just a publication. In case someone is interested in understanding this concept in detail, can go through this our latest publication. Thank you so much.
Thank you, Dr. Yashdeep sir, for a very elaborate and nice presentation, and it will really help us in our day-to-day practice. I just wanted to know that many women who are in metformin for PCOS, then they become pregnant. So even if the glucose levels are normal during pregnancy, should we continue with metformin, or should we stop, ask the patient to stop?
The metformin as such is no indication from prevention. If it is from PCOS induction point, I think usually once the purpose is solved, it has to be stopped.
You have cleared so many doubts. We are doing early pregnancy blood sugars as advised by Foxy. We are using DIPSY criteria, but then throughout pregnancy, these patients have normal blood sugars, and we just label them in early pregnancy as GDM. And now today you have cleared the doubts, and this will really help us. I just want to know, you said a 10 milligram % fall in blood sugar. What was that? How, what gestational, per week or per trimester? What was it? If you can.
I'm not sure whether I have cleared the doubts or created more confusion.
No.
Usually the purpose is to create more confusion rather than clear doubts.
No.
So that people think that it is not straightforward case of early gestational diabetes. That is a... So basically the concept is that what happens in physiologically, fasting plasma glucose will go down by 10 milligram per deciliter, and postprandial will rise by 10 milligram per deciliter.
Means over how much period?
Over 20 weeks. 4 to 6 to 24 to 24 weeks. Over 20 weeks, it's usually a fall of 10 milligram per deciliter. So that mild values can become normal by time and need not to be treated as GDM.
Okay. And then we should not be putting these patients on MNT, no? Early pregnancy, FG.
That is a point. Basically, any women, when advised healthy lifestyle, there is no harm.
Okay.
The only thing is that if you're labeling a 95 milligram per deciliter just based on cutoff, and 70% chances that women will not have gestational diabetes. So labeling a women, giving them stigma that you are gestational diabetes, now you do intensive monitoring, you need to follow 1 to 2 weeks. Then there will be some glucometer error which shows a positive bias. Then you start metformin. These women, most likely 70% are normal. So psychological and physical trauma,
yes,
that is a purpose that we need to be avoid in this subset of women.
Yes. Thank you so much.
Thank you.
I would request the speaker and the chairpersons to go towards the facilitation area. For the next session, I would like to invite the chairpersons, Dr. Siddhant Sudhanshu sir, Dr. Prabhat Ranjan sir, and Dr. Arshad Ahmed sir.
Good morning, everyone. And the topic is short stretcher management. And short stretcher complaint is very frequent for the pediatrics endocrinologists. And every apprehensive parents sometimes in their life approach the endocrinologist how their child will become taller. Even I approached Dr. Ved 10 years ago for my daughters. And Dr. Ved do some investigations, especially the bone age assessment, and just assured me and my wife especially that she will become taller than you. And after 10 years, she is taller than her mother and pursuing MBBS. So when the diagnosis is clear-cut, if there is growth hormone deficiency, the treatment is available, but the treatment is effective and it's costly. And the treatment, when it becomes costly, is controversy arises, especially in the case of idiopathic short stretchers. So the stage is over to Dr. Manas Vinivat for the discussion.
Thank you, sir. Good morning, everyone. At the outset, I would like to thank the organizers for inviting me here today. I'll be presenting a very basic case-based approach to management of short stature. So we had an 11-year-old girl child who was born of a full-term breech delivery, had normal developmental milestones and a good academic records. She was apparently normal with no history of chronic illness and treatment except one, which was short stature. So the parents did not notice that she was faltering in her height till 6 years of age when her 4-year younger sister approached her height. They consulted a pediatrician who advised them to just wait and watch and gave some iron and calcium supplements. But the younger sister now started growing taller than her elder sibling, and hence the patient was referred to AIMS. On examination, her general physical examination was completely normal and there was no Turner stigmata present. So the question now arises, when does short becomes a clinical concern for us as clinicians? So any height for age and sex less than 3rd percentile or less than -2 standard deviation below the mean, height more than 2 standard deviation below the mid-parental height, height velocity crossing 2 major centiles downward in a growth curve, or a height velocity which is consistently less than 25th centile for age are the causes of concern for us as clinicians for evaluation of child further. So short stature is not always abnormal. This is something which we need to remember because the term itself does not give us any information about the cause and is not always abnormal. I'll explain later in my slide why do I say so. But what is abnormal is definitely the term which is called growth failure, which is failure of a child to achieve or maintain a growth velocity which is normal for his age and maturity. So broadly, the etiology of short stature can be divided into physiological, which includes 2 terminology. First is constitution delay in growth and puberty, the second one being familial short stature, and pathological, which includes first the primary growth failure, which includes skeletal dysplasias and dysmorphic syndrome, commonly known as Turner syndrome, and secondary growth failure, which includes systemic diseases, and then the endocrinological abnormalities like growth hormone deficiency, hypothyroidism, as well as Cushing's syndrome. So for clinicians, we have a 3-pillar approach to assessment of child with short stature. The first is a good history taking, physical examination, and most importantly is the science of measuring, plotting, and interpretation of the growth chart. So this table actually summarizes the key historical clues which we need to take and the differentials we need to think in our mind when they are present, such as the history of delayed puberty in parents can actually ring a bell that it could just be a case of constitutional delay in growth and puberty. History of short height in parents can indicate the possibility of familial short stature or primary skeletal dysplasias. low birth weight at the time of birth, less than 2.5 kg, can indicate the presence of small for gestational age with failure to catch up growth. Any history of breech delivery, neonatal hypoglycemia or prolonged jaundice, cryptorchidism or micropenis can suggest presence of growth hormone deficiency or multiple pituitary hormone deficiency. If there is a history of polyuria, it may actually suggest the presence of a renal tubular acidosis or even uncontrolled diabetes. And abdominal symptoms like diarrhea and constipation can suggest presence of underlying celiac disease, hypothyroidism or malabsorption. So what are the stigmata which we need to notice specifically in the case of short stature, which can tell us something about the potential etiology? Like presence of midline defects and micropenis can suggest growth hormone deficiency. Goiter, coarse skin, and delayed reflexes are indicators of hypothyroidism. Presence of central obesity, moon faces, and abdominal striae are indicator of Cushing's syndrome. Very importantly, never ever miss doing a detailed Tanner staging for both boys and girls, and we need to understand that we always need to evaluate a child in context of his or her biological maturity, which is indicated by the Tanner staging as well as bone age and not just chronological age. The third most important tool in our kit was anthropometry. So how do we exactly measure height? So the gold standard is measuring height using a Holton's wall-mounted stadiometer. And if we have the stadiometer in our clinics, we should remember that this should also be regularly calibrated. Otherwise, we can just do it by the routine method of making the child stand with the heel, buttock, and shoulder touching the wall. And the great toe should, both the great toes should be in contact with each other. And then we measure the distance between floor and mark the height in centimeter. So not only making the height measurement is important, we also need to analyze the upper segment and lower segment ratio for the child, as it helps us to differentiate whether the child is having a proportionate or a disproportionate short stature. So if the child is having a shorter trunk, it may indicate the presence of spondyloepiphyseal dysplasias, and shorter limbs indicate the presence of achondroplasia or also case of an untreated severe hypothyroidism. After doing the anthropometric measurement, it's very important to plot and interpret those in the growth charts. So now what we have are the WHO and IAP combined growth charts, which are available for both girls and boys, which are commonly used these days in our clinic. So we need to use growth charts every time we have a child with short stature presenting to us, and we need to be consistent about their use. What are the parameters which we plot in the growth chart is the height, MPH, target range. We always plot the height using a single dot, and the bone age, I'll tell about bone age later on. We use a closed small triangle and join the bone age with the height age using a dotted line. And never ever forget to calculate the height age and weight age using the growth chart. So how do we calculate the mid-parental height? It's a very simple formula. For boys, it's father's height plus mother's height plus 13 centimeter divided by 2. When we deduct 13 centimeter and divided the ratio by 2, it gives us MPH for girls. And why do we need MPH? Because MPH plus minus 8.5 centimeter, it represents the 3rd to 97th percentile range of an expected adult height. So this is just an example of a 14-year-old boy whose height is 125 centimeter. By calculating MPH, the MPH is 170 centimeter, right? So what do we see? That even though the child's height is less than 3rd centile, the MPH is around 50th centile. So this rules out the possibility of this etiology being just a familial short stature, and this child needs further investigation. We also need to calculate the height age. The height age is calculated by plot corresponding to the 50th centile of the child's chronological age. And similarly, the weight age is calculated. It's the age at which the child's actual weight corresponds to 50th centile. So what is the role of this? The height age is more affected in endocrinological disorders, while the weight age is more affected in systemic diseases. So this is just an example. So we have a 14-year-old child. I have plotted the height and weight of the child, actual height and weight. When I trace the height to the 50th centile, I get a height age of 10 years. For the weight age, I trace back to 50th centile, I get a weight age of just 8 years, which means the chronological age is greater than height age and weight age, and this indicates the possibility of a systemic cause, an underlying chronic systemic disease. So coming back to our case, we had this child with history of poor gain in height. Her younger sister is taller than her. We plotted her height on the growth chart. It was less than 3rd centile. The MPH though, however, was on 25th to 50th centile. And thus this indicates that the child needs further investigation. So what is a major aim of doing investigation in the case of short stature is just to identify the systemic illness causing short stature. That is very important. And who should be investigated? So any child who is less than 3rd centile and inappropriate for MPH should be investigated in detail. Whereas child who are less than 3rd centile but appropriate for MPH, all should be followed up for further their growth velocity. So we have tier investigation. The first line is to look for commoner causes, especially the systemic illness. It's must for all cases. The second line investigation is we work for the uncommon causes like growth hormone deficiency and further investigate if abnormal investigations are found in the first line investigation. And the third one is more related to cause, like getting an MRI brain done, karyotype done, or mutational studies. So these are the list of first-line investigation which we should never miss. A basic hemogram, you do a serum creatinine and calculate eGFR, very important. Serum electrolytes, calcium phosphate, alkaline phosphatase, a thyroid profile, or serum FSH for all girl childs, and serum TTGA levels for ruling out celiac disease. And also never ever miss to do 3 baseline X-rays, X-ray chest to rule out chronic infection, X-ray skull lateral view, to look for cellular widening, which can be a clue to an underlying craniopharyngioma, specifically in cases of young children, and X-ray left hand with wrist for bone age assessment. The X-ray hand will also can give us clue about the underlying presence of rickets if the patient is coming with chronic rickets or vitamin D deficiency. Now, bone age assessment is also very important. So we always need to know that for a healthy child, the height for bone age is a true representation of a child's height status rather than the height for chronological age. And more commonly, we use the Gruelich-Pyle method in our OPD as it's user-friendly and easy to use. And this is how we plot the height of the child, as I've already told, with the help of a dot. And the bone age is plotted with the help of a triangle. So the distance between bone age and chronological age, if it's higher, it shows a better prognosis in gaining height further on if the underlying etiology is treated properly. So this is a table which we all need to remember, and it is most important. If the bone age is equal to chronological age and it's greater than the height age and the growth velocity is normal, it suggests of underlying familial short stature or some genetic syndrome, which unfortunately are mostly not treatable. If chronological age is greater than bone age, which is equal to height age, and growth velocity is normal, it is suggestive of constitution delay in growth and puberty and presence of a mild systemic illness. If bone age is very much delayed than chronological age and even growth velocity is also abnormal, it should ring in a mind that it should be a case of an underlying endocrinopathy like hypothyroidism, growth hormone deficiency, severe acid-base disorders like renal tubular acidosis, and presence of a chronic systemic illness. So these are the list of second-line investigation which need to be done if we suspect the first-line investigations are abnormal, which includes, like for a case of celiac disease, if TTG is positive, we need to do a duodenal biopsy. And similarly, if we're suspecting a case of growth hormone deficiency, we can do growth hormone stimulation test to prove it further. So what are the common issues in investigation? We should remember some of these clinical pointers. That first, not all anemias are iron deficiency anemia. It's very important to evaluate the cause of anemia in a child. And if the child does not have GI symptoms or malabsorption, there's a common that we do not screen for celiac disease. This approach is abnormal. We need to screen all children for celiac disease. TTG positive only is not sufficient for diagnosis for celiac. It's very important to do duodenal biopsy also. And if a baseline TSH level is normal, this does not rule out the presence of hypothyroidism. This is because secondary hypothyroidism can have appropriately normal TSH. We always need to do a baseline T4 for all patients. The interpretation of these investigations is also important because 99% of time, the reports are given in an adult format with normal ranges of adult. And the most important fallacy is measuring creatinine in children. To calculate the eGFR, we use the modified Squartz formula for children rather than the classical MDRD formula which we use for adults. Even the blood pressure, the serum alkaline phosphatase and serum phosphate levels have to be interpreted with pediatric reference range rather than adult ranges. And investigations which are not to be advised in the first visit are the serum growth hormone levels, as they have no utility as growth hormone is pulsatile, serum IGF-1 levels and IGF binding protein 3 levels. Straight away doing an MRI brain the first visit is not advisable, and vitamin D and IPTH level are not worth if there is no radiological evidence of rickets. So suppose all reports come normal, what do we do next? We recheck the anthropometry and repeat a physical examination. And the best step now is to reassure the parents and watch for growth velocity. So any growth velocity more than 5 centimeter, we continue follow for the next 6 months. So any child growing at the growth velocity of more than 5 centimeter per year practically rules out any other cause of short stature. This is to be something which is to be remembered. Coming back to our case, for our patient, all the baseline investigations were normal. Bone age, however, was markedly delayed. And we made a case of severe short stature with suspected growth hormone deficiency. The next step is to investigate for growth hormone deficiency. So when do we suspect? When we have a delayed bone age. And before doing growth hormone stimulation tests, we need to ensure that we have ruled out any other chronic systemic illness. We ensure the patient is euthyroid and eucortisolemic at baseline. So I'll not go into details of these tests, but the most common and safer tests which we use are the glucagon stimulation test and the clonidine stimulation test. We collect samples at different time points, and if the stimulated growth hormone is less than 10 nanogram per ml, it is suggestive of a growth hormone deficiency. So our child underwent a growth hormone stimulation test and it was not stimulable. So we confirmed the diagnosis of growth hormone deficiency, and we also did an MRI which was suggestive of a hypoplastic anterior pituitary. So what do we do next is growth hormone therapy. It's available as subcutaneous injection, which is given at 8 to 10 p.m. That is the physiological time of secretion of growth hormone in normal body. So it is available in form of daily growth hormone, which we start at a dose of 0.16 to 0.24 milligram per kg per week. And once weekly injection of growth hormone is also now available in India. And we monitor the patient by improvement in height SDS, which should be at least 0.5 in the first year of therapy, and improvement of growth velocity, which is around 10 centimeter in first year and more than 6 centimeter for second year onwards. And this is the follow-up and frequency of follow-up which we do. The first visit after starting growth hormone is done at first month, where we see the presence of side effects, and we also see the status of thyroid because it causes worsening or manifestation of secondary hypothyroidism when we start growth hormone therapy. Subsequently, 3 monthly visit, we check the anthropometry, again ask for side effects, get a baseline serum IGF-1 levels. In annual visit, we again have to repeat whole of the complete workup, with including serum IGF-1 level and the metabolic profile. So how long we continue growth hormone therapy? We need to stop once the child has reached the final height. And the best approach is when the growth velocity is less than 2 centimeter per year if measured over 12 months, or bone age is greater than 16 years in boys and 14 years in girls. So our patient was treated with growth hormone for 5 years, and you can see the moving up of the centiles of height, and at the age of 13 years, she was visibly taller than her younger sibling. Coming on to case 2, we have a 14-year-old male whose height was in 3rd centile, and height during a school trip 1 year ago was around 139 centimeter. So the growth velocity is around 5 centimeter over 1 year. He was pre-pubertal when he presented to us, but the father gave a history of a late spurt in height and achieved final height at the age of 19 years. So we plotted the height, which is corresponding to 11 years. The weight age was around 11 years. Height velocity, as we've already seen, was 5 centimeter per year. So clearly, chronological age was greater than height age and weight age. What do we do next? We do a bone age. and bone age was 12 years. So chronological age greater than bone age rules out familial short stature, as it is equal in familial short stature, and considering the strong family history, we made the diagnosis of constitutional delay in growth and puberty. So it's a normal physiological variation where the child is short for age, but height age is appropriate. The cause is a delayed maturation of the growth hormone pulse. It's more common in boys, and the final height is normal, so the treatment is not required in most of the cases. It's a diagnosis of exclusion, and what is the marker which indicates towards CDGP is the younger sibling is never taller than the index case. Another physiological cause of short stature is familial short stature. Very simple concept. Parents are short and hence the MPH is less. The child grows normally with growth velocity which is normal for his age. The endocrine profile and complete workup is normal. The bone age is equal to chronological age and the final height corresponds to MPH. In this case also, no need to do any further treatment or unnecessary investigation. Case 3, we had an 8-year-old child with poor history of poor weight gain and stunting. Her height centile and weight centile was less than 3rd centile. She had protuberant abdomen but no diarrhea. So the height age was delayed, which is 4.5 years, and weight age was significant delayed, just 2 years. We did a bone age, which is 5 years, and we can clearly see that chronological age is greater than bone age, which is greater than height age and weight age, suggestive of an underlying chronic systemic disease. We did a venous bicarbonate level to rule out renal tubular acidosis was normal, and chest X-ray was also normal. But a baseline IgA TTG level was very high. So this is a case of celiac disease further proven on biopsy. And it is very interesting to know once you start gluten-free diet in these children, they remarkably gain their height and weight very beautifully. So take-home points from my presentation are what to remember. The first one is a sibling rule. So if a younger sibling approaches or overtakes the height of an older child, that is something which is a red flag. So never compare the height of your children with their peers. Compare the height with the sibling, younger sibling if it is feasible. Second is growth velocity is the king. Always measure growth velocity. We not need to worry so much if the height, growth velocity is more than 5 centimeter per year. Third is celiac disease is silent. 10% can only present with short stature with no GI manifestation. It's very important to screen them at the baseline. Fourth is always use pediatric specific references for interpretation of labs, and early referral to endocrinologist is very important. And what to do is correct anthropometry. Institutes of around 50% of your work is done when you have a child of short stature. Clinical examination, including Tanner staging, is very important. The first line investigation, as I have told, is very easy to carry out, but the interpretation, we need to be very cautious. Always follow growth velocity if in doubt, and if suspicious, do a growth hormone stimulation test. Thank you.
Yeah, thank you, Dr. Maneshwini, for an excellent talk. Very lucid, very informative. I have just one quick question. Like for some cases of short stature, like in SGA or ISS, idiopathic short stature, or maybe in Turner's or in achondroplasia, we need to go for a higher GS dosing, yes, like towards the north of 50 microgram per kg per day. So in such cases, do you recommend using IGF-1 monitoring in some way, or it's like any experience you have regarding this?
So we have been treating in our pediatric clinic patients with idiopathic short stature who have a height less than -2.25 standard deviation, not expected to gain to their MPH, and even Turner syndrome, as you said, sir. So the baseline starting dose is conventionally higher, which is 0.35 milligram per kg per week, which is higher than the normal which we give for the patient with just growth hormone deficiency. That is because there is a presence of IGF-1 like resistance, GH resistance, which is present in the periphery. So in these patients as well, we monitor the patient with IGF-1 level, which we try to keep in like between -1 to -2 to +2 centile, yes, like normative centiles. That is what is recommended. That is what we do, and keep monitoring for side effects.
Yeah, like I am a pediatric endocrinologist, so I have used, whenever I have used, I have done a few times, but I have never seen it's going beyond +2 STS.
Yes, so correct. So it's difficult to treat them.
Yes.
The response is lesser as compared to growth hormone deficiency.
Yes. And any experience of using growth hormone therapy in patients with chronic renal failure?
No, sir, we have not been using. So usually we have not got any child with chronic renal failure referred to us for growth hormone. We have no experience. We have not given for that.
Okay. Thank you.
Any question or comment?
So for that we have to get a corrected length. It's like you have to take a point like ASIS. You can take pubic symphysis to the vertex like this, and then the corrected length. Like if there's a deformity of limb, so you can take it from pubic symphysis to the upper tip of the patella, and then patella to medial malleolus. Like length of the limb has to be taken rather than the appropriate height. Sitting position, you have, so sir, what I can say, you have to take a length, not in sitting position. It's difficult to take a sitting position because he's having a limb deformity. So you have to measure like from the ASIS, you can do the upper part of your patella. From patella to medial malleolus is limb length. And then you can see from the tip of your the vertex till pubic symphysis, the upper segment length. So that in that case, you have to do a length by length rather than taking a sitting height.
Dr. Bhatt, sometimes the patient of familial short stature parents insist to give some medicines.
Yes, sir.
And he cannot afford the recombinant growth hormones. So in that case, is testosterone injection, especially in boys, or aromatase inhibitor can be given?
So familial short stature, sir?
Yeah.
Familial short stature method, we do not give any treatment. We just do reassurance, give calcium and iron supplement, but ask the patient, the parents to monitor the growth velocity. For CDGP, if the child is also delayed in puberty, in that case we start low dose. Suppose a male is coming at 16 years with failure to gain height, but more than 14 years a child warrants a treatment for puberty itself. So we start with low dose testosterone. Aromatase inhibitor we are not using in our clinic routinely.
I would just like to add, if in a FSS, family short teacher, if one of the parents is very pathologically short, then we need to check it could be some hidden case of skeletal dysplasia or some mild AD variety of GHD, so that we can just rule out.
That
and
we
then
can see in history and physical examination
if it's
itself.
not
Otherwise,
there,
we'll
then
just monitor growth velocity.
Yes. Okay. Thank you, Dr. Manaswini Bhatt, for a very nice talk. Thank you very much.
I will request the speaker and the chairpersons to go towards the felicitation area. Now for the next session, I would like to invite the chairpersons, Dr. Anshuman Kumar sir, Dr. Kranti Bhavna ma'am, and Dr. M. Hayat sir to the stage.
Good morning, everyone. We are here to talk about management of thyroid nodules. Thyroid nodules are amongst the most common endocrine manifestations in our day-to-day presentation, day-to-day clinical practice. The prevalence is increasing in this era of high precision, high resolution imaging. Now, most of the nodules are benign, but these do give rise to significant amount of anxiety in our clinicians and our patients. There are many unanswered questions, the key being who needs evaluation, who needs intervention, and how should we avoid unnecessary procedures without missing out malignancy. I think this session will strike a balance between vigilance and intervention. I would like to hand over the mic to Dr. T. Shenoy, sir. He needs no introduction, he is quite famous. Sir, jokes apart, sir, the floor is all yours.
Thank you very much. Thank you, dear S.K. Singh, sir, and thank you, the organizers, for giving this opportunity to me. I have been using AI in a view. I have also done some publications regarding how we can place AI for thyroid nodule estimation also, which in my center I am trying to implement. So that's some slides which I will include in this. So first my thing is that this is the best opportunity because the first Bihar National State Conference, so I wish them best of luck for the future endeavors. So I really appreciate your endeavor to have this at a very good location. So thank you for having me. So learning objectives of today's lecture, we understand the epidemiology of thyroid nodules. We review diagnostic workup. As I told you, we should know ultrasound risk stratification systems, applying the existing diagnostic criteria, and as evidence goes, experience also growing, so we need to follow algorithms as well. So what is thyroid nodule? Thyroid nodule is a distinct lesion within the thyroid which is different from the radiologically from the surrounding thyroid parenchyma. So it can be a solid or fluid filled lump within the thyroid gland. It can be solitary, it can be multiple, otherwise it can be functional or non-functional. That means structural, functional, anatomical, everything has to be kept into consideration. This is the ATA definition of thyroid nodule. Classification, it is benign and malignant. If person asks you, Doctor Sahab, मेरे गर्दन में एक thyroid है, so we can say everybody has thyroid. Thyroid nodule है, तो differentiate between them. That is the benign and malignant. So it can be a colloid nodule, it can be a cyst, it can be part of thyroiditis, it can be pseudonodules of thyroiditis. And second side, it is malignance or not. So malignancy are definitely most common type is papillary carcinoma thyroid. Luckily, it is actually manageable many times by surgery alone. So you need not go for any other therapy, just surgery alone can be curative. But other ones which are not having great prognosis are the follicular, medullary and anaplastic carcinoma. So just a case presentation, a 32-year-old lady presenting with a thyroid nodule. Initially, thyroid was found incidentally. It's called incidentaloma. मतलब दूसरे जगह से आया था, just for seeing the nodule, they found they have a thyroid nodule. So the patient is requested to have a thyroid ultrasound, found to have a 2 centimeter nodule in the right lobe of thyroid gland. As you know, ultrasound emits non-ionizing radiation, sound waves, and you can pick up nodules quite early. So the very early stage you can pick up by ultrasound. So I think, what will you order first? I think majority will you agree that we have to be sensible. You should order thyroid function test before you comment on the type of daughter. What do you know whether it is harming the patient or not? But some people do all of the above, because some people tell, "Sab kuch kar lo, मैं बाद में देखूंगा." So it's not the way to do. It's showing you that holistically and pragmatically you should go by systematically. And if you are finding structural issue, go for higher investigation. If TSH is low, go for iodine scan. That is what I will tell in the future. So basically, thyroid functions are important to understand how they are active or not, whether they are functioning normally or not. Local symptoms have to be excluded, because you should know hoarseness of voice. I have a noise issue, small because I had a bad travel issue. So my hoarseness of voice is also one of the known typing happening. Difficulty to swallow, dysphagia, and foreign body sensation. Some people may tell they have a difficulty in the neck area. Something is happening in the neck. I am not understanding that. So there may be one clue for that as well. Malignancy, maybe you should understand by using the existing technology available. So genetically, understand that age below 20 years and age above 70 years are predisposed for having risk factors. And malignancy of thyroid in the family, including the MEN2 syndromes, have an important threshold. Environmental deficiency, as Zargar sir is also here from Kashmir, so many experiments have been done from Kangra Valley. We know that we have reduced incidence of goiter, but we have some people have thyroiditis because iodized salt has been used exponentially and more than what is required. That is a controversial area. But generally, it is protective in nature. Iodized salt is good, but you should understand iodine deficiency rates are not now seen, because majority of us are using iodized salt only. Understand that historically, iodine deficiency is known to be a major factor in the thyroid pathogenesis. Exposure to radiation. I come from an area where we have some industrial areas. We have got seaside area. There is a place called Karunagapalli in near Trivandrum or near Kollam, where so many people have got thyroid nodule because so many factories historically had titanium or some other chemicals. Ionizing radiations are also known to be in that area. Now, after vigilance and so many years of study by RCC, in our Trivandrum we have got RCC, we have found that we are able to arrest the incidents by addressing the factories to dump their waste correctly. So now we are able to address that better. That is important, the public health in the practice. Hormonal changes. One of the next speakers will tell about the thyroid and pregnancy. I will not touch upon that. So palpable nodules are 4 to 7%. Ultrasound can detect 20 to 70%. Higher prevalence in women, elderly, iodine deficiency, summarizing the slide. 5 to 15% have a risk of malignancy. So not every nodule can have a risk of malignancy. So this is a very important point to be noted. So demographic, this is the data published in the American Journal from way back in 1960s to as recently 2010 also. So this is the data showing that we can diagnose early the yield is better also. But what will you do? Will you diagnose early? You should follow them up. So what is the goal of assessment of nodule? You should understand the risk factors. You should do screening protocol. If it is required, go for surgery. Don't go for surgery in the every thyroid nodule. So radiation exposure, I have told you, rapid growth, hoarseness of voice, cervical lymphadenopathy. So presence of another area nodule, not reactive lymph nodes, pathological nodules can be a risk factor. As I had told you, MEN 2 syndrome and family history of cancer is a very important thing to be assessed as well. Physical size, more than 4 centimeter in size, hard in consistency, fixed nodule, vocal cord palsy, these are the major things of physical things. And the speed of malignancy progression, that is regional and distant. These are all early. This is published from 2012 publication. So detailed history I have told you, compressive symptoms, increased risk, these are all to be taken into consideration. Next, come to palpation. You should ideally palpate in front of the patient and also from behind, and ensure that you are doing it in the proper technique also, and don't keep on palpating. I think if you are students palpating, palpation itself can cause thyroiditis. So I have seen so many students palpate, मुझे पता नहीं चल रहा है तो बाद में कर लो, I'll tell. Don't do again and again. So that is known to happen, but theoretically you should definitely palpate it in the appropriate manner and understand if fixation is not out, not. And lymph nodes have to be also checked. So you should understand differential diagnosis of thyroid mass also, anterior neck masses. Majority are benign lesions. Some are congenital. Some people don't know how long it were. They include some tonsil, they have some issues also. Thyroglossal cyst that moves with the tongue movement. That's also one thing to be noted. Inflammatory causes and other causes are also known to happen. This is where you should know about the lymph nodes of the neck. So many lymph nodes are there. So we should know which area lymph nodes are draining which side. This is for planning for a long term. We should know what type of nodules you are finding. The submental and the jugulodigastric can be even physiological, but other things can have an association. Thyroid area, we have got the pre and paralaryngeal lymph nodes. So summarizing my first half, that is understand that neck fullness and thyroid nodule are different. If you are finding a distinct area, just palpable and nodule has been pathologically understood, then you should go for the higher investigations also. Respiratory symptoms and voice changes are also known to happen, and swallowing difficulties can be one of the presenting symptoms. Odynophagia or choking sensations can also be occurring. So how to examine further? That is the hands behind the neck, head and head neck section. This is called a Pisello method. And you can even find the trail sign. Trachea is deviated towards the which side? That is the opposite side most likely. And palpation always behind the patient is confirmatory to characterize the nodule swelling. Look for retrosternal extension, cervical lymph nodes and shift of the trachea. Front of the patient, very commonly we do it, but it is done only in reserved cases to look for tracheal shift. It's called Lahey method. And complete it by doing the Pemberton sign, because it's very important to know. I recently had a patient coming with, not this patient, this is just a historical fit photo. We call it the cork effect. So the thoracic inlet syndrome, superior metatarsal, they have the issue. It is classically seen in retrosternal. 30 seconds itself, head raising, you can find the issue. So now coming to the next stuff, how to evaluate further by using radiology. Highest percentage has found to be helping with the ultrasound neck. Now elastography and AI techniques have found higher yield with ultrasound itself. So that gives you a better edge over the palpation, and you can see CT and MRI, and sometimes so institutions do FDG PET. Some FDG avid nodules can also be found as incident loma also. Then go for the thorough examination and positive finding. So just finding out the next case, it's a 40-year-old female, reports of husky voice, something foreign body sensation, and found to have a thyroid nodule. So it's incidental finding again. Size is 1.5 centimeter and dominant nodule. There are two nodules, but dominant one is the right side nodule. So now we can find that more and more yield is there by examination. So now definitionally, incident lomas are defined as non-palpable nodes less than 1 centimeter. So this is not incident loma, it is 1.5 centimeter, noted during surgery or imaging for other purposes. So they are less chance of cancer, but they can find on follow-up, you can find earlier incidents. Exceptional, sometimes FDGs can have a more chance of malignancy. That's why you should find the primary source also. Dilemma exists whether you should do symptomatic, anxiety. There is a lot of protocol issues. Some people don't follow the protocol. That is why endocrinologists should be the team leader in that. We should find out that we are managing thyroid more. We should be involved in the decision making also. So laboratory test, basically TSH is the primary test to be screened. If you are finding low TSH, you go for scintigraphy. If it is not so low, go for the ultrasound scan, go for the FNAC if required. I will tell you indications as well. Again, calcitonin is again controversy if you are finding a family incidence of MN syndrome and hypercalcemic issue. Ganapati sir will talk about approach to acute hypercalcemia. Even there you can find calcitonin can be one of the tests which can be utilized. Anti-TPO antibodies, it is done very commonly now, but you should only recommend in some people suspicious of the thyroid disease like Hashimoto disease. Don't keep on doing it every 6 monthly or yearly. It's only one time only. That is now having long-term issues also. Thyroglobulin is one of the important tests to discriminate the benign from malignancy, usually done as stimulated values, that is stopping thyroxine for 1 month, post-thyroxine thyroidectomy or ablation also. Scintigraphy, just for showing this is important. It's available mostly. It is usually done as iodine scan or as done by a nuclear technetium thyroid scan. It is done to assess the functional status of thyroid nodule. If you have thyroid toxicosis, it can be done quite early and doing. It can pick up cold nodule, hot nodule, toxic nodule and warm nodule. So you can find variations of nodule. Percentage of thyroid tissue uptake is also important. Importance of finding cold nodule is that you can do FNAC from that cold nodule. It is photopenic area. That is important to adjust the importance of treatment also. Hot nodules are less likely to be malignant, but still you should go for follow-up. Ultrasound is recognized as a gold standard investigation. We can find the composition, echogenicity, margins, calcification, shape, and the blood supply of lymph nodes. So just to show you how we are using our technology also, the composition, our software finds, so we have got Siemens 1, which gives you 15 mmH. So we are finding more yield with it. By radiology doing consistently, we find that composition, echogenicity, margins, calcification, shape are picked up. Is our own patient subset. We have found early incidence of nodule pickup, and we had found colloid cyst because machine learning is also coming up, because machine learns more and more, and we also learn through that also. Then radiologists help by which nodule can go for an early FNAC and which can be followed up for 6 months to 1 year. Suspicious nodule, you find rim calcification and hypoechogenic and taller than wider. That is also one thing. But follicular nodule, usually it will be well defined, solid and predominantly solid, and definitely has to be done FNAC if required. So again, suspicious ones I have summarized here for you. Hypoechoic, irregular margins, microcalcification, taller than wider shape, and extrathyroid extension also. When you find TSH low, don't go for anything else than ultrasound. You go for the nuclear scan, then go for ultrasound. So now patient comes with this report of follicular cell. The same patient comes with follicular cell. They are not coming with follicular adenoma or follicular carcinoma. We are again stuck. We are not given category 3, category C we can say. So we are not sure what is happening. So whether we can go for surgery, again we should know for the next step. That is why multidisciplinary approach is required. We have tumor board in our area. I work in a periphery medical college. We have got tumor board. Whenever doubt at that, we discuss with the team. So not every case, we pool the cases in 1 week or 2 weeks and then discuss the case. This case we did a discussion and we did a holistic approach. So we found that majority can be benign also. 3 months, 6 months follow-up, we can see whether we can go for complications. So FNAC is the most commonly done. When I worked in Amrita, we used to do FNAC ourselves only because we are trained in doing FNAC. I urge you, if you are not trained, please try to go for some sort of training. You can just, there is no age immune to training also. And endocrinologists out there, if you are interested, please, because ITS does workshops on training doctors, endocrinologists on training, but it is not licensed to be done. It's only for your own understanding. FNAC can be done and sent to pathology. So pathologists coming and doing it and radiologists doing it may be difficult. Sometimes you can also help them. So Seshadri sir is interested in this, so we are able to help you out. So this is how we do it. 23 to 26 gauge needle. It is done without image training for palpable nodule and ultrasound guidance. Otherwise, reporting criteria is very much fixed. So we can find sensitivity, accuracy also. So this is the flow chart we usually do when long standing is there, when there is malignancy features are there. Then we are finding other symptoms of respiratory, you go for an early surgery. Otherwise, most often ultrasound radiology can be done repeatedly. Stratification systems, ATA, ACR TIRADS, Corrigan and EU TIRADS. We usually for the ACR TIRADS classification. TIRADS 1 is benign, TIRADS 2 also not suspicious. TIRADS 1 can actually have sample not sufficient also. So try to repeat if it is not coming sufficient. Then go for the surgery if it is mildly or moderately or highly suspicious. And if it is size more than 2.5 centimeter in TIRADS 3, definitely you can go for an early ultrasound based biopsy, or you go for a, so there is studies from Sujoy Ghosh sir from IPGMR doing liquid biopsy also, where they are doing some techniques to find out tissue based techniques also. This is how we can diagnose. Neeraj 5 more than 1 centimeter definitely has a risk. They should go for early ultrasound based techniques. This is the summary of what I have told you. Risk factors, nodule size, ultrasound images can go for a FNAC. So when I ask FNAC, I usually tell this analogy, go for a fruit basket. Fruit basket, there are so many fruits. We never know which is the unripe or the cancerous fruit. I will finish first. This is how we can do by ultrasound. At least we can find out which is going for this thing. Then you can risk stratification and go for the next. I will finish in 2 minutes time. So finally you can find that when you have a category 6 Bethesda, you can have a high risk of malignancy, whereas category 3 only 30%. Category 2 is the safest of the lot, 0 to 3%, whereas category 1, though is 5 to 10, can have a chance of progressing to the category 3 or 4 early itself. Molecular testing, again done in selective centers. We do it in our centers in Amrita and some place in CMC Vellore are there. So there is FRMA test sequence and thyro sequence which you're doing for category 3 only, BRAF, RAS and RED PTC. Special populations are required to be special interest. These are the pregnancy, pediatric, elderly and men syndromes. This is a summary of the ultrasound features and going for the progression. This is how we can use our own way of approach to find out the lesions. Last section, surgery, definitely indicated when you have got a follow-up required. Majority in hyperfunctioning cold nodules is not there. You can go for an antithyroid drug, radioiodine therapy if required, and only selectively when you are not finding remission, go for a early thing. Otherwise, majority surgical not required, only follow-up required. Independent nodules, we can go for diagnostic lobectomy or molecular testing. This is a case publication from Indoor, which was done, published by the team there. They found that long-term patients can find out yield by doing follow-ups only. And newer tests like galectin-3, HMBN, they are all described. They are overlap between the follicular and differentiated thyroid carcinoma. Newer technical elastography is also coming up because even liver fibrosis are found out. Similarly, elastography can help in your own ways also. Last, on follow-up, this is how you can do thyroglobulin if required for follow-up, we can do it, but definitely not indicated in everybody. Cervical ultrasound is very easily done, and if required, get the follow-up done. Red flags, recent increase in the size, new lymph nodes and development of dysphagia. These are 3 readily recognizable red flag signs for the malignancy for progression. This is the 88 given you the. I'll conclude my slide. Thank you very much for the kind listening.
So that was quite wonderful, wonderful images, wonderful oratory. You kept it short and simple and made it visually appealing to our audience. Now, if we have any questions, we would like to take them. Anyone? Sir, I have a question of my own. Sir, if a Bethesda patient, when you are going for Bethesda classification and it comes out to be indeterminate, sir, after how much time duration do you repeat FNAC? Is there a window?
Correct. So same area, if you have a nodule done, usually I don't repeat it till at least 3 months. 3 months is what usually done, but individual variations do exist. There are some people, I think we work in a place where majority of people work in the Gulf also. Some people come for the evaluation only for the nodule showing Bethesda 3 from Gulf. So in that case, I think I asked the radiologist, are you comfortable in doing the ultrasound the same area and finding out? Second opinion we can take and get it done. That is one way. So that will help you in getting the thing. Second thing I have not put in the slide is called microwave ablation or radiofrequency ablation. It is coming up in a great way. Korean guidelines are there regarding thyroid nodule. RFA and microwave ablation are not our forte. But if radiologist is commenting, the patient is having increasing size, not malignant, they have to reduce the size somehow, then you can go for a evidence-based approach. Because ATA 2026 has come with recently some approval for the microwave ablation selective cases also.
I think this concludes our session, sir. Thank you.
Thank you very much.
I will request the speaker and the chairpersons to proceed for felicitation. For the next session, I would like to invite the chairpersons, Dr. Prakash sir and Dr. Govind sir to the stage.
So, first of all, I would like to welcome Dr. Deep Datta to Patna. He is a very good friend of mine. We have studied together, given DM entry exams together. So, welcome Dr. Deep. And he is a well-known speaker to the different parts of the country. He is a very good orator, very good academician, and he has many papers in the national and international journals. And he will discuss today a very specific topic. So over to Dr. Deep, please.
Thank you so much, Dr. Redwas. Big thanks to the entire organizing committee and as well as Dr. S.K. Singh sir. It's a big honor to be in Patna. I was born in the city of Bokaro, which was a part of this state at that point of time. So good to be back to my roots. So I have been given the difficult job to speak on T3. Now in hypothyroidism, we are dealing with T4, diagnosis and therapeutic. But today in the next 20 minutes, we'll be discussing about T3 as an assay and T3 as a therapeutic agent. Is it really making a difference? So let's come to the assay part of T3. We have the free thyroid hormone or the free T3 or the total T3. Now in the age of whole body checkup packages, patients come to us with 20-page reports, and invariably they are doing now most time free thyroid profile, and you get to see the free T3. And very often you will see a highlighted value which is high, borderline high. So it's a big challenge. We must realize free T3 is a very low level hormone. Picograms per ml 10 raised to the power minus 12. The current assays, chemiluminescence which you are using is not reliable to measure such low levels of hormone. Some labs, to save money, they are using ELISA, which is even more erroneous. If you have to measure free T3, you have to do an equilibrium dialysis or a LC-MS-MS, which is not commercially available with most of the labs. So I think the take-home message, don't order free T3. There is no role of free T3 test in our clinical practice. So, and if you see an abnormal value, ignore it. Next, coming to total T3, that is in nanogram per deciliter, a slightly more reliable assay, only slightly more reliable. Still the most commercial assays are pretty much unreliable. So don't order total T3 also, it will open a Pandora box. Patient पूछेंगे डॉक्टर साहब करना क्या है, फिर हम इधर उधर देखेंगे क्या करना है, हमें भी नहीं पता. So total T3 भी नहीं करना है. In hyperthyroidism, we use T4 and TSH. In 95% of your Graves' disease, you can manage with T4 and TSH in your follow-up also, forget diagnosis. In your 5% of patients where you may see that T4 is normal, TSH is very low, patient is having thyrotoxic features, you may order a total T3 to rule out T3 toxicosis, which is very rare. So T3 total का भी कोई ज़्यादा role है नहीं हमारे काम में. They are creating labomas, patients are coming to us, we tell them go home happily ever after. Not to be interfered, look at the TSH for hypothyroid and T4 and TSH for hyperthyroid. Next, coming to liothyronine or T3 therapeutic agent. So I did a PubMed search और देखा कि T3 liothyronine का तो publications काफ़ी है somewhere in the paper. But if you look at the titles having liothyronine, the publications बड़ी है पिछले 15-20 साल में. So last 15-20 years the publications have increased. So I did a PubMed search to see क्या थे ये articles और क्या छाप रहे थे इन लोग. So very recent article JCM में छपी है last month में, which showed that this is a retrospective data, American database, हर patient का data उन्होंने study करके देखा. पहले तो उन्होंने ये बताया कि hypothyroid patients में dementia होने का chance थोड़ा ज़्यादा है. Now these are hospital record based data. They are highly biased data. These are not population based data. You can pick up a lot of things from here, but you have to confirm it in real practice. You cannot make clinical guidelines based on hospital retrospective database. उन्होंने कहा कि hypothyroid patients में dementia थोड़ी ज़्यादा होती है और in US they commonly use animal extracts like bovine extracts and even porcine extract, which has a mixture of T3 and T4 of variable amount, but they are used. People believe that it is more organic way of using thyroxine. It is not recommended, but people are using. So they found that in this cohort of 1.26 million patients, those who were receiving a T3, T4 combination therapy, they had slightly lower occurrence of dementia. Totally नई बात आई है, पहले कभी सुना भी नहीं था, पढ़ा भी नहीं था. This should be an area of exploration. JCM में छपी just पिछले महीने. अब आते बड़ी इंटरेस्टिंग पेपर, ये छपी है क्लिनिकल एंडोक्रिनोलॉजी, वेरी रिप्यूटेड जर्नल इंग्लैंड में. नाउ वन इज अमेरिकन वे ऑफ ट्रीटमेंट, टोटली एग्रेसिव, सब कुछ कर डालो एक बार में. अदर इज द ब्रिटिश वे ऑफ ट्रीटमेंट, सरकार खर्चा करती है तो दे ऑलवेज डू कॉस्ट इफेक्टिव कॉस्ट बेनिफिट एनालिसिस. So here they found that in NHS, the cost of treating hypothyroidism in entire UK and Wales was around 60 million pounds 10 साल पहले. और 10 साल में उन्होंने देखा कि cost of treating hypothyroidism in NHS went up to 130 million pounds. भैया ऐसा क्या हो गया कि 10 साल में डबल खर्चा हो गया सरकार की हाइपोथायरॉयड ट्रीट करने में. तो they did an audit and they found that in 10 years from 2010 around 5 to 2015 the prescription of T3 went up, liothyronine went up extensively, कि 1 in 3 GPs were prescribing liothyronine for managing hypothyroid. And it's a very costly medicine at the end of the day. And they found that there was no visible improvement in patients' control of both biochemical and clinical hypothyroidism. तो उन्होंने कैंपेन चलाई कि इसको यूज़ ना करो, and they were able to bring down the cost of therapy to around 88 million pounds in the last 5 years or so. So NHS believes that there is no use of T3 on routine use of T3 supplementation in managing hypothyroidism. अब देखते हैं सिस्टमैटिक रिव्यूज़ क्या कहती है. इतने क्लिनिकल ट्रायल छपते, हर ट्रायल पढ़ना मुश्किल है. तो दिस इज़ अ वेरी इंटरेस्टिंग सिस्टमैटिक रिव्यू अगेन पब्लिश्ड इन JCEM. इन्होंने देखा कि क्या एडवर्स इफेक्ट क्या है T3 थेरेपी के. नाउ वी नो T3 इज़ द पोटेंट ड्रग, इट इज़ द बायोएक्टिव फॉर्म ऑफ मेडिसिन. तो इसकी लो थेरेप्यूटिक इंडेक्स होती है. सो इफ़ यू गिव इट मोर, देयर इज रिस्क ऑफ एट्रियल फिब्रिलेशन, देयर इज अ रिस्क ऑफ ऑस्टियोपोरोसिस, देयर इज अ रिस्क ऑफ कार्डियक इवेंट्स. So they reviewed all the published data from 21 RCTs, some case control studies also, case series, and they found that largely whatever data is available, they could not find any significant increase of osteoporosis or atrial fibrillation. So some safety data we are having from this systematic review and meta-analysis. तो सवाल ये उठता है कि हम T3 के बारे में बात ही क्यों कर रहे. थायरॉक्सिन तो यूज़ कर रहे, पेशेंट कंट्रोल तो कर रहे हाइपोथायरॉयड. बात इसलिए कर रहे कि 10 to 15% पेशेंट्स फिर से हमारे पास आ जाते हैं. डॉक्टर साहब वो कमजोरी नहीं गई, थकावट हो रही है, नींद आ रही है, मेंटल मेमोरी लॉस हो रहा है, बदन में दर्द है, तो क्या करें. एंड वी सी पेशेंट केम टू अस विद क्लियर हाइपोथायरॉयड, वी गेव थायरॉक्सिन, TSH नाउ नॉर्मल, बट जिस सिम्टम के लिए आया था वो कंट्रोल नहीं हुई है. सो व्हाट वी आर डूइंग करेंटली, वी लुक फॉर विटामिन डी डेफिशिएंसी, विटामिन डी दे देते. अगर डिप्रेशन के सिम्टम लगे थोड़ा सा SSRI दे दिया हमने, कुछ लोगों को EVON दे दिया. So we are trying to find other causes because the symptoms of hypothyroid overlap with symptoms of dysthymia, depression, fibromyalgia and so on. And most of the times we are not able to satisfy the patient. So we published a paper from a cohort of patient in Delhi, but with Dr. Deepak Khandelwal, and we saw that overt hypothyroid, TSH more than 40, T4 low, इनमें तो अच्छी खासी symptom होती है. We know the typical symptoms of hypothyroid. When we made them euthyroid over the next 6 months, we again also found that nearly 5 to 8% patients continue to have those residual symptoms, which were again we were not sure what are we missing or not. So इस पे आई कि can we do something for this patient, and that gave rise to the school of T3. Maybe these patients are not converting their T4 to T3 efficiently in their body. We know it's the nuclear hormone. The hormone has to act on the nuclear receptors inside the cell. But what we are measuring is actually the circulating levels of the hormone. We cannot measure tissue hypothyroidism or tissue levels of hormone. That's the challenge with our practice. So now we know that we have the deiodinase enzyme 1, 2 and 3, which convert T4 to T3 inside the cell. And it has been suggested that a small cohort of these people, maybe a large number of these 10 to 15% patient may have polymorphisms of this deiodinase, कि उनमें efficiently convert नहीं हो रही है T4 to T3. So logically we should confirm this and then we should treat. But problem है, to confirm this we should do a thyroid profile using equilibrium dialysis, not chemiluminescence, which we are seeing. That is not reliable to pick up, not ELISA. And there if you see a normal TSH, low T3 and high T4 in mass spectrometry, जो कि नहीं है, then we may consider treating it. But वो facility, वो technology अभी है नहीं routine practice में. जब आएगी तब देखे जाएंगे. Other way is that you do a genetic testing of polymorphisms of deiodinases, जो कि इंडिया में अवेलेबल नहीं है, and if you pick up certain mutations in them, you are considering giving definitive role of T3. Otherwise, there is no definitive role. What we need to do in our practice is if you are having uncontrolled hypothyroidism, check the compliance, कैसे thyroxine ले रहा है, empty stomach रह रहा है कि नहीं, आधे घंटे से 1 घंटे, missing of tablets, we should be taken care of. Don't take your thyroxine replacement with calcium, iron or PPI and other multivitamins. Biotin is a notorious supplement. Everybody is taking biotin for hair loss. Now streptavidin is the enzyme which is used in chemiluminescence assay to measure hormones. People on biotin supplement, आपको टेढ़ा मेढ़ा report आने वाला है, TSH, T4, T3 सब कुछ. So always take a history. If you cannot explain the patient symptom with thyroid profile, take a history of biotin use. Stop biotin, recheck thyroid profile after 2 to 3 weeks. That is very important in our practice. Another systematic review which now looked at combination of T4 and T3 therapy versus only T4 therapy on thyroid symptomatology, quality of life, and they found, lot of papers they analyzed, and they found it doesn't make any difference in terms of all the symptoms. चाहे आपने combination therapy दी, चाहे T4 दी, कोई फर्क नहीं पड़ा. So again, we do not have any hard endpoint of using. This was one particular polymorphism which is well known, threonine 92 alanine polymorphism of the deadenous gene. अगर ये आपने पकड़ लिया तो दे दो T3, नहीं तो आज के दिन में कोई hard evidence नहीं है T3 therapy का. You may do it off-label, you may do it in those 5 to 10% symptomatic patients, counseling the patient very well. अगर 3 महीने में कोई symptomatic improvement आई, you may continue or better stop it. Now these are the different types of T3 preparations available in USA and Europe. हमारे यहाँ एक ही preparation मिलती है. Start low, go slow, give very low doses. अब कैसे दे इसको? We typically give in the ratio of 1:15 or 1:10 or 1:20. With 20 parts of thyroxine, T4 will be 1 part of T3 therapy. डिटेल में उसके आने के पहले ये देख लेते हैं कि एक और सिस्टमैटिक रिव्यू विच यूज द डेसिकेटेड एनिमल एक्सट्रैक्ट, जो कि ऑर्गेनिक वे ऑफ रिप्लेसिंग थायरॉक्सिन, जो बहुत प्रचलित है यूएस में, थैंकफुली हमारे यहाँ नहीं है. दीज प्रिपरेशंस आर नोन टू कॉज लॉट ऑफ एलर्जिक रिएक्शंस ऑल्सो because they contain many other proteins which we don't even know, they are not purified also. And this systematic review again found there is no benefit of using organic or desiccated animal extracts of thyroxine which contains both T3 and T4 in managing hypothyroidism. Another review which recently again showed that there is no harm or benefit. So there is no hard point of using this form of therapy for managing hypothyroidism in routine practice. So even the thyroid, the European Thyroid Association 88, they issued a consensus statement. उनका भी कुछ यही कहना था कि patient really परेशान है, dissatisfied है, आपके पास बार बार आ रहा है, तब आप you can try it short term as a experimental therapy, no role of routine use. अब आते करना ही है तो कैसे करें? So these are the different permutation and combinations. Since there is no perfect therapy, you can try different permutations and combinations. The dosing, try to keep as less of T3 component, as more of T4 component. If the patient tolerates, you can build it up gradually. एक खास बात है T3 की, it is absorption is not affected by food. चाहे खाने के पहले दो, खाने के बाद दो, फर्क नहीं पड़ता. Unlike T4, we have to be very particular. It has a very short half-life, so ideally should be given twice a day. Unlike T4, we are giving empty stomach first thing in the morning. So this is the typical way we, this is one formula you can use. अगर patient 100 microgram thyroxine पे है, तो उसको rule of 20 से divide करे 5 आता है. You can add 5 micrograms of T3 and you have to reduce the dose of T4 also compensatory. So typically we reduce by 12.5 or 25 micrograms. So we can go to an 88 microgram preparation of T4 and start with 5 microgram of T3, see the response and then you can further up titrate the dose अगर कुछ फर्क लग रहा है आपको. There is no role of T3 monotherapy. जितना भी थोड़ा बहुत स्टडी हुआ है with T4 and T3 combination therapy. Monotherapy तो करना ही नहीं है. There is no evidence. It's a very short half-life molecule, lot of fluctuations. इसका interpretation भी बड़ा मुश्किल होगा in lab assays. There are some case reports to show that you may use in mixed edema coma, but it's a very rare condition, difficult condition, life-threatening condition. But we know even in this rare sick patient, you put a Ryle's tube, give a hydrocortisone injection, give 5 to 6 tablets of 100 microgram thyroxine through Ryle's tube, crush it. It works very well in managing mixed edema coma. So unless you do some original studies, generate data, we still don't have guidelines even in using mixed edema coma also. So in certain patients awaiting emergency surgeries, cardiac surgeries, or there is some case reports, so they have used T3 in combination with T4 to prepare the patient for the surgery. Again, case series and case reports only, no definitive long-term studies for perioperative management of hypothyroidism. Role of T3 is very sketchy and unreliable. So I think these are the few red flags we should keep in mind. Not approved for use in pregnancy and lactation. Never used in people with established cardiac disease or cardiac arrhythmias. Not to be used in people with established osteoporosis. And don't use in sick euthyroid syndrome. That's a totally different area. It's a good practice. अगर करना ही है तो एक baseline ECG करके देख लो कि PR interval, QRS complex, tachycardiac arrhythmia तो कुछ नहीं है. If you really want to use a T3 based therapy in your practice, knowing well that yes, this is a drug with low therapeutic index. There are even reports of occurring of thyroid storm with unmonitored supraphysiological use of T3 therapy in clinical practice. I'd like to end by sharing one of our papers कि अब हम T4 पे आ जाते हैं. If you have poorly controlled elderly patient on chronic hypothyroidism, thyroxine ले रहा है, भूल जाते हैं, you can still consider giving once weekly thyroxine. We know it has a half-life of 7 days. So weekly therapy of thyroxine can help in these patients who have difficulty in remembering tablets. You will have a good control of hypothyroid, but the problem remains in the first 2 to 3 days. You will have a supraphysiological spike of T4. Patient may complain of tachycardia, palpitations. Again, underlying cardiac disease है, better not to give weekly thyroxine therapy in people with underlying cardiac disease. So the take-home message: there is no role of T3 or free T3 assay in clinical practice routinely. In rare, if you are considering T3 toxicosis, तभी check करें total T3, never free T3. There is no definitive role of even using liothyronine for routine management of primary hypothyroid. That rare patient 10% who has persistent symptoms of hypothyroid, you have given SSRIs, vitamin E, vitamin D, calcium, patient coming back to you. In that, you can try it at an extremely low dose for short period of time. Thank you so much.
Thank you, sir, for your nice and informative presentation. And you have rightly said there is no role of routine use of TT3 or FT3 level, and most of us are routinely recommend pre-T3 level along with pre-T4 and TSS. So thank you. And any question from the audience side?
Yeah, that's a very emphatic lecture with very important points emphasized. First, one comment: I have used T3 in one patient of central hypothyroidism as a part of panhypopituitarism following craniopharyngioma irradiation. The patient was having VPC. Seeing the VPC, even I had given, because the T3 was persistently coming to be low and the T4 was going high on replacement, and you cannot monitor by TSH. That's just an anecdotal case. I took the risk and the patient is doing well. And regarding a question, what's your take on the relationship between symptomatology in a patient of primary hypothyroidism who is duly replaced on levothyroxine and GDP, that is gross domestic product?
Oh, that's a very great question. With greater affluence, I think जब रोटी कपड़ा मकान हो गया तो दिमाग किस पे खुराफाती करे? I think functional symptoms are going up in our society, especially if you are living in Delhi and urban areas, so much of stress. The functional symptoms, psychiatric issues are unfortunately going up with the increasing prevalence of obesity. We know obesity leads to insulin resistance, leptin resistance. Leptin suppresses TSH level. With obesity, there is leptin resistance, TSH will go up. So if person has got rapid weight gain in past 3 to 6 months of 5 to 10 kilos, thyroid whole body checkup कराया, TSH आ गया 6, भाग के गए डॉक्टर साहब अपनी thyroid ठीक कर दो. He is not bothered about weight gain, he is not bothered about acanthosis, skin tags, he is bothered TSH 6. So we have to, and then they come to us, and if you give them thyroxine, it was not hypothyroid. If you give thyroxine, the symptoms will not improve in those patients. They'll again come back to us. So we tell them, please lose body weight, your TSH will come down, and many of these functional symptoms may already disappear. We need not treat them.
We have such a study across 15 countries in Europe. I think you can replicate one in India in different states with different GDP and different strata and see the symptoms.
Oh, so, any question? Yes. Dr. Neeraj, please.
Sir, I have also used T3 in patient of central hypothyroidism, and they have also responded positively. But one group of patients where I feel when the dosage of LT4 goes above 200, 250, is there a place for this T3 therapy?
Well, that's a great question. So yes, we come across this problematic patients of needing more than 200 or more than 2 microgram per kg body weight of thyroxine. Thankfully, most of them have poor compliance issues. We can do a levothyroxine challenge test. We have an Indian protocol also published recently from Calcutta. Almost all patients will pass the levothyroxine challenge test with flying colors. But still, if you have ruled out malabsorption, also celiac cases, you may consider, you need to generate and publish data, sir. You can consider on experimental basis.
So, after giving LT3 in some patients, there is symptomatic improvement initially, but later on patient again starts complaining of the same symptoms. So, what is your own take?
Again, a very difficult question to answer. We started with 5 microgram, make it maybe 5 microgram BD slowly, see if we can up titrate to maybe 10 microgram BD till the patient tolerates, see the symptoms improve. So the right answer is, I don't know. Sir, you are in an academic institute, please generate some data. We are looking forward to it.
So with this, any question? No. So with this, we will conclude here. So please go to the checkers point.
Thank you, sir. It's an honor, sir. Yes,
sir. Sorry for the interruption. After Priyanka,
thank you, sir. Thank you. Thank you.
Before Priyanka takes charge, it's my pleasure to felicitate our dear Arya sir. Sir, he has come as a surprise to us and we'll be felicitating him. Sir.
सर को देना है अरे आपका है अरे नहीं आइए सर आइए फोटो
यहीं पे कर लो
थैंक यू थैंक यू सर थैंक यू really good. Good morning, sir. Camera আছে Thank you, sir. All good, sir. हाँ जी बताओ Yes. हाँ सर
अरे यहाँ किसी को अनिल चला जाओ
आ जाओ साइड आ हाँ जी सर हाँ नहीं कोई स्टडी नहीं होता है हवा की बातें हवा वाली बातें
Thank you all. Priyanka, you can come.
Thank you, sir. Now moving on to our next session, I would like to invite the chairpersons, Dr. U.S. Rai sir, Dr. Abha Sinha ma'am and Dr. Poonam Nal ma'am to the stage.
Good morning, and I welcome you all on this session of the thyroid dysfunction in the pregnancy. The speaker is Dr. S.K. Singh. He is well-known personality in the endocrinology. He has been chairperson of many society. He is ex-director of Institute of Medical Sciences, Varanasi. He has been Dean and Head of Department of Endocrinology. Over and above, he is my good friend, and we have studied and stayed together for 12 years in the IMS BSU. I welcome Dr. S.K. Singh for this lecture.
Thank you, Dr. U.S. Rai, Chair. First of all, I acknowledge my gratitude to Dr. Santosh, Dr. Ved, Organizing Committee, for first meeting of Bendocon here in Patna. There are many memories when I'm standing here that U.S. Rai had been my room partner. We did DM together. He did in nephrology, I did in endocrinology. And both we had a common mentor, Professor H.S. Bajpayee, who was the head of the Department of Endocrinology. Santosh has given me a big topic. I have superannuated. My photograph is when I was in service. So you can see. And then he has given me a topic to discuss to you. I expected more women because the topic is of interest for women, but one chairperson is enough. The topic is management of thyroid disorder during pregnancy, and in this I would cover up the pregnancy effect on thyroid, what are thyroid diseases in pregnancy, the management of one of the most common disorder in pregnancy, that is hypothyroidism, management of autoimmune thyroid disease, management of thyrotoxicosis through case study, and uncommon conditions, and then take home. This is the cartoon showing the effect of pregnancy on thyroid due to increased HCG, that is human chorionic gonadotropin. There is an increased level of T4 as it acts on thyroid, and therefore there is a decreased level of TSH. And also there is a increase in the type 3 deiodinase, which converts T4 into reverse T3 or metabolizes T3 into T2. That is the reason in pregnancy T3 may not be very useful, because it will be converted into T2. There is increased level of estrogen that results into high TBG, that is thyroxine binding globulin. Increased thyroxine binding globulin will increase the demand for total T4 and T3 by the thyroid, and there will be increase in the level. There is an increased iodine clearance, and also there is an increase in the hormone synthesis. Iodine is a substrate for hormone synthesis. So there will be increase in the requirement of iodine. Dietary supplementation has to be increased. And if somebody has compromised iodine intake, there will be a problem. Thyroid gland may get enlarged. The thyroid function test is also affected, and we should remember this, that the lower reference limit of TSH is reduced by 0.4 milli-international unit, whereas the TSH upper limit is reduced by 0.5. So the reference range for non-pregnant will not be the same for pregnant. It will be 0.4 and 0.5 less than the actual reference range, and that should be remembered. T4, T3 both gradually increases as TBG increases. So the total T4 and T3 is usually increased by 50%. So you are likely to get a report of thyroid hormone in pregnancy. The T4 is almost 50% raised. So if the upper limit of T4 is 12, sometimes you may encounter up to 18. And that is most of the time is wrongly interpreted by the gynecologist. The T4 is increased and reference is sent to us, that it is high level of T4 and this is a major concern. But in fact, it is total T4 that has increased because of increased TBG. So the thyroid disorders which are seen most common is hypothyroidism, which is around 2 to 2.5%. This is the fact sheet of these disorders. Anti-TPO is 10%. Postpartum thyroiditis being very common, but it is not picked up. However, it is accompanied by hypothyroidism and therefore comes to medical attention. Graves, 40% of graves, they may occur during pregnancy, and it is mainly because Graves occurs in reproductive age in women, and there is a chance that you will have more number of patients with Graves in pregnancy. Gestational hyperthyroidism is another entity that should also be remembered, and it almost mimics the picture of thyrotoxicosis in pregnancy. Solitary thyroid nodule and thyroid malignancy not very common, that may also be a coincidence. Hypothyroid in pregnancy may lead to difficulty in conceiving because of the menstrual irregularity, and majority are on T4, and there may be a problem in titration of the doses. So overall incidence is high, and it may be linked with the high fetal loss or abortion, stillbirth, premature or post-maturity. In the newborn, it may lead to hypomentation or cretinism if it occurs in antenatal life. The most common etiology is primary thyroid failure, and that is a cause of hypothyroidism. Autoimmune thyroiditis leading to hypothyroidism is another cause. Sometimes now we don't see iodine deficiency because of fortification of iodine in salt. Those who are on lithium for other indications, and patients with Sheehan syndrome, those who have developed Sheehan syndrome and get pregnancy subsequently may also manifest with hypothyroidism. This is the simple flow chart. I think this is very easy to practice, that we measure the TSH pre-pregnancy and also during pregnancy, and reflexly if the TSH is slightly high, we also measure anti-TPO antibody, and we can categorize if TSH is less than 2.5 up to less than up to 1.1. This is perhaps it is less than 2.5 to less than 0.1. This is thyrotoxicosis. TSH between 0.1 to 2.5, it is normal, and TSH between 2.5 to 10, you can subcategorize into anti-TPO positive and anti-TPO negative. If it is anti-TPO negative, again you have to look for the level of TSH. TSH 2.5 to upper limit of reference range, you don't require treatment because that is normal. TSH between upper limit of reference range to 10, consider treatment with thyroxine because they are having subclinical hypothyroidism. Those who have anti-TPO positivity, again TSH between 2.5 to upper limit of the reference range, that is normal reference range, consider treatment because we want to keep the TSH less than 2.5. TSH between upper limit of reference range, which is usually 4 up to 10, treat with thyroxine in pregnancy. So there is a clear indication of treatment with thyroxine with the TSH level between 4 to 10. Also, if it is anti-TPO positive, level between 2.5 to 4 needs treatment, and if it is anti-TPO negative, we can wait. We may not treat at this stage. So hypothyroidism in pregnancy, the TSH should be kept less than 2.5 and don't require treatment if it is there. TSH between 2.5 to 4, anti-TPO negative, no treatment, but anti-TPO positive is better to treat because there is an increased chance, and there are reports in literature that it may be associated with some adverse outcome. TSH more than 4 up to upper limit of reference range, even it is normal, treat to keep TSH less than 2.5. So that is clear for subclinical hypothyroidism or hypothyroidism in pregnancy. Usually the diagnosis is based on the TSH, but T4 also helps. As I said, TSH in most of them will be in the reference range or even sometimes above the upper limit of reference range because of increased TBG level. Usual dose is to 50 to 25 to 50% more in pregnancy. So there is a need to escalate, and this escalation is needed up to 20th weeks of pregnancy. Then after, you don't require increase in the dose of thyroxine because the physiological changes are such that it is not needed. Serial monitoring more frequent, 3 to 4 weeks monitoring is required. Otherwise, we usually go for 6 to 8 weeks monitoring but here in this case 3 to 4 weeks monitoring with TSH and sometimes T4. Anti-TPO positive with euthyroidism, that has also been a concern, because the observation had been that there is a 30% increased chance of pregnancy loss. So anti-TPO positivity was taken as one of the serious thyroid disorder responsible for fetal loss in pregnancy, and most of the obstetrician had this concern. Hypothyroidism can occur, and therefore monitoring is required. 4 to 5% is a chance of conversion into hypothyroid. So those who are anti-TPO positive with euthyroidism, the risk of hypothyroidism is more, and therefore they should be monitored. This is one of the data from the VACAM study, and they also have increased risk of postpartum thyroiditis. So anti-TPO positive with euthyroidism, the only concern that they should not develop hypothyroidism. This is very interesting study published in NEGM 2019, tablet control, current control trial. In this, the anti-TPO positive women who had frequent pregnancy loss were put on thyroxine even though the TSH level was normal. So TSH between 2.5 less and 2.5 above, they subcategorized into 2, but it was less than 4, and then the therapy was instituted. What they found, that you can see the medial line here, that medial line is not favoring therapy. It should go beyond the unity line 1, but it is just touching the 1. So it means that the treatment for any outcome with anti-TPO positivity with thyroxine was not beneficial. So there is no need of treating those who have anti-TPO positive and the TSH was in the reference range. Another study, this is also very interesting, T4 life trial that was published in Lancet. Anti-TPO positive women 18 to 42 years, 2 or more pregnancy loss, means they had a risk of pregnancy loss. They were included in this study and treated with thyroxine. They were randomized, those who received thyroxine and those who didn't. And the outcome was that even with the treatment, there was not much difference in the outcome. So the treatment of anti-TPO positive women, even though they had increased fetal loss, may not be beneficial with thyroxine, though some other therapy has been advocated for them, that selenium may be useful or some other methods, but I don't have any, I have not seen any study that supports that we can do something for those who have anti-TPO positivity and also have increased pregnancy loss. The reason could be something else than the thyroid disorder. This is a case, 32-year female, 14 weeks of pregnancy with Primi 1 and Gravida 2, was referred to endocrinology for thyroid hormone profile. She has BMI of 24 and the vitals normal, systemic evaluation normal. The lab test was T3 was 135, which was in the reference range, but FT4 was done in this case, because some obstetricians know that free total T4 is raised, so that may not give the correct picture and better to go for FT4. However, there is a caveat in measuring the FT4 in pregnancy, because the level is falsely lowered in pregnancy of FT4. So we should not rely on that. And FT3, as Datta has already said, that measuring T3, FT3 is just filtering the ocean. Ultrasound showed a thyroid nodule 10 into 15, that is more than 1 centimeter. It was tier 2, but PSV was close to high perfusion of the nodule. Nodule was vascular. So what could be the reason? The TSH is suppressed 0.05, FT4 that is free T4 was high, and there is a solitary nodule. So this could be hyperfunctioning thyroid nodule. Is that correct? So we should know what are the conditions where we get the TSH suppressed. Overall incidence of suppressed TSH is 5 to 18%. And I said that HCG is increased and that leads to suppression of TSH. So one may encounter up to 20% of patient may have suppressed TSH and that may raise concern that there is some thyroid disorder, but in fact it is physiological. 1.3% of pregnancy have gone even lower, that is 1.5, well, less than 0.1 milli international unit, and the causes could be a Graves' disease which has gone into partial remission, could be SCG mediated gestational thyrotoxicosis, usually associated with hyperemesis gravidarum, or could be a thyroiditis, and many occasions it could be a nodular toxic nodule producing too much of thyroid hormone. Graves' disease, as I said, that's not uncommon. 40% of overall series of Graves patients may have pregnancy sometimes, and therefore it is not very uncommon. TSH is less than 0.01 usually, not even less than 0.1, but less than 0.01, and thyrotropin receptor antibody positivity is usually seen in them. The Graves patient should be monitored bi-weekly so that you titrate the dose, because there is a risk of development of hypothyroidism which will be detrimental to fetus. If you undertreat, there is a risk of fetal thyrotoxicosis, though that can be monitored by the fetal heart rate. And FT4 can be checked 4 weekly, but as I said that you should keep this fact in mind that FT4 is falsely lowered in pregnancy. The overall goal of treatment is to maintain FT4, though there is a limitation of FT4 in Graves patients to normal. Usually medical therapy, and first trimester we choose propylthiouracil, and then after methimazole or carbamazole. Block replacement therapy is not a choice. Many believe that block replacement, that you give antithyroid as well as you give thyroxine, but that is not useful, that is not recommended also. Radioiodine, of course, out of question. Surgery can be done in second trimester, but that is rarely needed. Gestational thyrotoxicosis, which is almost mimicking the presentation of Graves' disease, may occur in 1 to 3%, usually up to 20 weeks, and they do not have goiter or orbitopathy, which is common with Graves, and it is mainly due to high level of SCG. So you order a test of SCG, level more than 60,000 or even lakhs supports the diagnosis of gestational thyrotoxicosis, which doesn't require any treatment, just reassurance to the patient, and it takes care of on its own. So, points of differentiation between Graves and GTT. Graves, usually there is a history of thyroid autoimmunity, family history of thyroid disease, or overt hyperthyroid features before pregnancy, associated ophthalmopathy, and thyrotropin receptor antibody positive. Anti-TPO is also positive, that is an evidence of autoimmune thyroid disease, but in gestational thyrotoxicosis there is no past history of similar problem, no goiter, no ophthalmopathy, usually TRAB is negative. So, if you have any doubt to differentiate between the two, TRAB will be very helpful to differentiate whether it is a Graves or it is gestational thyrotoxicosis. Measurement of TRAB will be very helpful. Patients with active hyperthyroidism or previously treated with radioiodine, or patients with high TRAB levels, you have to go for serial fetal stress monitoring in such cases. So, TRAB is indicated only in these 3 conditions during pregnancy. Toxic adenoma and toxic multinodular goiter are also seen in pregnancy, and the case which I showed to you actually is showing features of toxic adenoma, and ultrasound shows increased vascularity. But TRAB may be required, it will be negative, and antithyroid drug is usually avoided in toxic adenoma because there is a risk of hypothyroidism and fetal hypothyroidism. Subacute thyroiditis, which is recurrence or viral in etiology, and there will be preceding history of viral episodes, and markedly raised ESR may help in finding the diagnosis of subacute thyroiditis. Coming back to the case, SCG was ordered to see whether it is toxic adenoma or it is a case of GTT. The SCG was 60,000, which supported diagnosis of gestational thyrotoxicosis, and patient didn't require treatment. usually after 20 weeks it comes to normal. So the clinical pearl is suppressed TSH physiological in pregnancy 1 to 3%, GTT is 2.5%, autoimmune thyroid disease is common but effect on pregnancy outcome has been variable. Thyroxine treatment has no effect on anti-TPO positive euthyroidism. Postpartum thyroiditis is closely followed up for development of hypothyroidism. Raised TSH is stratified for treatment selection. Graves in 0.5% and medical treatment is the choice for Graves with pregnancy. TRAB testing is warranted for clinical features of Graves in pregnancy and when you have a doubt to differentiate with the thyrotoxicosis. Fetal monitoring is frequently required. Autonomous functioning thyroid nodule or multinodal goiter or subacute thyroiditis not very common because usually seen after middle age and not in that age, but you may encounter, so that should be borne in mind. Thank you very much for your kind attention.
Hello. Thank you, sir, for your lucid presentation. You don't worry, I am only one gynecologist or obstetrician here, but I can benefit, many women can be benefited by me because I am an obstetrician. So I would like to thank organizing committee for giving me this opportunity to chair your session. You have told about the guideline of hypothyroidism in pregnancy. If it is between 2.5 to 4, we have to do anti-TPO. If it is positive, then we have to treat. There is a dilemma among us. If we are not able to do anti-TPO in everybody because we have poor patient, then whether we should treat or not. Because Indian guideline says it should be less than 2.5. Although American says you do anti-TPO. So if we are not able to do anti-TPO, can we treat 2.5 to 4? And in which dose we should start thyroxine?
Yeah, very good question. In fact, I also support that we should treat even though it is anti-TPO negative, and the guidelines also you must have seen that consider treating these patients even though it is
so we are not
doing
routinely. Patient who can afford, we are doing, we are voluminous patient.
It's not needed, but it's better to treat because ultimately we have to keep the TSH less than 2.5.
At what dose we should start? Suppose only 4 or 3.8, so what dose should be started?
To achieve the level of less than 2.5, you need to give as you treat hypothyroid patients.
No.
It is not that you give only
according to body weight
microgram or 25 microgram. Usually, as I said, that the dose has to be increased by 25 to 50%.
No, if she is taking before, then we can increase by 25%.
Yeah,
but first time she has come in pregnancy.
Yeah, keeping that in mind, that dose has to be increased. So once you are starting treatment de novo for the hypothyroidism, you have to consider this in mind, that dose usually is 25 to 50% higher. Therefore, it's better to start with 50 microgram.
50, okay. Thank you, sir. Thank you.
Sir. Life study says that supplementation of T4 is not. So, which prospect we should carry forward? This is quite contradictory.
It's not contradictory because treating with T4 in anti-TPO positive conditions is not going to change the natural history of autoimmune thyroid disease. The positivity, anti-TPO positivity doesn't reflect the damage of the thyroid gland. So there's no point in treating. The only thing that if there is anti-TPO positivity, it means that there is some kind of thyroid destruction ongoing, and maybe in future person can develop hypothyroidism. But once the patient develops hypothyroidism or T4 gets lowered, then only you need to treat. Otherwise, no point in treating if it is euthyroidism, because this will not affect the natural history of autoimmune thyroid disease. And same should also be practiced in pregnancy. But by giving this, you are not going to reduce the anti-TPO positivity by any means. So autoimmune thyroid disease is an occurrence which is not going to be influenced by treatment with thyroxine at any stage. However, those who will develop hypothyroidism which is roughly around 5% per year. So almost after 10 years, anti-TPO positive may have hypothyroidism. In them, the T4 therapy may be useful, but not in pregnancy. So no point in giving thyroxine in pregnancy.
Sir, we are entering into the phase of IVF. So in IVF clinics, many hormonal treatment and sometimes ovarian stimulation treatments are also given. So patient is being referred. So now the bed is prepared and we are going to implant and everything and do the IVF procedure. Now the TSS has fluctuated. Then in this condition, we know that estrogen and other hormones affect the level of the TSS. So how should we proceed?
Yes, in IVF there could be a challenge of maintaining the TSH to normal because they are giving very high doses of HCG, HMG, and also they are influencing the overall estrogen physiology. So there is a possibility of fluctuation in the overall total T4, T3, and TSH may also be affected. TSH is very variably affected these days because people are given so much of supplements and that might interfere, and laboratory findings haywire is not very uncommon. So if you have a suspicion, you can start therapy because it's such an innocent drug. Even slight over treatment will also not be that harmful. So it's better to treat if TSH is high, and we have already have a clue that the TSH between 2.5 to 4 will also be requiring treatment with thyroxine. So no point in withholding treatment for such cases. However, the obstetrician have two kinds of thought. One is that they do get elevated TSH level more than the reference range, but at same time sometimes they believe that empirical use of thyroxine in these subsets of patients may also give benefit. So they are using, I would not say unnecessarily, but it is empirically or maybe their experience based use of thyroxine in some of their patients. They are giving, even for improving the oocyte outcome they are treating, and also they are treating the male partner with the hope that that will improve the semen quality. So these things I think is on empirical basis with more of experience.
Even in non-pregnant women, if patient is presenting with amenorrhea, TSH is 6 or 7, physician will say we will not start, if T4 is normal, we will not start thyroxine. But in our books, if it is subclinical hypothyroidism, you must treat. If patient is presenting with menstrual irregularities, so we are treating. Even it's 6, we are treating.
Yes, subclinical hypothyroidism, when to treat, I think there are many debates on these. What are the group of patients who would really be benefited by treating if they are in subclinical hypothyroid state? We are very clear about this, that the children, infertility, those who have a nodule, thyroid nodule, they may be benefited. Even early CKD patients may also be benefited by subclinical treatment of subclinical hypothyroidism. Cardiac patients, dyslipidemia, these are the subsets of patients who can be benefited. But we do not have very hard data level of evidence A for treating such patients. And knowing that there's so much of variation in the TSH level from the various laboratories due to vitamin and biotin interference, you should wait. If there is no urgency of treatment, please hold the treatment for at least 3 months and see what happens to the level of TSH. I always convince my patients that if you have a disease will go ahead, it will not come back. So if you have disease, next reading will be high. If you don't have disease, it may stay here, or if it is spontaneously cured, why to start therapy? So better to withhold for at least 3 months and see if it doesn't improve, you are very likely to start therapy, and that might be useful in them.
Thank you, sir. Thank you so much.
I would request the speaker and the chairpersons to proceed for the felicitation. Now for the next session, I would like to invite the chairpersons, Dr. Santosh Kumar Singh sir and Dr. Shyam Kishore sir to the stage.
Very good afternoon from Shyam and myself. It's my pleasure to invite Dr. Arpanda over the dais to deliver his talk on PCOS across life stages. And I can assure you, you will definitely like the talk and it will be a memorable one. Arpanda, please. Only thing I would like to share about the first part, MBBS North Bengal Medical College. I was a year junior to Arpanda, so we have a long association since then. Arpanda, please.
Thank you. Is it working? Thank you. Good afternoon. I certainly feel privileged that very first edition of your Bendocon, we are here. Thanks for your enthusiasm. I remember when I have done DM that time, my number was 83 in the country. And now this number has nearly gone to 3,000. So all our senior people are there, more than me. Okay. So this is what I am going to talk around 20 minutes. PCOS across life stages. We'll come back from the thyroid to the ovaries now. And a little bit of a so-called non-orthodox way I would like to present, just a bit of a disclaimer that I don't have a share in the pharma industry, and this is my understanding of the topic. Sincere thanks to my DNB residents, and certainly I take the responsibility of the text of the talk. I'll come little bit of a cases first, and then I will go through about the life stages of that. So let's see some cases now. This is the first one. Quickly I'll read it. 9-year-old girl, 1 year symptom with a facial hair, spotting 3 months, accelerated growth, getting ahead in the school, along with the friends. A girl of 20, irregular cycle since menarche, which was at 12 years. Insidious onset, increase in facial hair and the body hair. And the lady of 32 had a bad experience of IUD at 30 weeks. Primary hypothyroid, planning for pregnancy, complaint of irregular cycle, there is some increased facial hair. Why the cursor is not moving now? Okay, my cursor is not moving, doesn't matter. Irregular cycle and increased weight. No, the cursor is not moving. Okay, doesn't matter. And the lady, who is 63, rapid onset facial and the chest hair, lost around 10 months. Diabetes and blood pressure was controlled okay, but recently finding it difficult. Also gained weight of 5 kg in last 3 years. No, now the slides are not going. Okay. So the first girl, 9-year-old girl, Tanner stage 3, pubic hair, no clitoromegaly, height more, bone age advanced, breast B3, rest examination unremarkable. The girl of 20, normotency, BMI 24, hirsutism, facial hair, genitalia, no clitoral enlargement, systemic examination normal. The lady has abdominal striae, moon faces, fat, you know the diagnosis now. Increased growth hair, system examination is normal. And the elderly lady, hirsutism, androgenic alopecia, sinus rhythm, BP is little high, HbA1c has worsened from 7.4 to 8.7, and the rest of the normal examination is normal. But interesting is that, to my talk, is that ultrasound of this girl reported to have enlarged ovary with cysts. In the girl of 20, same. The lady of 32, both ovaries shows polycystic appearance, ovarian volume 10 and 11, and ultrasound here showed atrophic uterus, multiple cysts to both ovaries. So is this PCOD or this one or third one or the fourth one? And people of my age, not the new golmal, this is the old Rishikesh Mukherjee golmal, you remember, sab kuch golmal lag raha hai. Actually, whatever we see most of the time is not that. So the left side is the correct one, the right picture is not the correct one. And actually they are not cysts. Even if we see this, they are a bit accumulated follicles and various stages, little bit of a theory from follicular arrest to stromal hypertrichosis to anovulation. And here comes the diagnostic criteria. 2 of the 3, this is the first one that we always follow, Rotterdam criteria 2003, oligoanovulation, hyperandrogenism, and polycystic ovary morphology. And this definition was 12 follicles. Most importantly, we need to exclude other androgen producing conditions. So basically, this is a diagnosis of exclusion. That's what I wanted to tell you in my cases. And if you see the different phenotype will be there, and that's why it's called 2 out of 3. So some people will have all of 3, that is phenotype A. But phenotype B, ultrasound is completely normal. So we are diagnosing a polycystic ovary syndrome with a normal ultrasound. And as you see, C and D. So practically both of them, 2 of the 3 should be present. And the old criteria, this was the follicle, and now current criteria is more than 25 follicles, and preferably it has to be a transvaginal ultrasound, which is definitely difficult in our place, particularly young unmarried girl. So PCOS is the most common endocrine disorder of reproductive age in women. Prevalence 5 to 10%. And the new criteria also exclude PCOM, ultrasound, or raised AMH. And important thing to remember that hyperandrogenism, any other cause, has to be excluded. So that's the 2-hit hypothesis, how it happens. So I'll not go through in details. So in our first case, the basal LH was high. I'm not telling you the values because it will make it a bit complicated. Estrogen was high, 17 OHP normal, ruling out the congenital adrenal hyperplasia. Thyroid function was normal, bone age accelerated, electrolytes normal, karyotypes 46XX. The girl of 20, that's what the LHFS you see. Testosterone was high, DHEA was high, 17 OHP was high. When you stimulated with the synactin, it was very high. The lady of 32, basal cortisol is high, overnight not suppressed, low dose not suppressed, ACTH disproportionately high, free testosterone high, HbA1c 5.8, and the lady of 62, the DHEA sulfate was normal, but androstenedione was high. Inhibin elevated, CA125 was normal, so diagnosis of the girl, central precocious puberty. Second one, as you know, late onset CAH. Third one, Cushing. And the fourth one is androgen secreting ovarian tumor. And this is what the diagnostic algorithm will tell. We will start in the top left, history, physical examination, irregular cycle, clinical hyperandrogenism, exclude other cause, diagnosis confirmed. If negative, then biochemical test, and that's how we will proceed. And very, very mandatory exclusion of the diagnosis, the TSH, prolactin, 17 OHP, and FSH-LH. And this hopefully should be clear for us. So next, that's what main topic of PCOS across the life stages. So if it's a young girl, adolescence age, the presentation sometime multiple systematic, but diagnosis itself sometimes is difficult because on the cycle, because you may take 3 years after menarche to establish the regular hypothalamo-pituitary ovarian axis. 3 years. So we need to give a bit time. So we are not diagnosing anybody with a PCO at the age of 14. The main concern here are acne, hirsutism, and hair loss. Treatment will depend on what the patient wants and patient needs. It may be anti-androgen, it may be estrogen progesterone preparation, it may be metformin, systemic treatment along with weight reduction and a local treatment for hirsutism or acne. Maintaining weight and counseling is very, very must. And we see a lot of time that mothers are coming, will there be any problem in the pregnancy? You imagine somebody at 19 years, mother is worried about the pregnancy. Young adult, the concerns irregular cycle, acne, hirsutism, weight gain, fertility issue, here it will come, 25, 30 years, anxiety or depression because of the look, and again the treatment will depend on what is they want and what is needed. It has to be local therapy, combination of metformin, estrogen, progesterone, anti-androgen, and help for conception. The next one, in the middle age, concerns are weight, high blood pressure, high lipid, high sugar. And this is what our main issue now is coming, to know about the PCOS across the life stages. So something is happening beyond the ovary, and this is a snapshot of something happening. 2/3 of the people with the polycystic ovarian syndrome have insulin resistance, 2 times higher chance of NAFLD, or now it is MASLD, 45% chance of type 2 diabetes, and very importantly, endometrial cancer. Some of the cumulative data is 2.7 times increases postmenopausal endometrial cancer in people with the PCOD. And this is what the metabolic syndrome, metabolic impact of the PCOD. And as you see that metabolic syndrome risk in PCOS women in their 30s is comparable to that women of 50 to 60 in general population. And we have some pathogenetic explanation for that, insulin resistance and compensatory hyperinsulinemia. Then causes increased steroidogenesis, and that's all make this problem. And weight control is very, very important. So in postmenopausal arena, the concerns are weight maintenance, postmenopausal hirsutism, blood pressure, diabetes, dyslipidemia, coronary artery disease, and endometrial carcinoma. So in one way, we need to follow them up for this diagnosis. And treatment, therapeutic lifestyle, weight loss, pharmacological therapy for metabolism, anti-androgen and HRT or not, we are going to do this. So for the therapy is concerned, lifestyle, first line of therapy, although here I mentioned 30 minutes. Personally, I believe 30 minutes is not good enough. It should be 45 to 60 minutes, and no question of 5 days in a week. Every day we eat, every day we should do exercise. And there are clear mechanisms how it improves. We all know now, after the availability of Mounjaro and Ozempic, 5 to 10% of weight loss, because increased SHBG, reduce the free testosterone and restores the ovulation. So weight loss is very, very important. Whenever we are treating hyperandrogenism, like hirsutism as acne, our first line is the suppression of LH, that is by estrogen progesterone preparation. Particularly, we try not to use the word of oral contraceptive. It doesn't give a good sense in our country for the young unmarried girl. But estrogen progesterone preparation to regularization the cycle and for the hirsutism is a good treatment. And then other treatments are there. 4 licensed drugs are there: spironolactone, cyproterone acetate, finasteride. Purposefully, the 4th one I didn't mention, that is our flutamide, because this is quite a bit liver toxic. There are some reality checks is there. We need to counsel them very clearly that hair growth cycles are slow. So whatever you do, by the time you see some improvement, it will take probably 3 months. A good improvement, 6 to 10 months, but maximum of your response will be seeing by around 12 months. So no, not to expect that within 2 weeks something magic will happen. So that will get our expectation of the patients very correct. And mechanical removal of the excess facial hair, body hair, that depends on the social need. And we don't need to tell, the results are do. The other issue, which is the famous picture, mere paas bachcha hai, now we have changed that initially from the bottom, optimal health, the BMI optimization, folic acid, letrozole, clomiphene citrate, metformin, gonadotropin, IVF, that's more or less you go. Metformin is definitely one of the medicine in our prescription for people with the PCOD, unless proved otherwise. Purposefully, I am not mentioning about inositol because my reading of the literature of inositol doesn't cause anything great. Still now, it's probably not the best one. So in summary, in adolescence is a PCOS symptom, increasing BMI, psychological burden, PR matching problem. In reproductive age to pre-menopause, PCOS symptoms, subfertility, pregnancy complication, pregnancy outcome, BMI, metabolic burden, psychological burden, and after menopause, BMI, metabolic burden, diabetes, dyslipidemia, coronary artery disease, all these hypertension, and not to forget about endometrial carcinoma. So when I was preparing the slides, Santesh has given this slide the title as PCOS across life stages. It's not mentioned in women or men. So I was thinking, is it possible that bhaiyo ke saath bhi aise hota hai? We don't have overly agreed, but is there anything called a male PCOS? Actually, it is there. We don't have overly agreed, but there is something called male PCOS. Just a few points to tell you. Quite a bit literature is there last 15 years that male equivalent of PCOS, a diagnostic criteria obviously cannot be the same, and usually there sister has PCO or mother had PCO, or they have been exposed, mothers has been exposed to androgen in pregnancy. And presentation is early onset androgenic alopecia, and that's why the Salman's picture actually good androgenic alopecia matches here. Hormonally, they have increased LH-FSH ratio, elevated testosterone, DHA sulfate, and AMH increases. So that's very interesting to see a male PCO. More importantly for our health is consequence of insulin resistance, obesity, dyslipidemia, cardiovascular risk. And the treatment, the genetic component like to play a role in the PCOS with maternal obesity and PCOS. And this can be just because of high androgen exposure in the pregnancy in particular group of people. So that's why I want to stop with the research question, that my research question. We need to see what we need to see in future with the PCOS, that cardiometabolic impact of PCOS. What is the role of now for us? What is the role of Ozempic and Mounjaro? Whether you can use them, they are not licensed, this is unlicensed till now. We cannot use a lean PCO on of these medicine, but we need more data and more study. Some studies are going on. And what could be the intervention for the sons of mothers with PCOS or sisters with PCOS? So nothing can be more pleasurable to beat Pakistan. I think all of us will agree. Thank you very much.
Thank you, sir. Excellent talk. Sir, one simple question. Where do you place AMH routinely in evaluating PCOS?
For our, as you see the recent criteria, it has that PCOM in ultrasound or AMH, but we don't do it. Mainly the gynecologist obstetrician that do it. Their panel automatically includes an AMH. But the problem is that AMH can be a bit falsely high in PCO, and that cannot be taken as a reassurance that their fertility potential is very good. So probably we should not do, unless there is a problem with subfertility and a gynecologist are assessing them.
Otherwise it's not required.
We don't do. I don't know about a lot of endocrinologists are there. I don't know about your opinion.
Before I ask upon the questions from the floor, please.
Very unusual situation in Sunday morning in Bangalore. You will not give a half of this crowd also. I'm very pleased to see that a lot of people are here.
Upon to start with AMH, across the life stages. So at birth you have in utero the genetic predisposition. In infancy and early childhood you have raised AMH. That is very peculiar of this PCOS category. In the reproductive category, there is normalization of the menses. The androgen levels fall, and almost 30% of these typical PCOS ladies, they ovulate normally. And the fertility chances are increased. So gynecologists who are there would agree that the fertility chances are increased, and that is again linked with the, although there is a decrement in the follicle number, the role of the AMH, there are increased fertility potentials in the IVF clinics. Lastly, about the last stage post reproductive age, that is the menopausal age group, and there was a study where they have compared with the normal menopausal women, and we all know the cardiovascular problems which the normal postmenopause females have. They are linked with the dyslipidemia, including the LDL cholesterol and all, the BMI, truncal obesity, whatsoever. What was peculiar to PCOS was increased hypertension, increased triglyceride, and cerebrovascular morbidity. So that was very typical of them. You talked about Salman, and this was a study which you showed in your slide also. They took males with androgenetic alopecia, and 30% of them, they had that gonadotropin values and the lower SHBG, which was typical of that. And from the PRS, the polygenic risk score, they have, which is linked with PCOS, they have shown the males, they have increased incidence of type 2 diabetes, obesity, and interestingly, increased coronary artery disease and androgenetic alopecia. And from that PRS, there are studies, Australian studies, which are similar to your first case. And they have shown that the PRS, one standard deviation change, is linked with early puberty, almost 0.9 months. And one standard deviation of PRS is linked with the peak height velocity earlier. So according to that case of yours with precocious puberty, we have this category where we can have early peaking of the height and the puberty, which is again linked with PCOS.
Correct.
So that was just to share about that. And the last AMH correlation was with the laparoscopic ovarial drilling. They have shown that the fertility chances are increased if you have an AMH of less than 7.7. So a lot of things today about the AMH and across the lifespan. So I should give a big hand to Orpanda, the way he presented. Thank you. Thank you.
Thank you.
So we can wind up, and Priyanka will be there.
I would request the speaker and the chairpersons to proceed towards the felicitation area. For the next session, I would like to invite the chairpersons, Dr. Surendra Kumar sir and Dr. Angad sir, to the stage.
Good afternoon. Welcome to this session of thyroid toxins without hyperthyroidism. It is interesting, confusing, and challenging. As we are going to presentation of our expert, the Manas P. Barua. Please start.
Thank you so much, and I sincerely thank Santosh Da for inviting me. It's a great audience, as Arpana said. Sunday evening, the hall is full, so that kind of stimulates you to talk on a topic which looks very simple, but there are so many small and big nuances which sometimes are, very useful in your clinical practice. So, So my topic is bit odd, thyrotoxicosis without hyperthyroidism. Usually thyrotoxicosis is always with hyperthyroidism as we usually think, or we are taught in our younger classes. But there is a subset of thyrotoxicosis which doesn't have hyperthyroidism. And let us discuss some case scenarios. So this one is a first case is a 28-year-old female primipara, no history of thyroid disease, no history. The 5 weeks postpartum, she complains of palpitation, anxiety, heat intolerance, and mild tremors. Thyroid function test shows slightly high FT3 and somewhat more higher FT4 and THS is suppressed. and anti-thyroid antibody is positive, and thyroid palpation is unremarkable, no tenderness, no goiter. What is the diagnosis? So this is a typical postpartum thyroiditis, which was mentioned by S.K. Singh sir also. It's one of the subcategory of thyrotoxicosis presenting around pregnancy, usually presenting after pregnancy, sometimes within pregnancy also. And this is of autoimmune origin without any pain. The case 2, you can see 38-year-old female mother of 2, primary hypothyroidism pre-existing. Last 3 weeks complaints of symptoms of thyrotoxicosis, mild symptoms. Again, thyroid function test shows somewhat higher FT3, FT4. FT4 is more. Anti-thyroid antibody positive, thyroid palpation firm, non-tender. What is the diagnosis? So it's a hacetoxicosis. What happens, in a classical case of primary hypothyroidism, we usually expect that the thyroid function should go down and down and down. The patient should become more and more hypothyroid. But it's not always true. Sometimes there are surprises. And some people with lesser degree of hypothyroidism might present with a brief period of thyrotoxicosis, which is usually transient, and it is followed by a greater degree of hypothyroidism. That could be one of the subset where the presentation and progression is little different. So it is again of autoimmune origin and painless, usually painless. Rare cases have been described as painful. The third case is a 68-year-old male teacher having malignant melanoma and on immune checkpoint inhibitor nivolumab for last 8 months. For last 3 weeks, complaints of palpitation and neck pain. Neck pain is there as a Malay. And the anti-thyroid antibody is negative, but there is evidence of thyrotoxicosis, especially T4 is higher, T3 is not that high. And thyroid palpation shows firm, mildly tender thyroid. What is the diagnosis? This is a new entity nowadays. We are encountering more and more immune checkpoint induced thyroiditis. Again, this is a thyrotoxicosis without hyperthyroidism. The fourth case is a 58-year-old businessman, smoker, long-standing hypertension and diabetes, so no history of thyroid disease earlier. Had ventricular arrhythmia, treated with amiodarone, and then he's developed the symptoms of thyrotoxicosis. Again, thyroid function test shows typical evidence of thyrotoxicosis, anti-thyroid antibody negative. Thyroid palpation unremarkable. What is the diagnosis? It's quite apparent, amiodarone-induced thyroiditis, but it is type 2 amiodarone-induced thyroiditis. So type 2 amiodarone-induced thyroiditis, usually this presents with the transient thyrotoxicosis or destructive thyrotoxicosis. There is another class of amiodarone-induced thyrotoxicosis, that is type 1, usually seen in iodine deficient areas, and they usually present like Graves' disease, hyperthyroidism. So this is how you different from type 1 to type 2. And here your radioactive iodine uptake will be low, and Doppler ultrasound will show low vascularity, unlike the type 1 amiodarone-induced thyroiditis. The next case is a 31-year-old male college student, regular gymming, takes multiple non-prescription high-energy yielding nutrition supplement, presents with symptoms and biochemical evidence of thyrotoxicosis. Thyroid palpation again unremarkable, though this is a new entity again. We are getting more and more. Thyroiditis induced by exogenous thyroid extract, which are present in a lot of food supplements which are prescribed by the non-medical persons. So it has to be kept in mind while you differentiating different causes of thyrotoxicosis in any presentation. Final one is a 24-year-old female nurse, no history of thyroid disease in the past. Severe neck and posterior ear pain, malaria, fever, and occasional palpitation. Has this typical feature is high free T4 and slightly high free T3. So T4 to T3 ratio is higher. Anti-TPO negative, TS is suppressed. So thyroid palpation shows grade 2 thyroid, hard to firm consistency, significantly tender. What is the diagnosis? This is your classical subacute thyroiditis or decurvent site thyroiditis, which is a classical form of painful thyroiditis. So these are the different pictures of thyrotoxicosis which can present to you without any hyperthyroidism. So just for the discussion, I have presented these prototype cases. They are not real cases. So what is thyrotoxicosis without hyperthyroidism? The thyroid gland overproducing. With hyperthyroidism is the thyroid gland overproducing the hormones. So production of the hormone is going on at a higher rate and it is being released. So that is Graves' disease, toxic MNG, toxic adenoma. These are three typical types. And without hyperthyroidism, it is caused by the release of pre-formed thyroid hormones or from an external source. So always remember, thyroid gland has got at least few weeks, store of thyroid T4 and T3, mostly T4 in the gland. So for various reasons, that gland can get destroyed and that can be released and causing a transient form of thyrotoxicosis. That is a thyrotoxicosis without hyperthyroidism, because there is no production. In that period, there is no production of thyroid hormone in the gland. So that is thyrotoxicosis without hyperthyroidism. And of course, if somebody is taking extra thyroid, thyroxine tablets, without prescription or with prescription mistakenly, or taking thyroid extracts, which can actually supply thyroid hormones to the person who is taking it, that can also present as thyrotoxicosis without hyperthyroidism, because exogenous thyroxine is going to suppress the production of thyroxine inside the gland, the endogenous production. So thyroiditis denotes an inflammation of the thyroid gland, and it leads to the destruction of normal follicular architecture. And destruction-induced thyrotoxicosis has different, typical, features like abrupt onset of thyrotoxic symptoms, unlike, Graves' disease or multinodular goiter is a very insidious onset. Graves can be, it may look abrupt, but it's not exactly abrupt. It's kind of a long duration of presentation. But usually destruction-induced thyrotoxicosis is very abrupt, and development of new enlargement of existing goiter. Usually they are antibody negative unless there is a pre-existing status where patient was having no thyroid disease with antibody positivity. Usually they present with low radioactive iodine and low vascularity as demonstrated by Doppler ultrasound. I will come to that. And elevated serum thyroglobulin at some phase of the course of the disease, and some variants may progress to permanent hypothyroidism also. So the classical type is subacute thyroiditis. It has got different name in the literature, so let us just stick to one name, that is subacute thyroiditis, because otherwise it will be confusing. So epidemiologically it's uncommon but not rare, and it's mostly seen in temperate region, and sometimes what happens, for few weeks you will only be seeing subacute thyroiditis cases successively, and for many months again you may not have any case at all. And a rate of occurrence is 1 per 5 cases of Graves' disease. So that is one kind of ratio which might help you in differentiating the different causes. Female, of course, is more, as in all endocrine cases, rare in first decade and common in second to fifth decades. It could be viral etiology, but there is no concrete evidence. It could be coincidental because there is no inclusion body which is found in these cases in histopathology. There are various viruses which have been implicated, even COVID. A lot of literature showing that there is thyroiditis following COVID inflammation, but there is no concrete evidence. And there could be some acellular phenotype which may make a person predisposed to the occurrence of subacute thyroiditis. Etiology could be humoral or cellular, mediated by T lymphocyte sensitization to thyrocyte antigen. So basically, it happens because of immune reaction to the thyroid gland causing a destruction, which can be because of a wrong signal, but usually it's not expected to be a direct injury caused by any virus or any organism. So pathological hallmark is an enlarged and edematous thyroid gland and slightly adherent to these structures, and it's usually painful, and it's not very easy to mobilize, unlike other thyroid enlargement, and more often irregular in distribution. And many times, or most of the times, you'll find that the two lobes are not equal, but most of the other diseases, the two lobes are usually diffusely involved, and they're felt equally. Even if they enlarge, there is equal enlargement in both the lobes. And only in multinodular goiter you find that there is a irregularity. Many times I have found that the referred cases, they confuse multinodular goiter with thyroiditis, vice versa. So clinical features, wide variation in terms of mode of onset and severity, and the prodromal symptoms are always there. The malaise, myalgia, arthralgia, upper respiratory symptoms, like any other viral disease. Fever may go up to 40 degree. Pain and tenderness very typical. It could be very severe pain, or there may not be any pain at all also, but usually they present with pain. And the localization of pain is an upper, bilateral or unilateral. Initially, are encrypted to the other. Usually they do not stay in one lobe, but usually invariably over the next few weeks they will involve the other lobe. And there is radiation, typical radiation to the posterior auricular area. There is presentation of thyrotoxicosis and there is a goiter most of the times. The pain is, as I have said, it's around the jaw or in the back of the ear. Many times patient may go to a dentist or maybe may go to a neurologist for cervical spondylitis, and it may be misdiagnosed for a couple of weeks time also. The goiter, the pre-existing goiter may be noticed first as in 8 to 13%, and slight to moderate enlargement. Very big enlargement is not seen. As I said, they are not typically equal. One lobe may be larger than the other. And cervical lymphadenopathy, although expected to be there, is not very typical. It's not very commonly found. The routine blood test, it's very important to note that very high ESR is a classical hallmark of subacute and we have all recently used CRP, serum CRP as a marker, and it helps a lot. I'll show you some findings of my own study. Moderately increased TLC up to 18,000 you can find. There are other non-specific markers of inflammation may be there higher, but they do not help you because any kind of inflammation there may be higher levels of all these markers. Increased hepatic enzyme also may be found. That's found in most of the viral disorders. This is our study which shows that CRP is a good discriminatory test compared to ESR, but here we can see that the CRP of the subacute thyroiditis patient is much higher. So if there is a confusion between Graves' disease and subacute thyroiditis, sometimes you may encounter, and you want to, many times we see that people are started on anti-thyroid drugs unnecessarily, and that goes on for many, many weeks, which is not at all necessary. In those situations, maybe serum CRP level or high ESR can discriminate between a Graves' disease patient and subacute thyroiditis patient. And here again, we have shown that serum CRP is better than ESR in discriminating these two groups of thyrotoxic patient. And this is a thyrotoxicosis without hyperthyroidism. So firstly, there is release of preformed stored hormone. That's why you find more T4 than T3. So classically, in subacute thyroiditis, there is higher T4 than T3. And classically, in multinuclear goiter, there is higher T3 than T4. In Graves' disease, both of them should be increased. Thyroid hormone synthesis actually decreases and actually stops totally for some time till the whole gland recovers, and the patient remains toxic till the whole store depletes in the circulation, and that could be around 3 months or even lesser than that, but usually not beyond 3 months. But the pain may remain beyond 3 months also. So the course is the variable duration 2 to 5 months without treatment. The recurrence is unusual, 2.3% per year, but not rare. So phase 1 is thyrotoxicosis. Phase 2 is hypothyroidism because the gland has been destroyed, and phase 3 is recovery. The patient comes to euthyroid status. So these are the tests which are special investigation: the thyroid function test, radionuclide uptake test, thyroglobulin, and thyroid ultrasound and Doppler. So this is how the thyroid hormones behave. Typically, T4 will be initially very high because of the destruction and release of the preformed hormone. Then it depletes, comes to a very low level, hypothyroid level. Then it gradually rises and stabilizes over next 6 to 7 or 8 weeks period. Likewise, because of high T4, there will be THS suppression to a very low level. Then the TSS rises at the hypothyroid phase, and gradually it falls and finally becomes normal. Likewise, your radioactive iodine, firstly it will be suppressed, then it will rise. When the TSS rises, parallelly radioactive iodine uptake will increase and it will stabilize around normal. And thyroglobulin, in the intervening period, in the mid period of the course of the disease, it will rise and it will fall again. This is also one of the markers of gland destruction which is used. What is the role of ultrasonography? It's very important. So we know in a thyroid ultrasound, Doppler is used widely, and in Doppler you find pattern 0 flow, that is no vascularity, pattern 1 flow, normal vascularity, and pattern 2 flow, hypervascularity. So this is a normal a high resolution ultrasound of thyroid, you can see the normal gland is not enlarged and it's a diffuse ecotexture but not very bright. And this is Graves' disease. You can see that compared to this, the glands are enlarged and it's a brighter ecotexture. And this is an adenoma which is localized with a capsule, surrounding capsule. This is subacute thyroiditis. Just try to differentiate it from Graves' disease. In Graves' disease, this diffuse brightness, but here there are dark, dark areas. These are the inflamed areas, and these are brighter normal areas. Gradually, the entire gland will be involved and these will become darker, and these will start healing. The healing process will happen in patches. So more importantly, I will not show it because it's a colloid goiter. I will try to show the Doppler ultrasound. That is, in thyrotoxic patient, normally you get this kind of pattern 1, and this is adenoma, very highly vascular, localized structure. The same adenoma which I have shown. The same Graves' disease I have shown, this is typically hypervascularity, inferno appearance, and this is subacute thyroiditis. Same toxicosis, here the inferno appearance, this is normal, this is hypovascularity. So this is how you differentiate very simply by ultrasound. And in radionucleotide scan, this is normal gland, which shows that brighter uptake in the thyroid area and some uptake in the salivary area. In case of Graves' disease, the uptake is much more in the thyroid area. In case of toxic MNG, you get, mixed picture, high uptake, low uptake. So this is a mixed picture. And finally, subacute thyroiditis, you find that there is no uptake compared to Graves. There is no uptake, and because there is no uptake in the thyroid gland, the entire radionucleotide is taken up by the salivary gland. So this is how we differentiate. Therapy of subacute thyroiditis is mostly symptomatic. This beta blocker, non-steroidal anti-inflammatory drug, and reassurance. Most of the patients will actually recover by reassurance itself, but some of them may require, next phase of treatment, that is with glucocorticoid. And we have shown that because we don't have any objective evidence as to what should guide our glucocorticoid therapy, we tried to find out. We found that a CRP level of 19.3 and ESR level of 46 is a discriminatory level at 1 week after the onset of symptoms or presentation. If the patient is having more than 19.3 CRP, it's almost invariable that patient is going to require glucocorticoid because patient is going to come back with poor quality of life and persistent pain. So our suggestion is that maybe CRP level of 20 can be taken up as a discriminatory test for inducing glucocorticoid therapy. Of course, you give it for 4 to 6 weeks depending on the symptoms and gradually taper off, and usually you expect a full recovery. Alternative therapies like radiation, the destructive therapies like radiation, sodium iodate, and thyroidectomy are there, but they are not very rarely used. I personally, I'm lucky enough not to use any one of them. So they are very rare, modalities which are practiced in rare situations. Experimental therapy, THS, thyroxine, T3, of course, they are again in experimental situations only. They are not clinically practiced mostly. So with this, I end my talk, and thank you very much for your patient hearing. You can take up questions now.
Thank you, sir. Thank you, sir, for this marvelous presentation. Now, sir, you have shown too many ultrasounds. If the microcalcification is there in someone, how we will proceed for that?
Yeah. So actually, microcalcification is a different entity. So it's usually seen in, nodular goiters. It could be 1 or it could be 2. Usually in multinodular goiter, if you have microcalcification, that becomes a suspicious. If the calcification is curvilinear in the periphery of the nodule, it is usually considered as a benign. But if there is speculated microcalcification throughout the nodule, inside, outside, along with some internal vascularity, the vascularity going inside the nodule. Usually in multinodular goiter, you find that the vascularity is in the periphery. But if it goes inside, that also becomes a suspicious nodule. Of course, that has to be confirmed by a guided ultrasonography. That is my practice. But that is a suspicious nodule then, that time onwards. So high category of thyroid nodule.
Recently, there was a case on this.
But that is not subacute thyroiditis, where we don't expect any calcification. It's a subacute presentation. Only in a long-standing pathology, you expect calcification, which can be a harbinger of malignancy inside that nodule.
Sir, questions?
Yes.
Leave the CRPSR aside. Tell the audience when not to use steroids, because most of the times I see people with subacute thyroiditis without an adequate trial of NSAID. So when should I think of starting steroids in somebody with subacute thyroiditis?
I think so. Very important one. Before steroid, I request all of you not to prescribe azithromycin and all this stuff, antibiotic, number one, because mostly they get that, and I'm very sorry to say. And glucocorticoid you should reserve for the patients whose quality of life has suffered significantly, and there could be rare cases like that. And of course, you will take all the precautions before giving steroid. So I would say, in good judgment, ask the patient to come back with a lot of reassurance. And maybe you can wait for another 2 weeks by reassuring more and simply changing the NSAIDs. That works as a placebo. Finally, if it doesn't work, maybe you can start glucocorticoid at 4 weeks. But try to use a minimal dose and try to use probably lesser potent. Deflozacort works in most of the cases.
When would you give steroids? No textbook tells you this, so what is your practice?
Somehow I do use steroids. Sorry to say that, but I do use steroids. I have used the NSAIDs, but somehow I don't get satisfactory response. And 2 cases, one was reported in JES about the presentation as PUO, pyrexia of unknown origin from SAT, and that responded in a diabetic to steroids. So I have my own experience.
In fact, the topmost internist of Guwahati, he had PUO. He suffered for almost 6 weeks before it was diagnosed to be. He received all the antibiotics given by ENT people.
And the other place where it's sort of quackery, JJ, is in amiodarone-induced thyrotoxicosis. You give methimazole, you give steroids, you want to just for the benefit of the patient. So that's one place. And I was just going through the therapeutic plasma exchange, and I would like to know your experience on that. Therapeutic plasma exchange in patients with amiodarone-induced thyrotoxicosis.
No, sir, I don't have personal experience.
And even in preparation for surgery in cardiac patients with subacute thyroiditis, they have gone for therapeutic plasma exchange. And one of the other cases, it's again for the audience, undergoing hysterectomy and chemotherapy. So anybody can just guess what can be the association with Manav stock. Hysterectomy with chemotherapy. JJ, it's for you also. Manav stock, treatment, hysterectomy and chemotherapy. Thyrotoxicosis without hyperthyroidism. Any guess? Hysterectomy, that was a case of choriocarcinoma.
Choriocarcinoma.
Yeah.
Thank you, sir.
I would request the speaker and our chairpersons to proceed for felicitation. Now for the next session, I would like to invite our chairpersons, Dr. Om Kumar sir, Dr. E. Haq sir, and Dr. Sudhir Kumar sir to the stage.
So I think speaker has been changed. Initially it was about hyponatremia, a very common condition, clinical condition. But yet another very important clinical condition which has to be addressed in day-to-day medical practice is practical management of acute calcium disorders from deficit to excess. So in this era of indiscriminate use of vitamin D, this is very pertinent, and the speaker is none other than Dr. Ganpati Bantwal. So I may request him to proceed to this very important topic.
Thank you, Chairperson. Let me thank Dr. Santosh Kumar for giving me this opportunity. And I also thank Nagesh for preponing the talk, and that's the reason the confusion. Okay. Yes, so this is a vast topic because I have to cover both hyper and hypocalcemia also. So let me try to do justice. See, the normal range of calcium varies between 8.5 to 10.5 milligram per deciliter. It's a very important electrolyte, or what you can, or mineral you can say, which is critical for bone health, muscle function, and nerve signaling. And as you know, hypocalcemic and hypercalcemic emergencies are life-threatening, and we'll have to treat them immediately. So this is some basic physiology. Human adult contains approximately 25 milligrams of calcium per body weight, of which more than 99% is found in the skeleton. 50% is the ionized or free or dialysable form. This is the active form. 10% is bound to anion like phosphate, bicarb, sulfate, citrate. And 40% is bound, it's the protein bound. So this is very important because you have excess proteins or you have a change in the pH, suddenly the calcium may change up and down. So that's the reason you require to know about these things. So coming to the regulation of calcium, a decrease in the ionized calcium produces an inhibition of the PTH released by the CSAR. So what happens is the PTH increases now. That in turn will see that the calcium is absorbed more from the kidneys. PTH in turn will stimulate the 1-alpha hydroxylase, so you produce active vitamin D. Active vitamin D will further ensure that you increase the absorption of calcium from the gut along with this. And when you have increased vitamin D, increased PTH, you find that there is some amount of bone resorption, and you find that the calcium is maintained at the normal level. So let me begin with the case. 44-year-old male who just came around 2 months back. Generalized body ache since 1 year, left humerus fracture while turning during sleep, nailing in 2025, right femur fracture while squatting December. We thought it's a malignancy, so he did a PET CT was done. This is outside. But then it found 3.1 into 2.5 centimeter lesion in the left lobe of the thyroid gland, referred to our hospital. Not on any other medications, no calculi, abdominal pain, normal examination. So what we found was labs, there was anemia, but otherwise they were okay. And then we did a calcium profile, it showed 12.3, corrected was 12.9. Vitamin D, low, PTH 888. Now how will you manage this case? Hypercalcemia seen in 1 to 4%, symptoms vary. Most important cause, hyperpara or malignancy. Untreated, lot of morbidity can happen. Different type of symptoms, CNS like confusion. Severely when you have, they can have coma also. Anorexia, pancreatitis, gas, the moans, groans, what is here in hyperpara. Polyuria, because it has a diuretic effect, it produces a nephrogenic DI, renal stones, arrhythmias can happen. Physical signs, of course, you can have features of volume depletion, hypertension, QT prolongation, band keratopathy, etc. So the moment you find hypercalcemia, what you should do, whether it is PTH mediated or non-PTH mediated. So always get a parathyroid hormone. You must maintain the cold chain when you actually do this. Take it with the ice syringe, immediately cold centrifuge it, and then assay it quickly. Otherwise, you may not get a good value. So that's the reason that is very important when you actually do an assay for PTH. So other causes include non-PTH mediated. So when you have a high PTH, what happens is increased calcium, low phosphate, high PTH is hyperpara only. You find high calcium, low PTH, and low phosphate. That's also like looking like that. Generally, you start suspecting, are we dealing with PTH RP? Because it also produces the same type of feature. There are others like vitamin D intoxication, increase in vitamin D, thyrotoxicosis, etc. So primary hyperpara, increased calcium, low phosphate, PTH increased or upper limit of normal. Vitamin D depends on the thing. Humor hypercalcia of malignancy, if it is PTH-RP mediated, high calcium, low phosphate, but PTH is low, but check for PTH-RP. Others like LOH, granulomatous disease, where active vitamin D is produced by the macrophages. These are other causes. How do you classify? Mild up to 12, moderate 12 to 14, severe more than 14 up to 16, life-threatening more than 16. How do you approach? Repeat once again to find, are we really dealing with that? Suppose you find somebody is having a calcium of 18 and he doesn't have any symptoms, then there is a problem with the assay. You think of a myeloma because you may have a pseudo hypercalcemia, so suspect that. Drug intake, lithium mimics like hyperpara. Vitamin D excess you see, if it is more than 150, if your vitamin D levels, nanograms per ml, so start suspecting that. Thiazide diuretics unmask the parathyroid adenomas. Granulomatous disorder, tuberculosis, sarcoidosis. So I told you more than 90% of the cases, HPT and malignancies. Okay, this is the diagnostic which I actually told you. So how will you approach this patient? Correct volume depletion, stop bone resorption, effective treatment for underlying causes. First line therapy is hydration, bisphosphonates or denosumab next, calcitonin, glucocorticoids or hemodialysis. IV hydration, what do? Saline you have to give them. Very important is you must hydrate them properly. Rationale of this, always use saline, not other preparations, because the calcium absorption is coupled to sodium. You give a little bit more. One is you have dehydration, pre-renal azotemia. The only way the calcium can go out is through the urine. And now by giving fluids, you are seeing that it's going out in the urine. So sodium is not absorbed when you hydrate them properly. So you can bring down by around up to 4 milligrams can also happen. So what is the expert opinion? Isotonic fluid at a rate of 200 to 500 ml per hour, possibly preceded by a bolus of 1 to 2 liters to maintain a urine output of 100 to 150 ml per hour, taking into consideration the patient's renal and cardiac function. Other problems, monitor potassium and magnesium in these patients. Rarely you may get hypernatremia. Effect is short term, within 1 to 2 days. What about diuretics? You have to use diuretics only once he is fully hydrated. Don't use it before that because you produce dehydration, more sodium gets absorbed, calcium gets more absorbed, and the hypercalcemia can worsen. If at all you give, only give it. Otherwise, don't give it at all. So you give it in somebody who is having, say, a little bit of chest discomfort because of fluid overload, then you give it. Otherwise, just hydration is enough. No need of giving diuretics. So only in fluid overload or only after appropriate hyper. Calcitonin, fastest acting. You want to bring down the calcium quickly, use it. What is the problem with this? One is short acting. So within, say, 3 to 4 days, you develop tachyphylaxis and then you can't use it. So that's the only problem with this. And some side effects like nausea, vomiting, abdominal cramps can happen. So useful, but short acting. Then the main line, bisphosphonates, mainstay, zoledronate and pamidronate. Onset of action, it takes at least 2 to 3 days for action. First time when you use, you may get a flu-like reaction. Don't use if the GFR is less than 30. Denosumab, use it, say you gave zoledronate, it's not working. You give another dose, not working, then you give denosumab because in refractory hypercalcemia, this is the drug of choice. And in fact, people have used 120 milligram on day 1, 8, 15, 29, and they found it was actually useful. So it's been actually recommended for treatment of hypercalcemia of malignancy where people were given zoledronate and they didn't respond. So they found 64% of the patients responded by day 10 of treatment, 70% responded over the course of treatment, mean duration 9 days, and they had normal levels of calcium for around 104 days. So it's equally good or better than zoledronate and is preferred in refractory hypercalcemia. Glucocorticoids, multiple myeloma, where Dickoff factor is there, that gets suppressed when you actually give glucocorticoids, 200 to 400 milligrams for 3 to 5 days. So quick action. Also use it in vitamin D excess granulomatous diseases because that will inhibit the 1-alpha hydroxylase which is produced by the macrophages. If you are given this, still it's going on increasing, you can actually try calcium mimetics. Not as a major thing, but then see that you maintain it near normal. So you can use calcium mimetic, 30 milligram, can go up to 120 milligrams also. And finally, somebody is having severe hypercalcemia, neurological, what is in confusion, coma, then you can actually use hemodialysis with the 0 or low calcium dialysate. So this can be used, somebody is having more than 18. There's an entity known as parathyroid crisis when you have more than 14 milligrams, multi-organ involvement, worsened by immobilization, high-dose vitamin D. They were already taking medications for this. So what do you do in them? Hydration, calcitonin, bisphosphonates, or denosumab. Dialysis is the last resort. So what did it do to our case? We did a technetium system maybe. It showed a left inferior parathyroid adenoma, underwent surgery. You can see his PTH came down to 72 in 15 minutes post-surgery. Post-op management, they actually went into hungry bone syndrome. Histopathology was suggestive of parathyroid adenoma, discharge on calcium and vitamin D. So coming to case 2, 42-year female, 1 year back underwent total thyroidectomy, benign follicular disease with thyroiditis. Presently she's on 100 micrograms of levothyroxine, calcium carbonate twice daily, calcitriol, pantoprazole. So she is having permanent hypoparathyroidism. Now she came in November with pain abdomen, generalized numbness and pain, phonation difficulty, dyspnea, vitals stable, but you can see that the calcium is 6.4, phosphate is high, ionized calcium low, PTH is low. So how do you approach this case? How are the symptoms? Mainly they present with nervous system symptoms because of the irritation of the nerves. Chwastex and Truch's sign. Truch's sign is more sensitive or specific. Only 1% will not have, it's a false positive is just 1%. So it's very sensitive, Truch's. Whereas Chwastex sign, 10 to 25% will have a false positive. Others, bronchospasm, arrhythmias, etc. So what is the most common cause of hypocalcemia is hypoalbuminemia. So that's the reason you require to correct it. Suppose somebody is having an albumin of 2.4 and his calcium is 7. It's not low. You add, so take 4 as a normal value, minus that 2.6 is 1.4. You add 1.4 to that 7, that comes to around 8.4. So the corrected calcium is serum calcium plus 0.8 into 4 minus serum albumin of the patient. So you have to ensure that this correction has to be done. So a lot of causes, increased protein binding like alkalosis. Many times when you hyperventilate, you may get tetany, complexing anions. Why do you require to know this? Citrate, blood transfusion, massive blood transfusion can have hypocalcemia. Then drugs, inhibition of bone resorption by estrogens, rapid bone form, hungry bone syndrome, etc. So rapid accretion like our patient, because severe hyperpara, post-op, hungry bone, how do you diagnose it? From hypopara, which can happen after you remove this, you have low calcium, low phosphate. If you have developed hypopara, you will have low calcium and high phosphate. So that's a differentiating feature between a hungry bone. So you can have this hungry bone after parathyroid adenoma, and you may also have it hungry tumor syndrome, which can happen with metastatic prostate cancer. Usually this happens when you introduce an agent like an estrogen, because what was happening now, it was in a balance. Bone formation was balancing with bone resorption. The moment you gave this, what happens is the osteoclastic bone resorption stops and then it gets into the bones, and that's the reason you get it. And sometimes it can follow even thyroidectomy for thyrotoxicosis. Rarely this can also happen in this patient. So what do? First confirm. Then if the patient has seizures, life-threatening hypertension, laryngospasm, heart failure, give IV calcium even without waiting for the ionized calcium reports. What do you give? Elemental calcium gluconate is better. That's because you have to give an IV bolus. You can give 10 to 30 ml of 10% gluconate. mixed in 150 ml of dextrose over 10 minutes. This raises by around 0.5 to 1.5 milliequivalents. Suppose somebody comes to you, corrected calcium less than 7.5, suddenly he may develop a laryngospasm and also. In these patients also, you can actually give them IV calcium. If you don't have calcium gluconate, carbonate may be given, but then extravasation can produce tissue necrosis. See, what we find always a problem in medicine wards is they'll give one bolus, stop it. Action goes off within 2 hours. So you have to continue to give an infusion. What is the rate of infusion? 0.5 milligram to 1.5, so that you maintain it in the normal range. And then gradually, once the patient becomes better, you can start him on oral calcium and vitamin D. What about ECG monitoring? Not always mandatory, except when the patient is taking, say, he's on digoxin. So then you monitor, because you may produce arrhythmias. Very importantly, many times you find in general, in the inpatient, you give them infusion, give calcium, vitamin D, patient is not responding, continues to have symptoms of Chvostek, Trussier sign. Why? Because they have hypomagnesemia. So correct the hypomagnesemia, persistent magnesium. If it continues, give them oral 300 to 400 milligram in 3 divided doses. A drug which can produce a magnesium sparing diuretic is amiloride. Calcium rich diets, very good. They're also rich in aromatic amino acids, so they stimulate the production of IGF-1, which increases the intestinal absorption of calcium, stimulating the synthesis of calcitriol. Always give it with a protein-rich meal. Prebiotics can also be given sometimes. This is some things, diet people ask you, no? So they can actually be fermented, enhance calcium absorption by lowering the pH. Some sources of magnesium you can see, almonds, soya beans, seeds, wheat, germ, millets, etc. Okay, so I'm sure you can't read this. So whenever you find life-threatening or patient is having significant symptoms, IV calcium, then look for medications, acute illness, liver disease, renal disease, check serum magnesium, and then check for PTH. So this is roughly, and if you find that the serum PTH is high and also the phosphate is high, other conditions like pseudohypopara, phosphate ingestion, rhabdomyolysis, tumor lysis syndrome, renal failure. If the serum phosphate is normal or low, vitamin D deficiency, resistant, hungry bone, hungry tumor syndrome. PTH is normal or low, hypopara. So we are treated acutely. Now what about long term? Correct hypo or hypermagnesemia. Then you start them on calcium. See, one important thing is calcium carbonate, 40% elemental calcium. Second thing, don't give more number of tablets at the same time. The maximum absorption, active transport of calcium, the absorption is 500 milligrams. So don't give more than 500 milligrams at a time. So you want to give it, you give more frequently, 8th hourly, 6th hourly, 4th hourly. That's a better way of giving it. So because the absorption is around 80% from the small intestine, and 7 hours, at the end of 7 hours, it's complete. Intestinal absorption is calcium is saturated at 500 milligrams, and therefore higher doses should not be prescribed as it is unlikely to be beneficial. These are some of the calcium preparations. See, in an older people, you can actually give this tricalcium phosphate because it gives calcium phosphate in the ratios what we want. See, hydroxyapatite is made up of calcium and phosphate, and we want to keep it in 1.6:1, that ratio, and you get it from actually the tricalcium phosphate. Other things are given here. So calcium carbonate requires an acidic environment, so it should be taken with a meal. Patients on PPI, elderly with achlorhydria, use calcium citrate, that does not require it. And is also preferred over calcium carbonate in patients with constipation. Many people complain of constipation, and in this they found that it is because of, you change it to calcium citrate. Then vitamin D, if you just give calcium, it's not enough because you require vitamin D also. Especially in hypopara, what happens is you don't have active vitamin D because the 1-alpha hydroxylase enzyme is not used. I mean, it cannot get activated. So that's the reason. So vitamin D, you have to use active vitamin D. What is the dose? 0.5 micrograms to 2 micrograms per day. A rough rule of thumb is if you give 0.25 or rather 0.5 twice a day, it increases by 1 milligram. 2 tablets twice, two times 2 milligram. 3 tablets 2 times is 3 milligram. But this is a rough rule of thumb. Fastest acting, peak concentration in 3 to 6 hours, increases and effect, half-life is 5 to 8 hours. So even if you develop hypercalcemia, you just stop it, they become better. What about vitamin D2 and vitamin D3? They require hepatic and renal transformation for full activation. So may not be that useful in patients with in hypopara rather. Now what about 1-alpha calcidol, which the nephrologists use? It is only 50% as effective as calcitriol. So it's not that potent. So you'll have to give double the dose. Yes. In addition, in all these patients with hypopara, you can actually, a few slides only, you can actually give cholecalciferol supplements because you have other extra benefit, extra systemic effects can happen. So that's the reason you have to give. How do you monitor? Weekly measurements initially, stable quarterly, annual get an ultrasound abdomen and 24-hour urinary calcium because in PTH, it's very difficult to maintain. They'll have hypercalciuria, can develop renal stones. What about phosphate binders? Rarely you will have to use it, more than 6.5. Some studies have found an increased risk of vascular calcifications in these patients. If the patient is not responding to anything, then what do? You can actually give them PTH. Natpara was available, not in India at least, outside. But then it went off because of technical issues. Now you have, now we don't have, we are going the Fortio itself, the PTH injection, but you may have to use it twice because it's short acting. And then now you have what is known as a transcon PTH, palopegteritide, which has been found useful. Yes, what about finally, calcilytics can also be used. People have started using what is known as Encaleret, which is a phase 2B trial. It cons the calcium sensing receptor. I'll end here. Thank you for patient hearing. Yeah.
Thank you, sir, for very informative talk. Now the session is open for question and answer.
The real problem arises in ICU. There you get the acute calcium disorder. Whatever you have said is more representative of chronic calcium disorder. What happens in ICU, if a patient is suffering from sepsis or AKI, develops AKI, the calcium level usually goes down. In some cases it goes.
Correct.
You give calcium there and you also give magnesium. Now the question is, how magnesium helps to restore calcium? That is number one. And second, blood magnesium does not represent the true picture of the magnesium of the body.
Correct.
So how much magnesium you are going to give the patient?
Yeah, so that's right. So both hypo and hypermagnesemia can inhibit the level of, can inhibit PTH release and also PTH secretion. So both can happen in both hypo and hyper. So usually it happens when you have a level below 0.4 millimoles. So that's the level they say at which it actually inhibits that. So both the actions via the calcium sensing receptor. So this is one. Secondly, you can give magnesium infusions 1 to 2 grams over 2 to 4 hours. So that is how you have to give. Once you see that the magnesium levels are more than say 1, then you can actually stop. And if you feel it's coming down, then actually you can give, the patient is stable now, is okay, you can give oral magnesium also. So that's another one. You will have to give an infusion otherwise in this type of patients.
Level. What mechanism magnesium plays in restoring the calcium?
I told you, no, PTH plays a role in calcium metabolism. So what it's doing is, it is restoring the action of PTH. Yes.
I could not hear that. Okay, thank you.
Fine.
Sir, one similar question, sir. That managing the patient of hypocalcemia in emergency or hypokalemia in emergency, many times we see the serum magnesium level is also low, and most of the patient is in hypotension. In that case, is it advisable to give IV or IM magnesium sulfate?
Yeah, so that's a double-edged sword. We'll have to take precautions. See, if the patient has hypocalcemia, You give calcium infusion till the blood pressure improves. And once the blood pressure improves, then maybe you can add the serum magnesium. So we'll have to take the pros and cons and then decide. Let the BP improve, then you give it. So that you can actually do it. Yes. Not aware, sir.
I'm not aware, so I'm asking you.
No.
What is your practice? You use subcut or intranasal?
No, it's subcut only.
Always subcut. Yeah.
Yes.
So
no, see, subcut, see, we also find that if you want to give for its pain lowering efficacy, then both nasal as well as subcut is also okay. So because of the
I'm
CGR.
asking because people use it intranasal, and as he said,
No.
it should be a straight no.
No. Yes, it's no. Yes, agreed.
So if there is no question, we can close the session. Thank you, Doctor.
So moving on to our next session, I'll be inviting the chairpersons, Dr. N.P. Verma sir and Dr. Siddharth Singh sir, to chair the session.
Shall I start? So after calcium disorders, a very important again electrolyte disorders, hyponatremia. We know how much important it is when we are talking about ICU management, or even in our OPD, many patients come with hyponatremia. So how to deal with them, we will know from our expert, Dr. V. Nagesh. I think he will enlighten us on this topic.
Yes, sir. Thank you, sir. And before I begin, I'd like to thank Dr. Santosh, sir, and my dear friend Ved for inviting me. The first time I've ever come to Bihar in my life. And it's always a pleasure exchanging talks with Ganpati, sir, and I should thank him for passing me 13 years ago in my exam. Sir was my examiner. So I won't say no to him. He didn't say no to me 13 years ago. So basically, evaluation and treatment of hyponatremia is always a very difficult thing. In fact, when we were students, these were the acknowledgements, because I had to take the help of so many people for the slides and all that. This is posterior pituitary is one topic which I've never been able to understand properly. In fact, when we were DM students, we used to read the posterior pituitary chapter just before the exam, go into the exam hall and write it, because we'd forget it after 3 or 4 hours. And I think that holds true even today. We've got only one major guideline. This is such a difficult topic that in the last 15 years, we've had only one guideline on hyponatremia. They gave you one guideline in 2014, and after that, they've literally given up. Everywhere, whatever talk you do, this is the guideline you see. EJE guidelines. So basically, why are we so bothered? Even though we don't have a lot of literature on management of hyponatremia, especially from an endocrine perspective. For all practical purposes, nowadays, if you see any evaluation by a nephrologist, a neurophysician, all hyponatremia is assumed to be because of SIADH, and almost everybody will be on a Vaptan.
This is the real clinical practice. The minute you see hyponatremia, you are on tolvaptan. This is actually not true. This is a very underreported electrolyte abnormality, perhaps the commonest electrolyte abnormality, especially in the critical care setting. 30% of hospitalized patients at some point of time or other will present with this, and it leads to significant morbidity and mortality. It is often missed. There is nothing like an asymptomatic hyponatremia. All hyponatremias are symptomatic. The severity of the symptoms changes. And there are multiple situations where you can get this, especially in pediatric age group as well as in the geriatric age group. A typical example, you got a 68-year-old lady who's on progressive drowsiness and syncope. She's on a low sodium diet. Many people nowadays are actually recommending increased sodium, low sodium diet, completely cut down salt from your diet to prevent hypertension. She's on telmisartan and hydrochlorothiazide. People who are on keto diets also generally take in a huge amount of water to prevent the water load. And this can also cause hyponatremia. There are multiple social media influencers also recommend a low sodium diet. And on top of all of this, she's had diarrhea for the past 3 days. She is now presented with some amount of lethargy, does not have any focal neurological deficits, doesn't mean that she has she does not have neurological problems. They are often very subtle in hyponatremia. She's got a weight of 60, BP is low, pulse rate is rapid, flat jugular veins and decreased skin turgor, which indicates hypovolemia, probably because of the diarrhea. The sodium is very low, potassium is low, which again indicates that there was sodium and potassium loss because of the diarrhea. Urea is 92 and creatinine is high, you have a pre-renal failure kind of picture. Many times you had this mild, moderate and severe. Once we had this guideline, this was actually changed to mild, moderate and profound. Mild is between 130 to 135, moderate is 125 to 129, profound rather than severe is less than 125 millimoles per liter. And you have this terminology, acute and chronic. This is perhaps the most important thing we can see about in hyponatremia, because your entire management differs depending on whether the presentation is acute or chronic. But in real world scenarios, it's often very difficult when a patient walks in like this. You can't really differentiate whether the patient has had an acute or the patient has had a chronic hyponatremia. In those situations, it's always safer to go with an initial bolus, 1 or 2 boluses, if the patient has a very severe, profound hyponatremia, and then subsequently treat it like you treat a chronic hyponatremia. Because otherwise, pontile myelinolysis can be a rare and distinct possibility in this cases where chronic is treated like in an acute setting. And a lot of times, the severity symptom is graded as either moderately severe or severe. You don't have asymptomatic hyponatremia, like I said earlier. Moderately severe, they will have confusion, which is one of the commonest presenting features, headache, nausea without vomiting. If it goes into the more severe hyponatremia, then you start having vomiting, cardiorespiratory distress. Patients will be an altered sensorium, they might not be arousable, and they might even end up having seizures. And the GCS score comes down. Many times, don't read the numbers. This is a mistake people do. First, look at the sodium, look at the clinical condition of the patient, and if the patient is severely affected, if the symptoms are more, even though the sodium might not be very low, you should actually go up with an initial bolus and then correct slightly more aggressively. Look for the duration, but like I said, duration is not always available. Previous history and old reports are not always available. Very important, look at the list of medications, including SGLT2 inhibitors, thiazide diuretics and antipsychotics. Thiazides, especially chlorthalidone, is especially notorious for causing hyponatremia and is often missed. And it is one of the commonest antihypertensives used, especially in diabetic patients. This is how you approach. You first assess the volume status. Is the patient euvolemic, hypovolemic or hypervolemic? Look at the osmolality, serum osmolality. Again, there are many fallacies in measuring a serum osmolality. Most of the commercial reports you get with serum osmolality will usually not be correct. Look for hypotonic hyponatremia and then assess the urinary sodium excretion and fractional sodium excretion. Most of the time, if you look at a spot urinary sodium, that will give you a lot of clues as to the diagnosis. Generally, this is the mnemonic we use, VOU, volume status, osmolality and urine studies. These are the classic symptoms and these are the multiple landmark studies which have actually looked at hyponatremia and have eventually come up with the present guideline. This is how the normal brain progresses through hyponatremia. You have an initial normal brain, then you have a normal osmolality, you have a volume depletion, then subsequently you have a water gain. Water shifts into the brain, then you have a low osmolality. The brain rapidly adapts to this by losing sodium, potassium and chloride. Slowly the osmolality comes down. You come to a stage where there is low osmolality, but the tonicity is maintained. Over a period of time, if this water influx persists, then slowly the brain starts getting rid of the organic osmoles. This is when you enter the stage of a chronic hyponatremia. And at this point of time, if you give the patient rapid or severe correction, you end up reaching a stage where you have a greater risk of central pontine myelinolysis or osmotic demyelination as it is called nowadays. Generally, this is how we proceed in the algorithm. First, look at the hyponatremia and you look at the normal osmolality. Is the osmolality low? Is it moderate or is it high? Low osmolality is usually seen in conditions where you have hypovolemia. This can be because of any acute conditions like diarrhea, dehydration or vomiting which was seen in our patient, or it can be because of use of any medications which cause a renal salt loss. The commonest of which are diuretics, ACE inhibitors, some amount of tubulopathies, mineralocorticoid deficiencies including acute adrenal insufficiency, primary adrenal insufficiency and a cerebral sodium wasting syndrome. These are all the causes which can give this kind of a picture. The most common of which are always diuretics. SGLT2 inhibitors are very rare. Then you have euvolemic, which is always headlined by SIDH, but there are other conditions which will also contribute to the euvolemic hyponatremia. Sometimes in the post-operative phases, especially when there is a significant amount of water retention because of cerebral stress. Hypothyroidism, though it is often implicated as a very common cause of hyponatremia, for every 10 microunits per ml rise in TSH, the sodium falls by only 0.14. This is more often than not a major cause of hyponatremia, but when it is coupled with pituitary insufficiency or is coupled with adrenal insufficiency, then that can actually secondarily precipitate to the hyponatremia. Psychogenic polydipsia, where there is a significant amount of water intake, especially in people with schizophrenia. Bihar potomania, where you are taking in only more water without electrolytes, or even what is called as the bread and the toast syndrome, toast and tea syndrome. Sometimes drug reactions to thiazide and ACE. People who are on significant amount of endurance exercises, they have a lot of sodium loss in sweat, but they replace only with free water. And ACTH deficiency, these are the conditions which can cause this kind of picture. Hypervolemic is when there is excess of fluid retention. Solute is retained, fluid is retained, but more fluid is retained. Classically seen in people with heart failure, liver failure, and very advanced nephrotic syndromes. This is how you assess the volume. You look at whether it is hypovolemic, euvolemic, hypervolemic, look at the urinary sodium. Next step you come to is the urinary sodium levels. If the urinary sodium loss is more, you are actually dealing with a renal loss. In a hypovolemic state, if the urinary sodium loss is less, this is actually an appropriate response. You are not losing sodium, but because in general you have lost a significant amount of water as well as sodium because of diarrhea, even though the renal losses are low, you have other situations where you are losing sodium, and this is what actually contributes to the hyponatremia. In euvolemic states, if your urinary sodium excretion is excessive, this can be because free water is not being excreted, which classically happens in glucocorticoid deficiency, which is aided by hypothyroidism, a few drugs, and of course the headliner of all of this, SIADH. If the urinary sodium loss is more in hypervolemia, you are actually looking at a renal failure where the kidney is pushing more of the sodium out. If the urinary sodium loss is less, but still more water is retained, as can happen in cirrhosis, cardiac failure, or in nephrotic syndrome, you can have this kind of a picture of hyponatremia. So this was the case scenario. She had diarrhea, sodium potassium was low. The serum osmolality was pretty low, urine osmolality was very high, and the urinary sodium was 67 millimoles per liter. So the possible causes of hyponatremia in this case were: 1, renal losses because of a thiazide diuretic. They are the most notorious of the entire lot. The low salt diet. She did not have any sodium intake. She was losing sodium. She was not replacing sodium. And on top of it, she had a already renal loss of sodium, and there was a superimposed diarrhea. So she ended up having an acute and chronic hyponatremia. Most of the time, reabsorption of sodium chloride happens in the distal convoluted tubule, and this is what is maximally affected by thiazide diuretics. People have this misconception that loop diuretics actually cause more hyponatremia. It's actually wrong. It happens more with thiazide. Even among thiazides, it's more with hydrochlorothiazide, more with chlorthalidone and less with hydrochlorothiazide. So whenever you encounter somebody in your OP or in your inpatient with hyponatremia, first stop, look at the diuretics, look at the antihypertensive, stop the antihypertensive. Amyloid, mannitol, SGLT2 inhibitors are not actually major causes. SGLT2 inhibitors on their own rarely favor cause hyponatremia, but they can potentiate a hyponatremia which is caused by chlorthalidone, especially chlorthalidone. So you always have a warning that if somebody is on chlorthalidone, be a bit circumspect about using SGLT2 inhibitors. Then this comes to the question, is it acute or chronic in this case? Most probably this is chronic with a superimposed because of acute diarrhea, but because of reasons of safety, it's always better to assume that this is a chronic case and deal with it accordingly. This is generally how it happens. The cutoff is 48, less than 48, more than 48. The primary risk is cerebral edema in acute and osmotic demyelination if you supplement very rapidly in the chronic cases. Symptoms are often mild in chronic because the patient has compensated to some extent. The main problem is overcorrection injury, so you have to correct gradually. The first are, there are differences between the European and the British guidelines. Generally, if the patient has severe hyponatremia, you give them 100 to 150 ml of 3% hypotonic saline over 20 minutes. Check serum sodium again. If it has not corrected or reached a safe path, again correct it. If it has not increased by more than 5 millimoles per liter, again correct it, give another bolus. You can give up to 2 to 3 boluses. Once you have reached a 5 millimole increase in sodium, stop infusion and then you have bought yourself enough time to assess for the cause of hyponatremia. If there is no improvement in the first hour, check for other explanations because there can be other causes for cerebral symptoms other than hyponatremia. The patient might have had a stroke, the patient might have had some infection, might have had meningitis. You should also look for other causes. It can be because of adrenal insufficiency. All of these things should be controlled. And serum sodium should never rise by more than 10 millimoles per liter during the first 24 hours, including the 5 millimoles you have given as a bolus. The total correction should not be more than 10. Some studies actually said that it should be 6, but recent studies have said that we can be a bit more aggressive with correction because mortality increases if you correct too slowly. And stop sodium infusion if the sodium level has gone beyond 130 and then you are dealing only with fluid restriction. These are the differences between the European and the British. The Europeans are slightly more aggressive, you give bigger boluses. And democlocycline, urea or Vaptan are second line. European guidelines are not very aggressive with Vaptans as opposed to the American guidelines. They recommend against lithium or democlocycline. They usually use urea loop diuretics. The main problem with the current guidelines, even the 2014 guideline is, there is too much emphasis on the clinical assessment of the volume status. And more often than not, most clinicians diagnose SIDH. Like I've said, SIDH is actually a diagnosis of exclusion, but people diagnose SIDH, start Vaptan and then go ahead with further management, which should not be done. Even the recent guidelines actually do not even endorse the term SIDH, but because that has come into common parlance, people are still going ahead with the term SIDH. This is how it works. It is a diagnosis of exclusion. This is what people have to remember. Exclude hyperglycemia and other causes of non-hypotonic hyponatremia. Look for acute or severe symptoms. If there is acute symptom, don't diagnose anything. First correct with saline, then you go ahead with the symptoms. Look at the urine osmolality, then look at the urine sodium. If the urine osmolality is low, if the urine osmolality is normal and the urine sodium is high, inappropriately high urine sodium excretion is happening in urine, then that is the condition, situation, and diuretic is ruled out, then only you have to go ahead with a diagnosis of SIDH. More often than not in clinical picture, whenever you see any patient who presents with hyponatremia, it will always be a euvolemic hyponatremia. Hypervolemic is less common. Hypovolemic is only seen in acute situations. In all of these situations, clinical assessment will not give you a good picture. You should always look for a lab which has a good urinary sodium. Sodium is the major contributor to plasma osmolality, and we have problems with proper assessment of urinary sodium and serum osmolality. So many times in emergency situations, a surrogate marker we use is specific gravity. If you got a urine specific gravity of 1.005, that approximately equals a urine osmolality of 100 milliosmoles per kg. Generally, the rule of the thumb is 35 into last 2 digits of urine specific gravity. For instance, if the urine specific gravity is 1.010, you're probably looking at a urine osmolality of 350 milliosmoles per kg. This is how you assess the urine osmolality. Look at the urine excretion, if the urine sodium excretion is more than 30 millimoles per liter, consider diuretics. If all of these conditions are ruled out, then only you look at SIDH. And as far as management is concerned, I have told you initially you give a bolus, then you correct slowly. And always rule out conditions like hyperglycemia, hyperproteinemia and hypertriglyceridemia. So is the scare of osmotic demyelination, should we be correcting more aggressively, because recent studies have actually shown us that if we correct slowly, there is more mortality. If the urine serum osmolality, if the serum sodium is more than 120 milliequivalents per liter, you don't have to be very scared about osmotic demyelination or Pontin myelinolysis. But if it is less than 120, caution is required even today, because this condition can happen, especially if the values are less than 105. You have to be very slow. And also in people who have hypokalemia, which indicates that you are probably dealing with diarrhea or a vomiting which has caused both hyponatremia as well as hypokalemia, alcoholism, chronic liver disease, and people who are malnourished. Most of the treatment guidelines have actually said that we should not be so circumspect about treating, but it depends on the rapidity of treating. Correct less than 6 millimoles per 24 hours, your mortality is actually more. If you correct between 6 to 10 or even at the more than 10 millimoles per 24 hours, your mortality increases. So you have a sweet spot between 6 and 10. In the first 24 hours, you can actually go up to 10, unlike in the earlier guidelines which recommended not correcting more than 6. The mortality improves if you have a fairly more rapid amount of correction, but make sure that you are not dealing with a very chronic case. I'll give you another typical example. A 30-year-old male, hyperpigmentation, loss of appetite, vomiting. This is the BP. This is the cortisol, ACTH. These are the sodium and potassium levels. What is the diagnosis in this case? You are looking at a primary adrenal insufficiency. How many in this room would use Vaptan in this case? Absolutely contraindicated. The only thing which works in this case is you give them glucocorticoid supplementation and some mineralocorticoid supplementation. That should about match the case. It is chronic hyponatremia due to adrenal insufficiency. Just give the patient oral hydration, prednisolone, fludrocortisone and salt supplementation. Another case, you got a 40-year-old male, history of pulmonary tuberculosis. Hyponatremia was managed as SIDH with fluid restriction. He is presented with severe vomiting after starting anti-tubercular treatment. BP is low, no pedal edema. Sodium concentration is in the profoundly reduced range. You are dealing with an acute on chronic. He had a chronic SIDH because of tuberculosis. Once you started ATT, he again developed vomiting and he developed an acute on chronic hyponatremia. The symptomatology is severe. You are again going to treat him with 3% NaCl and then subsequently fluid restriction. You are not going to use a Vaptan in this case. This is how these molecules work. In hypovolemia, Vaptan should not be used. Adrenal insufficiency, it should not be used. It causes more of aquaresis, that is why you should not give it in dehydration. Never for an acute rescue, used only once you diagnose an SIDH. These are all the antagonists which we use in clinical practice. The commonly used one is tolvaptan. They act by aquaresis, which is free water excretion. Severe hyponatremia, again you run a risk of cerebral edema and uncal herniation. Never give tolvaptan. Hypotonic saline is always the best. So most important key takeaway is you should have a rational use of tolvaptan. Only in SIDH and in a few cases of hypervolemic hyponatremia, not indicated in acute or severe hyponatremia. It is a secondary step. Acute is always hypotonic saline. Over a correction risk is there and it should always be monitored and start with a lower dose and then escalate. And sometimes there are reports of hepatic toxicity which needs monitoring. This is the decision tree which you can use when you are using a Vaptan. Like everything else in hyponatremia, it's quite complicated. Some studies have actually shown, I'll just finish, only 2 more slides. There can be some amount of elevation in liver enzymes. So if somebody is on tolvaptan for a long period of time, in addition to monitoring the sodium, you should always monitor the liver enzymes. And in people with chronic liver disease, it's probably safer not to use Vaptans. Cerebral salt wasting is what we are traditionally taught, but it's not as common as we think it is. This is one more interesting case. A 41-year-old who presented with fatigue, headache of 5 days, abnormal involuntary movements, admitted, low sodium, Urine osmolarity was 412 and urine sodium was 48. So you had more of urine sodium loss. When you actually had a look at it, TSH was low, free T4 was low, cortisol was low. You are looking at a combined case of secondary adrenal insufficiency and hypothyroidism. This was a case of lymphocytic hypophysitis. This again does not require a Vaptor. Once you start the patient on oral glucocorticoid replacement and after 24 to 48 hours, you replace thyroxine, you will actually have a very good diuresis and the patient will respond to therapy. And the sodium will be corrected. Whenever you want to use sodium, especially in a younger patient, this is the rule you use, multiply patient's body weight by the desired rate of correction. For instance, if you have a 60 kilo patient and you need a 1 millimole per hour rise in sodium, this is for the infusion after you have given the bolus. Infuse 60 ml. For 2 millimoles, infuse 120 ml. For half millimole, infuse 30 ml per hour. This is how you correct the infusion rates. If you are on 3% saline, after you have given the bolus, you monitor every 2 to 4 hours. AVP antagonist in the emergency setting, every 68 hours in the first 48 hours and subsequently probably when you are on therapy, long-term therapy, probably every 2 weeks or monthly. And stop 3% saline and the Vaptans when the symptoms have abated or sodium is more than 120 and the safe rate of correction has been reached. Subsequently, management is entirely by fluid restriction because it is the safest method of monitoring or managing a case of hyponatremia. To conclude, hyponatremia is much more common than it is usually made out to be, and it is also quite common in the community, especially in the elderly people, but it is often missed. We need to have a high index of suspicion because there is no true asymptomatic case. If you actually go deeper into the case, you will find out that many of these patients have gait disturbances and confusion and memory losses. You need urgent, careful and safe treatment which is within limits. Don't over-infuse sodium, don't give enthusiastic sodium infusion because you will create a much bigger problem for the patient. And Vaptans are a new class of drugs, but be a bit conservative in using Vaptans, and this is something which cannot be routinely handled at the general physician level. You will always require, in many cases, an involvement of an endocrinologist, a nephrologist or a neurophysician whenever you are starting Vaptan, and it needs more monitoring. Cannot be used in unreliable patients. To summarize, sodium is perhaps the most important ion. This has been in our body right from the time we evolved from fish, and this is what keeps us alive. Endocrine causes are usually subtle. The commonest ones we see in the community are diuretics, but endocrine causes are subtle and they always need to be ruled out. Not every case is by default SIDH. It can also be adrenal insufficiency and very rarely hypothyroidism. With severe hyponatremia and risk factors for demyelination, always be more conservative when using this ion. That's it. I come to the end of the presentation, and if there are questions, I'd like to take them.
Very thank you. I think this talk has simplified the evaluation and management of hyponatremia. Another thing I want to add or want some discussion, there is an entity psychogenic polydipsia, but very often we come across habitual polydipsia. How often do you see this where people drink excessive water because of the knowledge that excessive water drinking is good?
Yes.
So how often do we come across as a cause of hyponatremia?
Sir, usually this doesn't happen until your countercurrent exchanger gets washed out. Normally till I think 3 to 4 liters, most people will not have it. This comes only because people have these health facts that you have to take more water, 6 to 7 liters, that is when this happens. And there is another recent entity which has, recent particular group of people which have come up. Many people who are on keto diets are being advised by Instagram influencers that there is no need of restriction of fluid. People with CKD are actually asked to take in 6 to 7 liters of water a day. At least this is a phenomenon which is very common in my state because they are very big on keto diets. Nephrologists, actually these people present more to nephrologists than to us. Many of them are actually reporting that patients are coming with increase because most of the time nephrologists will put these people on fluid restriction. The Instagram influencers have been telling them that this is all a myth. You can drink any amount of water. The more amount of water you drink, the more your creatinine is flushed out. People are presenting with this kind of a picture and that has become a problem. But generally, I don't see a lot of people who present with this water fat because they start for a few days, then they get tired of drinking water. After a month or so, there are most of the time people I have seen are psychogenic even in children. A few children I have actually seen who present with this condition. Common presentation I have seen with these children who drink in more water. I have had maybe 4 or 5 cases in the last 1 year is, the mother has a second child, she starts giving more attention to the child. This guy feels deprived, he wants to attract the attention of the mother, he starts drinking more water. I have typical 3 or 4 cases who are presented with this kind of picture. The minute the attention shifts and the water is restricted, they come back to normal. It's actually very easy to treat. Once you start restricting the fluid, increase the sodium intake, the kidney readjusts itself and you will have a resolution.
Your first slide caught my eye.
Which one, sir? Yeah.
First slide which you presented. There was low sodium, critically low sodium, critically low potassium. Which iron you are going to treat first?
Ideally, we'll have to give both.
Both you ideally, but
Yes.
you know both cannot be treated.
So I would actually go with sodium first.
I will differ with you.
Yes.
Because if you go with sodium,
then there will be
the
potassium
potassium will
diuresis.
shift and the chances of cardiac arrest is more. So it is first you correct the potassium because the level of potassium
2.5.
is
I think it was 2.5,
It
yeah.
is a critical level where in 2.6 even the patient goes for the cardiac arrest.
Yes.
So the potassium has to be corrected first, then you can go for the sodium.
Yes,
That
you're
is
right.
number one. The second question is, when you suggest or can we add loop diuretic to tolvaptan or not, or if we can, in which condition?
So loop diuretics actually can be used in some situations where you have hypervolemia. Generally, we use tolvaptan in hypervolemia, especially in some amounts of cardiac failure. You can actually add a loop diuretic. Because by the time when you use a loop diuretic, by the time it reaches the medullary countercurrent multiplier, there is already maximal concentration. So there will be no further reabsorption of water when you add a loop diuretic. So I think generally in that situations, you can add a loop diuretic.
Thank you. Any questions?
Very nice talk. It's a very difficult talk. I find it very difficult to cover it in 20 minutes. I would just give one word of caution with 3% NaCl infusion. I have seen a couple of cases of osmotic demyelination in my career. It's a disaster. You can do nothing for the poor patient.
Yes.
So when people give 3% NaCl, they should have the facility to check serum sodium every 2 to 4 hours. First of all, what people do is they will start the 3% NaCl over 8 hours and they run away. Something should not be done. And to me, what I was taught in BARDS, every hyponatremia that you see is always a chronic hyponatremia
Yes.
unless and until you've
Proven
seen
otherwise.
a sodium value within last 48 hours. There's nothing called acute on chronic.
Yes.
Once it's chronic, you should be very, very careful with your 3% NaCl. This is the teaching I have had. So I'm sharing my teaching with you. Your comments.
This is an experience I've had because I come from a pediatrics background, sir, MD pediatrics. We had a lot of these conditions. Especially diarrhea is very common in the pediatric age group.
No, but you have a sodium value within 48 hours to confirm.
We don't have sodium values. We always make sure that we supplement very slowly. We used to be very careful with hypertonic saline because spontaneous myelinolysis is even more commoner in children.
Fair
And
enough.
once that sets in, the patient will be in vegetative state for the rest of his life.
It's really, really sad if you get 1 CPM. I would only use, I'll tell you my experience, people may disagree with me, I would only use 3% NaCl if I see somebody in ICU who's comatose or convulsing. Other than that, sodium 106, if patient is in a ward and is awake, I would not be giving 3% NaCl. If anybody wants to contradict me or debate with me, I'm happy.
But if you have the facilities to monitor, you can perhaps do it.
Which hospital has, even the best hospitals in India don't have 2 hourly sodium. You need residents to run. No?
When we were students, we used to do. Corporate, you won't.
So you and I are different. Yeah?
Yes.
We are endocrine trainees. We are talking about general wards where they're seeing 200 patients. They will just start the drip and go. So that's where the CPM
In that
happens.
scenario, I think it would be dangerous. Yeah, sir.
Hello. Sir, you rightly said that most, if not all, patients come to our clinics, they are already on tolvaptan or any other vaptan. Sir, how long we should stop this vaptan prior to doing the urine parameter or other parameter to go for?
First of all, if the patient is already on a vaptan, I would be a bit circumspect about stopping it in the first place.
Okay.
So even if you stop it, perhaps even if you can gradually withdraw. Generally what we recommend about using Vaptans is I use it very, very carefully, almost minimally.
Okay.
You stop it. Generally fluid restriction works in a majority of cases. If at all somebody is on a Vaptan and you want to stop it, you have to do it gradually. Suppose let us assume he's on 30. You can't directly go from 30 to 0. You'll have an immediate rebound rise in the, he will not have an aquaresis and he'll have a rebound rise in the free water fluid overload and he will again end up in hyponatremia. You'll have to bring it down slowly, but probably stopping it for 48 to 72 hours should be good enough.
Okay, for 2 to 3 days usually that
at least. But you have to do it slowly. You cannot suddenly take them off a Vaptan. Okay. Starting it is very easy, taking it off is not all that easy.
Okay, thank you.
So I think it was a very good session and we can conclude it now.
Thank you.
I would request the speaker and the chairpersons to proceed for felicitation. For the next session, I would like to invite the chairpersons, Dr. Anshuman Kumar sir and Dr. Rakesh Sharma sir.
Good afternoon, everyone. It gives me immense pleasure to invite on stage Dr. Rana Bhattacharya, sir. Apart from being a great doctor, a great academician, an excellent orator, he is a teacher par excellence. I have had the privilege of being trained under him during my DM endocrinology days. He is actually an endocrine chat GPT. Whenever you are facing complex clinical situations, you have confusing clinical guidelines, difference of opinions, you just talk to him and he gets your answer every single time. Sir, it's a matter of pride and privilege for me to chair one of your sessions. It's actually one of the highlights of my career. Thank you, sir.
Thank you, Anshuman, for this compliment, and thank you, chairpersons, and thank Team Bendocon for this invitation. So I won't delay you from the lunch that is awaiting you. I'll deal with a topic that is something that we commonly deal with, that is delayed puberty. And I won't go into detail of the approach, I'll focus more on management. So whenever we talk about delayed puberty, there are some confusion regarding various aspects of puberty, which actually makes the decision a bit difficult sometimes. The normal puberty timing, it varies among population and even it has changed over time. The normal puberty onset has become bit earlier than before. A very common condition of delayed puberty is constitutional delay in growth and puberty, which can often be confused with a case of actual hypogonadism. On the other hand, it has been seen that around 1/3 of the patient with actual organic hypogonadotropic hypogonadism can actually started to have puberty at normal time but then gets arrested, so further lead to confusion. And a patient with hypogonadism can shift to spontaneous recovery for a variable period of time and then again relapse back to hypogonadism. So for complicating the picture further. So with these complications in mind, let's start directly what the importance of puberty is. So puberty actually is a process where the maturation of gonads occur with acquisition of secondary sexual characteristics, and that is associated with growth spurt as well. Ultimately leads to adult height, pubertal features and fertility for that individual. I won't go into the detail of the sequence of pubertal event in an adolescent, but typically the girls, the earliest sign is either height spurt or development of breast bud, and in boys, again, height spurt or testicular enlargement. Now, how to define a delayed puberty? In girls, now it's practically speaking, if the secondary sexual character doesn't appear by 13 years, or in boys by 14 years. In girls, primary amenorrhea is a spectrum of delayed puberty. When we say that when by 13 years there is non-development of secondary sexual character, or if there is secondary sexual character, we wait up to 15 years to define the case as primary amenorrhea. And as I was saying, that arrested puberty is also a spectrum of delayed puberty. How to define it? When there is no progression of pubertal features over a period of 2 years, or once puberty starts, it's not completed by 5 years. So that is called arrested puberty. So what are the causes of this delayed puberty? Now we typically divide delayed puberty in 3 groups. Number 1, it's constitutional delay. I talked about this in brief. Then hypogonadotropic hypogonadism. Now in these 2 conditions, the gonadotropin levels are low or normal, which is inappropriate for the low levels of gonadal steroids. And the third category is hypergonadotropic hypogonadism, where we find the gonadotropin levels are high and sex steroid levels, that is estrogen and progesterone, are low. Now this is one of the algorithms. This is oversimplified. Actually we do not follow this every time, rather we rely more on our clinical examination. But whenever we see a pubertal delay, we typically measure the gonadotropin and the sex steroids to define or to rule out the presence of hypergonadotropic hypogonadism. And then if gonadotropins are low or no normal, then we try and differentiate between true hypogonadotropic hypogonadism or constitutional delay. Coming straight to management. Now, while managing a patient with delayed puberty, we should consider few important points. First, we need to maximize the height potential. That is extremely important. And psychological morbidity is also important because we are dealing with an adolescent, so peer pressure is extreme. Bone health is important because adolescence and early adulthood are a very important period of mineral accrual in bones. Future fertility is also important, and the appropriate treatment, how to give a particular management for delayed puberty, definitely it depends on the condition itself. So let's start with CDG, peer constitutional delay in growth and puberty. So it's the commonest cause of delayed puberty in both genders. Of course, it's much more common in boys. However, if you look at the all cause of pubertal delay in girls, this is the commonest one. Now, how to treat these patients with constitutional delay in growth and puberty? One of the way to do it is by expectant observation, because they are spontaneously they enter puberty at a later age. Second is gonadal hormone therapy, and there are other therapies as well. Now, expected observation is something that used to be practiced maybe 2 or 3 decades earlier, but nowadays we do not prefer this treatment because of many reasons. Number 1, we know that these patients will enter puberty, but when they will enter puberty is very unpredictable. So average time is about 3 years, and the psychological stress of the undeveloped puberty is so high in this adolescent period. So this approach is not followed nowadays very often. And third, as I was saying, that puberty is a very important period of bone mineral accrual. So effect of bone mineral density is also very important. Now, the second mode of therapy is gonadal hormone therapy, and this is something that we prefer nowadays, because if we use this properly, it can start growth spurt and sexual maturation without undue advancement of bone age. Now, you know, with a rapid advancement of bone age, the final height may be curtailed. But here, if we appropriately use the gonadal hormones, the final height is not compromised. And most importantly, it improves psychological well-being. Now, how to start this therapy? Let's start with boys because it's more common in boys. Typically, we start when the boy is older than 14 years and testicular volume is less than 4 millimeter and total testosterone level is less than 100 nanogram per deciliter. Now, why these cutoffs are important? Because if the testicular volume is more than 4 and testosterone level is more than 100, the boy is expected to enter puberty within the next 6 months to 18 months. So, there you can wait and watch. There is no need to start gonadal hormone therapy at this point. So, if these criteria are fulfilled, then you can start with gonadal hormone therapy. One of the common mode of therapy we use is an injectable form of testosterone, like either enanthet, propionate or mixture of the testosterones called, it's available as Sustanon. So, whatever is available in your area, you can start with that. Typical starting dose is 50 milligram every 4 weeks for a period of 3 to 6 months. Then we wait for 3 to 6 months. And then if there is no development of further progression of puberty, then we repeat the course with 50 to 100 milligrams again for 3 to 6 months. And then we stop and wait for puberty. Now, if the patient has true CDGP, they spontaneously progress to puberty after that. But if they do not, then always consider whether you are dealing with a case of hypogonadotrophic hypogonadism, not a case of CDGP. So, there is an alternative to this injectable as well, although oral testosterone undecanate is previously was available like in the brand name of Andriol Testocap. Now they are not very widely available, but you can start with 40 milligrams and then gradually increase to 80 milligram twice a day and continue for a period of 1 year, and then you follow these patients up. Other than gonadal steroid or testosterone, you can use oxandrolone, although it's not widely available in our country. I do not have a personal experience with this because this particular drug does not help you with progression of pubertal features. They only help in height acceleration because these are anabolic steroid and these are non-aromatizable. So, because it's an anabolic steroid, it promotes growth, it does not induce pubertal change, and it does not advance bone age because it does not get converted to estrogen-like components. Another agent, that is aromatase inhibitors, that you can use along with testosterone to increase the final height, because aromatase inhibitors, they prevent conversion of testo to estradiol, and estradiol is an agent which actually causes advancement of bone age and rapid fusion of the epiphyseal cartilage. However, there is a concern with bone health, and in the context of CDGP, typically we do not use this agent. So, this is all about boys. Now, what about girls? Before starting treatment, there are some prerequisites as well. Particularly, the excessive exercise, eating disorders and excessive psychological stress should be ruled out, because these are the common differentials of CDGP in girls. So, they can lead to functional hypogonadotrophic hypogonadism and delayed puberty. So, these should be excluded, and once those are excluded and we are not thinking about hypogonadotrophic or hypergonadotrophic hypogonadism, we should start therapy for CDGP in girls. Typically, we give estradiol valerate, that is most commonly available now. Typical dose is 5 microgram per kg per day for 3 to 6 months. Now, practically speaking, the tablets are available in a 1 milligram strength. So, the dose comes to around 0.25 milligrams per day. So, what we do practically, we break the tablet into half, so it makes it 0.5, and we give it every alternate day. So this is a practical way to use this drug. And again, just like boys, after a course of 3 to 6 months, we wait for another 3 to 6 months. If there is no spontaneous progression, we repeat with a bit higher dose of 10 microgram per kg per day and wait for another 3 to 6 months. And still, just like boys, if there is no further progression, we should consider hypogonadotropic hypogonadism. And alternatives are also there, like oral conjugated equine estrogen. We do not prefer these agents, popularly known as Premarin. And transdermal estradiol is also available. Now, regarding transdermal estradiol, the problem is that the patch is not very suitable for our climate, and the gel that is available, they usually contain higher dose of estradiol, so it's very difficult to give a lower dose. So we mainly stick to the oral preparations. Now this is all about CDGP. What about true hypogonadism? Now here the principle is to mimic the normal puberty. So we typically start with low dose, we gradually build up to full adult dose. Usually we start treatment at around 12 to 14 years in boys and 12 to 13 years in girls. Now here is the question that in boys the normal puberty starts at 14. So why we may start at 12? We use this at the age of 12 when there are some red flags of conditions like say hypogonadotropic hypogonadism, where we have some features like say cleft lip, cleft palate, undescended testes, all those point towards a congenital isolated hypogonadotropic hypogonadism, or have a large pituitary tumor, or rather the more common is suprasellar tumor like craniopharyngioma, which operated and underwent radiation therapy. Then we may start early with a very low dose to mimic normal puberty. Similarly in girls, if they are diagnosed early, we can start at 12 to 13 years. And gonadal replacement therapy, the starting dose is just like as I have described in CDGP. So we start with 50 milligram every 4 weeks for 6 to 12 months, and then we gradually build it up. And ultimately we titrate the dose depending on the peak and in sometimes trough level of testosterone. If you are interested in how to do this practically, we can discuss it in the Q&A session. Again, regarding transdermal therapy, the patch is not available in India. Gel, again, in early puberty, the testosterone gel, the dose is relatively higher. So when with the injectable preparation, a mid-pubertal range is achieved, then sometimes we transfer to gel. What about gonadotropin therapy in hypogonadotropic hypogonadism in boys? There are many data now that we can start with HCG, recombinant FSH, to develop or to increase the testicular volume. Sometimes FSH can be given prior to HCG, sometimes we can start those agents together. So they seems to be more physiological rather than testosterone, which directly acts on the secondary sexual features. However, there are some problems as well. These are very costly therapy. Very few people can actually afford this, and more frequent injections are needed, typically thrice a day for both HCG and FSH. So these are the typical regimen that can be followed if you start therapy with gonadotropin instead of gonadal steroids. Now in girls, again, just like CDGP, we start with a very low dose and then gradually build up to adult dose, which is typically 3 milligrams per day. Transdermal estradiol we can use. Patch again is very difficult, as I've said, using in India. Again, when the higher dose is reached, you can use a gel, because estradiol gel is also available. So it depends on your patient preference. Now, it is very important not to forget about progesterone, because progesterone is important for many aspects, particularly once the breast stage 3 or 4 particularly is reached for further breast development, particularly for the development of nipple areolar complex, and to increase the diameter of breast, progesterone is very important. Plus, we need endometrial protection, because unopposed estrogen action can lead to endometrial hyperplasia and potential malignant changes in the endometrium. So typically we start MPA, medroxyprogesterone acetate, when the girl is in breast stage B4 or there is breakthrough bleed. We start for 1 to 5 days per month and we gradually increase to day 1 to 14 each month. We can also use micronized progesterone and we can monitor biochemically, although it's not a routine. Now these are the typical situation, but what about some special situation? When there is, I was talking about the reversible condition, that is some IHH or idiopathic hypogonadotropic hypogonadism can spontaneously reverse. So what we do in males, we should follow up with testicular volume. And if is there any suggestion of increase in testicular volume while the child is on testosterone, we should interrupt the testosterone therapy, monitor the patient with gonadotropin and testosterone level. If it is increasing, we can stop the drug and follow up for recurrence. Functional hypogonadotropic hypogonadism, we should always treat the underlying cause, although we need temporary therapy with gonadal steroids. In case of hypothyroidism, if you just treat hypothyroidism, spontaneous puberty starts. There is no need to give gonadal therapy or gonadotropin therapy. Some cases of hemochromatosis may be reversible, but many a time we need to give therapy, particularly in patients with thalassemia. Klinefelter syndrome, sometimes we start therapy once LH level starts rising, which often occurs before starting of lowering of level of testosterone. So before testosterone comes down, sometimes we start testosterone therapy preemptively. And in some patients who underwent radiation or surgery may need simultaneously the growth hormone therapy. So to summarize, whenever possible in a patient with hypogonadism, we must try to have a etiologic diagnosis first, which can be treatable condition itself. So the management strategy changes. When to start your therapy and how to gradually build up depends on the etiology and age of the diagnosis. Psychological impact of delayed puberty is immense. So even in a patient of CDGP where we know that there will be reversibility, we treat with short courses of gonadal steroid, and therapeutic intervention should not be unduly delayed. Thank you for being patient listeners.
Thank you, sir, for such a composed presentation, and you justified every word of introduction by Dr. Anshuman.
Thank you.
And actually, I'm a pediatrician, so my purpose was to know about when to interfere in cases of delayed puberty, and we all know that we should first of all exclude CDGP, and then only we can go for investigations and further management of a particular patients. The main purpose of pediatrician, actually the cases go first hand to the pediatricians.
Absolutely.
To our clinic. So we have to identify what is CDGP and what is pathological permanent hypogonadism. So what we can do in that cases, which come to us, and how we can identify those cases and refer them to suitable centers.
Right. A very important question. Actually, due to want of time, I couldn't go into the approach of different cases. It's a very important differentiation to make whether we are dealing with hypogonadotropic hypogonadism or CDGP, and it's very difficult. Now there are certain features like number one, if there are some red flags of hypogonadism, as I was saying, that if there is undescended testis, if there is micropenis, if there are some features like midline defects, we should always think about we are dealing with hypogonadism. Plus, if there are some features of CNS manifestation like raised ICT and all. So again, we think of permanent hypogonadotropic hypogonadism. If those features are not there, and if there is a family history of delayed puberty, then we should think about CDGP. Now there are some tests. We can do gonadotropin stimulated testosterone levels in boys, or we can have tests like AMH and Inaugural B. For that we have different cutoffs, but then again there can be some overlap. So there will be some patient where it would be very difficult to differentiate between these two. So what to do in this case? Always start gonadal hormone therapy. So as I was saying, you just start like CDGP. So wait to give 3 to 6 months and then you wait. If there is no progression, give a second dose. Still wait. Still no progression. Then you consider this is a case of hypogonadism, not CDGP. So in difficult cases where you are unable to differentiate, you should give a therapeutic trial like thing. Okay.
Any question from audience?
Yeah, so you can treat with human menopausal gonadotropin, which is bit cheaper. Of course, we do use it because some patient cannot afford recombinant FSH.
Thank you.
But please remember the LH content of this is inadequate, so you have to give HCG along with that. What I do, I give both those drugs together. But there are evidence of all kinds of things, like starting FSH 1 hour before, starting FSH after 1 hour, and all those things. But I personally, whenever I treat with gonadotropin, particularly when the testicular volume is lowish, I start with both of these together. In adolescents, of course. In adults whom I am treating for infertility, the situation is different.
Yeah, because there are a series of studies from Richard Quinton.
Yes.
Where actually you start FSH first. If the
Yeah, as I was saying, that there are some studies, mainly by Richard Quinton from UK. They have started FSH first, waiting for 1 year, and then start.
One the volume. Your comment on that? Have you tried that out?
I haven't tried that because see, FSH is bit costly. That's number one, and number two, they have come to us for pubertal features, and only having eldest testicular size, it doesn't satisfy the patient. That's my practical take on it. So it's better to start with 2 drugs together. That's what I follow.
Yeah, because my observation was that if you actually start both of them together, the final sperm count actually ends up being lesser. If you start them on FSH first, because the basic way it works is LH works to LH essentially helps you in differentiation of the sperm.
Yeah.
FSH helps you in increasing the sperm count.
Definitely. Definitely. Yeah.
So because
scientifically that is all right, but again I said kind of there are studies regarding all those 3 approaches, and there are evidences in all those 3.
Have you given testosterone in anybody along with this?
Yeah, because those who are particularly in adults, of course I do. Because of their potential sexual dysfunction, and it's very difficult to maintain testosterone in the HCG in a wide number of patients. But in adolescents, I typically start with HCG and then wait. I do not start testosterone automatically along with HCG. But in adults, in most of the situation, yes.
You can use. You're using it, right?
Sir, is there any role of gonadotropin therapy in female pubertal induction, sir?
See, for females, gonadotropin therapy is not very practical. There are some studies with GnRH as well in pumps, but gonadotropin therapy to induce puberty is extremely difficult proposition. Kind of how to go about that. So there is, I am not aware of any such studies, and I have never done it. And I do not know anyone who has done it. So we always go with gonadal hormone therapy. That is very simple, starting with estradiol and then add on with progesterone. Now, whenever we need fertility, then of course gonadotropin therapy is important.
Sir, so with gonadal hormone therapy, what is the outcome of that ovarian size? That is okay for?
See, regarding ovarian size actually is not a concern. Our main concern is uterine size, which is a particular concern in Turner patients and others, because what we have seen that if we are not properly giving the estrogen as well as progesterone, we should also monitor uterine size, because even in Turners nowadays many of the girls growing up, they are marrying and they are going for IVF therapy. So adequate uterine volume is very important. So nowadays we always monitor for uterine volume. But ovarian volume is not a concern, because whenever you give gonadotropin later in life, usually the ovulation occurs. But our main concern is uterus rather than ovaries.
Thank you so
much. Yes, please.
Your institutional experience about the cutoff of inhibin B, there are multiple data, 35, 65, 111.
I know.
And the second one, your clinical data on the absence of axillary hairs, pubic hairs in CGDP versus hypogonadotropic hypogonadism. So any data of yours?
Right. What we have observed regarding pubic and axillary hair, there is no clear-cut differentiation. But other features, as I have said, like micropenis and undescended testes, definitely think about hypogonadism. That's number one. Number two, regarding inhibin B, in our assay, our lab, inhibin B assay is not available, so you have to send it outside, and we typically use cutoff of 35. So that's what we use.
Thank you, audience. Actually, puberty is not simple growth. It is a finely tuned process and interaction of different hormones. So there is a lot of scope of discussion always. So thank you, speaker, for such a wonderful presentation, and audience for the.
Thank you.
I request the speaker and the chairpersons to proceed for felicitation. Now we'll take a break for lunch. Lunch for delegates are on first floor, Utsav Hall, and for faculty is on 6th floor, 601. We'll restart our session at sharp 3:30 p.m. Thank you.
And for this, I invite Dr. Anil over the dais to chair the session, accompanied by our vibrant Priyanka. And I'm sure everybody is braced up for the post-lunch session. Thank you.
Good afternoon, everyone. So we'll be starting off with our next session. For this, I would like to invite our speaker, Dr. Neeraj Kumar Agrawal, sir, to the stage.
Good afternoon, everybody. I am thankful to Dr. Santosh, Dr. Ved, Bihar Endocrine Society, and Sanofi for allowing me to interact this afternoon. We know that we have a barrage of new molecules which have been coming up for control of diabetes, and further it can be used for different forms of obesity. So we can approach the diabetes in a different way together with the old molecules and the new molecule together. So we know that India has a good number of people with diabetes. It's all known to us, and we have seen umpteen number of data that we have how much burden of it in the country, and we have been dealing together, and we can see that the number of people who are diagnosed and undiagnosed are huge. So this is a scenario in our patients, and we have still unmet needs in the management of diabetes. So we can address some of the situations with then we have using oral drugs as well as insulin, and we try to improve the control with addition of drugs, maybe as a insulin also. So this could be a form of basal or basal bolus, and it could be basal with new molecule of GLP-1 receptor agonist, or this may come as a fixed combination. So we mostly come with a progressive addition of firstly we can add insulin to the sulfonylurea or insulin synthesizer drugs, and then we may shift totally to insulin, but in between we may have a potential to add a drug which can increase the endogenous production still, So we have a GLP-1 RA where it can affect with endogenous production as well as decreasing weight. So this combination of insulin and GLP-1 RA can be used as a combination in a single injection. So this may help reducing the number of injections. So what are the opportunities with fixed combination? That is, it is addresses the multiple physiological effects, convenience, earlier achievement of goals, and persistence of the patient because we are using single injection, and maybe side effects are reduced, and if possible with a reduction of delay in the underlying disease progression and complications. So what the components give us, that basal insulin gives us a target hepatic glucose overproduction, decreasing gluconeogenesis, thereby reducing the fasting glucose, and this reduces the fasting glucose values. Whereas GLP-1 RA, which is a glucose dependent insulin release suppressors, by decreasing the glucagon and delays the gastric emptying, postprandial excursions are reduced, as well as there is a reduction in weight. So it improves the postprandial blood glucose control. This combination addresses the 7 parts of the ominous octet, like hepatic glucose production, glucose uptake in muscles, lipolysis through insulin, and through GLP-1 RA, it increases the glucose dependent insulin release. We are we will be very happy with the situation where we get the insulin released more in the portal circulation. So this is a portal release, so there will be a more effect on the prandial glucose. There will be decrease in the glucose dependent glucagon, so there is a decreased glucagon effect, more of satiety because the GLP-1 RA is the effect, and decreases the gastric emptying as a effect of GLP-1 RA. So these all are the effects achieved by the combination therapy. These finds mentioned in all the recommendations since 2022 as individual drugs or in combination. Let us see the clinical evidence behind the combination, where we can have studies like SOLID study, where we can see through a case where a 45-year-old diabetic for 7 to 8 years, he was on metformin plus other OADs and had a A1C of 8.5% and BMI of 25 kg per meter square, which is overweight by the Indian standard. So in this such population, Iglar-Lixi was used as compared to IDEC-ASP, the combination available, and it was seen in type 2 diabetes suboptimally controlled on oral drugs, that is SOLID study. The population had adult diabetes with more than 3 months on stable dose of metformin plus OAD, and BMI was less than 40, and A1C was between 7.5 to 11, and more than 7 to 10 if previously on metformin plus second SGLT2 OD. So there was a phase of screening followed by the Iglar-Lixi once daily in 300 patients and IDEC-ASP in the another 300 patients, and this was an open label randomized treatment period of 24 weeks, and it was followed up every 3 days, and the end of the treatment was at 24 weeks. The primary endpoint was non-inferiority in the A1C change from baseline to 24 weeks. So the groups, like age was around similar in both the groups, females and males were similar, BMI was similar in both the groups, as well as duration, A1C and usage of metformin and SGLT2 inhibitor. The benefit of these drugs led to a reduction in A1C and the achievable A1 was less than 1.8 with Iglar-Lixi and IDAGAS was lesser. So mean difference was 0.2%. So this was a non-inferiority and marginal superiority. So this combination was effective, and we all know that when we are using a GLP-1 analog, there will be a weight reduction. So there was a weight reduction with Iglar-Lixi to the tune of 0.3 rather than, and this was 0.3 kgs, and the gain of weight was 1.2 kgs with IDAGAS. So when we know that the glucose is assimilated, so we gain weight, and where the GLP-1 is there, you can have a lower weight. So this weight difference could be there, and the number of patients who achieved A1C less than 7 were slightly more, around 12% more with the IDAG than the IDAGAS, and those without body weight gain at week 24 were 40% as compared to 21% with IDAGAS, and A1C less than 7 without body weight gain at 24 weeks and no hypoglycemia during treatment. So this was more with the Iglar-Lixi, that is more than around 13% patients did not have hypoglycemia. So hypoglycemia is avoidable with lesser dose of insulin and more use of GLP-1. So there the change in SMBG in 7-point scale, you can find that the at baseline and at 24 weeks the benefits are there, and again the data are similar, but still the Iglar-Lixi levels are lower. So mean insulin dose, as we know that with use of GLP-1 there will be a lower basal insulin requirement. So there was a small less requirement of insulin as compared to the combination insulin. And as we know that the hypoglycemia is a dreaded complication for any insulin glucose lowering therapy. So level 2 hypoglycemia was very low, and this level 1 hypoglycemia or any hypoglycemia were lower with this combination of GLP-1 and insulin. So this rate of hypoglycemia event rate was also around 30% lower with Iglar-Lixi than IDAGAS. So SOLID study showed that there is no, non-inferiority and statistical superiority in HbA1c reduction, superior body weight management, more patients achieve composite endpoints, there is a lower risk of hypoglycemic events, and no unexplained safety findings in a 24-week study. So this patient around 6 months did not find a bad effects. This again, there was a comparison with this lixisenatide and glargine combination against BiAsp 30. So aspartate and NPH aspart given twice a day. So this as a 57-year-old diabetic for 12 years on metformin, insulin, metformin SGLT2 inhibitor, other OADs and basal insulin. A1C is uncontrolled, BMI is 28 kg per meter square. So in this case, the insulin therapy was to be intensified in the form of adding the regular or short-acting formulations. So what can we get as compared to the twice daily BiAsp? So this Solimix study was done, and in type 2 diabetic on basal insulin, OADs for more than 3 months, A1C of 7.5 to 10, and BMI of 20 to 40 kg per meter square, and basal insulin dose at 20 to 50 units per day. So the open label study again, and Iglar Lixi once a daily and BIASP twice a daily, and follow up every 3 days, and 26 weeks study, and total of 400 plus patients on each arm, and the total of 887 participants were included from 89 centers across 17 countries, and there were 182 Indian patients. So the change in glucose A1C was non-inferior with the use of Iglar Lixi. So this was similar to the BIASP. Again, the weight will be lost with GLP-1, and this as we are will be seeing more of GLP-1 effects of other molecules and the larger dosage also, we can see that the weight reduction can be more with a higher dosage. So we can have a high weight gain with insulin, and we can have weight loss with insulin plus GLP-1 RA. Again, the A1C endpoints were reached in more patients than BIASP 30, and there was less weight gain with IDEG, this lixisenatide and glargine, and they were A1C less than 7% without weight gain and without hypoglycemia. This was very much more, because you can see that around 12% more effect was there. So odds ratio was 3.4. So you can see that when we add a short acting formulation, number of hypoglycemias may increase, and the mean difference in Iglar Lixi versus BIASP, that is total insulin dose, was much less, and nearly half of the insulin dose was used with a combination of IDEC than the BIASP in Iglar Lixi. Again, the hypoglycemias were lower, and the level 2 hypoglycemias were much lower, around half of the BIASP 30, which we usually see in our day-to-day practice. And nocturnal hypoglycemias are possible with NPH form, so there is a less with Iglar Lixi than the BIASP 30. So in summary, the Solimix study shows that the better glycemic control with weight benefit, less hypoglycemia, once a day injection, and similar proportion of side effects in both treatment groups. And what the patients told, that with Iglar Lixi, more patients were happier than the BIASP 30. So the patients who had perceived improvement were more in Iglar Lixi, and high score that was there, and increase in 6 points and the increase of 8 points. Lower scores means less treatment satisfaction. With as we know that the combination of regular and NPH wants a discipline in the food intake. The combination of this Iglar Lixi comes with a 2:1 formulation, and it can be used from 10 units to 40 units of this glargine, and there will be a 5 microgram to 20 microgram dose of lixisenatide, and you can up titrate according to the weekly therapy and the effects. And this can be started at 10 units when the patients are insulin naive, or there is a glargine dose of less than 20, and if glargine dose is more than 20, we can start with 20 units and up titrate according to the glucose values. And when the glucose values are more than 100 but below 140, at +2, 80 to 100 is the target, and less than 80 we can reduce the dose by 2 units. And weekly dose adjustment is based on the median fasting SM plasma glucose from last 3 days. And the importance is that it is to be given 1 hour before the meal because of the GLP-1 RA. And meal has to be taken at the most convenient meal every day. We can time the injection before 1 hour of the dose, the diet. And if in case of a missed dose, inject Agrawal elixir within the hour prior to the next meal. It can be given to the elderly. It can be given only in mild to moderate renal impairment. It cannot be given in pregnancy and can be given in hepatic impairment, but we should be aware that the patients are taking orally and they are not very, the intake is not very poor, so we can withhold the injections in the cases where the intake is very difficult. So in summary, the Agrawal elixir is 1 injection once daily, 1 hour prior to meal, and it has a benefit of lower rates of hypoglycemia, improved GI tolerability, effective A1C reduction, fasting plasma and postprandial glucose control, weight benefits, once a day dosing. More people are achieving glycemic targets, more people are happy, and it addresses multiple pathophysiological defects. These studies like Solimix showed that it is efficacious, simpler, well tolerated, provided better glycemic control with weight benefits and less hypoglycemia. And Soliswitch study indicates that it may be simple and effective treatment option, and it is associated with improved glycemic control without body weight gain and increased risk of hypoglycemia. Thank you.
Thank you, Dr. Neeraj. Makes physiological sense, this combination. The studies that you quoted were on top of oral anti-hypoglycemic drugs. Does it work without the oral drugs also equally well? I mean, Agrawal elixir alone without any oral?
We can use it and then see the prandial glucose, and then if at all not controlled, we can give a prandial regulator, because the fasting may be targeted by glargine and GLP-1 RA also, but prandial glucose we do not know, may be targeted by GLP-1 RA, but still may require a prandial regulator.
And did patients require, salvage prandial insulin also?
This is not known in this study.
Okay. Anybody in the house may please ask questions.
You have used
yes,
experience, bovine and porcine.
Yes, sir.
Then what was the reaction to the patient?
Again, the insulins were the similar in usage like current insulins, twice a day, Mixtard, or NPH and Ultralente, and those and regular insulins, bovine and porcine. Bovine was cheaper.
When I prescribe bovine to the Hindu problem, when I prescribe porcine to the Muslim, very difficult. You have to, while prescribing, taking the care of community only.
Currently, we are getting rid of this because of the science has progressed to the synthetic level, so there is no animal origin.
Bovine 40 units per ml was available, and only Novo manufacturing and goods marketing.
Later on, sir, USV also marketed the bovine, and we could get at 75 rupees a vial.
USV first company and the Pfizer do oral, OHA for only one drug.
we don't have any questions, we'll end this session here. Thank you.
Thank you, sir. Thank you.
So for the next session on tirzepatide, may I call upon Yoshi Samal sir and Dr. Amaresh Krishna to chair the session, please.
Continuing with the session on cardiovascular, kidney and metabolic syndrome, I would like to invite Dr. S.K. Sharma, sir, to deliver a talk on tirzepatide, a novel GIP and GLP-1 receptor antagonist. Over to you, sir.
Respected chairpersons, Dr. Santosh, thank you very much for inviting me here. And I will be speaking on this molecule, which is one of the very famously, I should say, sailing the sale of anti-diabetic and anti-obesity drug. And in the last 6 months, I must assume that you must have a very good exposure to this molecule. So this is a newer things in the armamentarium of our doctors for the treatment of type 2 diabetes as well as obesity. So let's look at what is the method, how you are combining these two GLP-1 and GIP receptor agonist in the same molecule. So here we know that GLP-1 is a natural endogenous hormone which is secreted from the L cell of terminal ileum, and it is having many actions. At the level of nervous system, it reduces appetite, it increases satiety, and also increases nausea. In pancreas, it is having increased insulin secretion from beta cell, and it causes decrease in glucagon. Thereby, it is helpful in hyperglycemia management. And of course, GLP-1 causes decrease in gastric emptying. As compared to that, a molecule which was discovered earlier than GLP-1, this is GIP, and it is having many actions which are similar to GLP-1, but there are some subtle differences. So as GLP-1, it causes decrease in food intake, but it decreases nausea as compared to increased nausea by GLP-1. It has got a special action at the level of adipose tissue, whereby it increases the insulin sensitivity at the adipose tissue. It causes buffering action of this. So more and more lipids are deposited in the adipose tissue. It increases storage capacity. Lipid buffering action is very important because it decreases insulin resistance in the body, and it reduces inflammatory immune cell infiltration. And of course, in the pancreas, it causes increase in insulin secretion from beta cell stimulation, but it decreases glucagon. It increases glucagon when the blood glucose starts going down. So this is the difference between GLP-1 and GIP. So here you have a molecule which is having both the actions. So what they have done, our scientists have taken the molecule of GIP and they changed some of the amino acid sequences. Thereby, the same peptide is acting on GLP-1 receptor and also GIP receptor. So you find that this activity is more or less similar to GIP, but GLP-1 activity is a bit reduced. Being a peptide and attached to a long fatty chain, it is having a long duration of half-life, 5 days or so. That's why it is to be given every week. Being a peptide hormone, it has to be given subcutaneously. You can't have oral preparation at present. So you have to give these drugs in such a way that you are gradually up titrating the doses, because the drug is having some GI side effects, just like GLP-1 receptor agonists like semaglutide. So you have to start with low dose and you up titrate the doses every month or so, and the doses are right from 2.5 to 15 milligram. So there are many areas of working, and you can look at the mechanism of action of this molecule at the level of how it causes glycemic control, weight control, metabolic, you can say lipid abnormalities are also reduced, and cardiorenal effects are there. So in glycemic control, you find that there is a beta cell function which is improved, insulin sensitivity is also improved, and glucagon secretion is improved once the blood glucose starts going down. It is a very good drug for weight reduction, even having weight reduction of more than semaglutide. So as compared to 15% weight reduction with semaglutide, this drug is causing something like 22.5% weight reduction in our obese patients. And it decreases the appetite, it increases lipid oxidation and reduces carbohydrate and protein oxidation. In lipid metabolism, it is, as we just discussed, that it causes transfer of lipids from circulation to the adipose tissue. So lipid partitioning and adipose functions are there with this drug, and it is having cardiorenal effect, whereby it have decrease in cholesterol, triglyceride level, LDL level, and improvement in HDL. It reduces inflammation, and it is having some positive effect on the reducing inflammation at the level of endothelium. So looking at glycemic control, we can see that there were a large number of studies by the name of SURPASS 1 to SURPASS 5. These were different types of type 2 diabetic patients, whether given as a monotherapy or in combination, and in comparison to semaglutide, you find that there is a significant HbA1c reduction with this drug. So you have something like 1.8 to 2.5% reduction in HbA1c. Many of the patients even reached to a value of less than 5.7. The drug being do not cause hypoglycemia, so that's why the patients were able to achieve that low HbA1c reduction without hypoglycemia. So that concern is not there, and because of this, that weight of the patient is also reducing, and there is no hypoglycemia. In large number of SURMOUNT trial, the drug was used for the treatment of obesity. And here again, in obese patient, in SURMOUNT studies, there was significant weight reduction in these patients. So you find here that one of the study which was looking at the islet function and insulin sensitivity in patients of type 2 diabetes. Here again, as usually, they started the dose by 2.5, after 1 month, 5, then 7.5, 10, 12.5 and 15 full doses, and they compared it to placebo, and they wanted to look at effect of this drug on the changes in clamp study, to look at in this disposition index, that is the combination of insulin sensitivity and insulin secretion, and there were many secondary outcomes also. So here friends, you can see there is a significant improvement in first phase of insulin secretion. As we all know that in type 2 diabetes, there is a significant, or you can say absence of first phase of insulin secretion, which was very typically highlighted here, and you find very good response. Similar to that, there is a very good response in the second phase of insulin secretion. There is an improved insulin sensitivity rate, insulin secretion rate here. In this, some of these trials, which is hyperinsulinemic, euglycemic clamp studies, they looked into glucose infusion rate. So higher the glucose is required indicates that the drug is having very good insulin sensitivity, and you can see here as compared to placebo and even as compared to other you can say molecule, you find there is a very good glucose infusion rate in patients who were on tirzepatide as compared to placebo and other drugs. So it is increasing the insulin sensitivity M values also. Significant values are improved. So on one hand, it is causing increased insulin secretion. On other hand, it is also reducing insulin resistance or improving insulin sensitivity. And here in this study, they looked at what happens if you reduce the glucose from 100 milligram to 45 milligram. So as we all know, the usual hypoglycemic response is there is an increase in glucagon. But semaglutide causes decrease in glucagon, but here you find that tirzepatide is causing significant improvement in glucagon. That's why the chances of developing hypoglycemia is not there. So in summary of this glycemic effect, we can see that there is a significant improvement in beta cell function, insulin sensitivity with weight independent component, which is here they are comparing it to placebo and semaglutide, and they demonstrated intact glucagon response in induced hypoglycemia in our type 2 diabetic patients. Looking into weight reduction, these SURMOUNT studies were there where you are looking at different types of patients, and one of the study was also comparing it to semaglutide. So as a monotherapy, you can see here the patients who are on a background of you can say lifestyle modification, diet, exercise, you find that there is a significant reduction in weight of our patients in obese patients. So 16% weight reduction with 5 milligram, you have 21.4% reduction in 10 milligram and 22.5% reduction in 15 milligram full doses of tirzepatide. So as the years are, as the time is advancing, you find more and more patients are developing weight reduction. So weight reduction, as we all know, is a component of both fat reduction as well as lean muscle mass. But here you find that most of the weight which is reduced is from the adipose tissue, and something like 10% of the weight is reduced in the muscle mass. There are some, you can say, concepts that this muscle mass reduce is also because most of these patients were having significant fat deposition inside the muscle. So that fat is also melted out. That's why the muscle indirectly showing loss, but otherwise you find that one has significant adipose tissue loss, whether it is from the central compartment or total fat mass. And similar change in fat mass and fat-free mass, you can see here significant fat mass was reduced as compared to the lean mass, and the more weight loss was there once the patient was on dietary restriction in this 18 weeks study with tirzepatide. So friends, they wanted to look at another concept that once we stop or once we lose weight, our basal metabolic rate decreases, and patient, once you stop this drug, they start regaining. They say that about 80% of what weight you lost is regained in next 5 years or so. So here they wanted to look at the metabolic rate of our patients in sleeping metabolic rate studies, and here you can see that there is a significant adjudicated weight loss induced reduction in sleeping metabolic rate and 24 hours sedentary energy expenditure, in particularly in our obese patient. So there is a significant energy restriction here in spite of patient losing weight. In addition to this, there is a concept of food noise. Obese persons are always having a thought of what to eat, when to eat, why not I am eating more frequently. So that is called now a food noise. And this food noise is significantly decreased. The food craving is decreased by patients who are on tirzepatide as compared to placebo. So you find that patient is now preferring less of, overall scores are good with tirzepatide, high fat diet is reduced, sweets are also reduced, starches as well as fast food consumptions are reduced once the patients are on tirzepatide. So tirzepatide decreases the food craving, for sweets, carbohydrates, starch and fast food fats in our patients. Looking into metabolic, you can say lipid metabolism, you find that there is a very good reduction in triglycerides. To some extent, there is a decrease in total cholesterol. HDL cholesterol is improved. LDL cholesterol and VLDL cholesterol are reduced. So, having some positive effect on the lipid aspect of our patients. Looking into cardiorenal effect of tirzepatide, we find that there is a significant decrease in systolic blood pressure to the tune of 6 to 7 millimeter of mercury and diastolic blood pressure of something like 2 to 3 millimeter of mercury, indicating that there is a good response in this aspect also. Now, looking into cardiovascular outcome of the studies, for example, semaglutide has a clear-cut cardiovascular outcome trial. Tirzepatide trial was a comparative trial with dulaglutide, and it was showing non-inferiority. Dulaglutide was showing earlier superiority to placebo. So here you find that if you take all the studies of this SURPASS and SURMOUNT, you can see that indirectly there is a 20% reduction in the cardiovascular outcome trial. These are extrapolated findings, not a direct trial. And similarly, you find that these patients who lose weight, who has significant reduction in HbA1c, have all the cardiorenal benefit in our patients. So summarizing the mechanism of action of tirzepatide, in CNS level, it is causing decrease in appetite, it decreases feeding, and it is also changing the behavior of our patients. So in liver, it is also reducing the fat component. So must be having some studies in the future for MASLD, and as like ESSENCE trial with semaglutide, we may have a drug which is also working similar to that and causing a, you may be having a treatment of MASLD as a tirzepatide in the future. In pancreas, as we all know, a significant HbA1c reduction is there, and patient is having increased insulin secretion, and glucagon regulation is clear-cut, telling us that if the patient is having hypoglycemia, glucagon is not going down, it is going up, and having very good insulin sensitivity action as a systemic effect. It reduces cardiovascular outcome by improving the lipid profile of our patients, and GLP-1 receptor agonist action of this drug is causing delayed gastric emptying. So in the end, we can say that key takeaway is that the drug, which is a single molecule but acting on the two receptors, GLP-1 receptor as well as GIP receptors, and activating both receptors as naturally occurring in our body, and it reduces appetite, food intake, and increases fat utilization in our body. Secondly, it causes reduced craving for the food which are very high caloric and fat, and reduces it significantly. It increases the feeling of satiety, thereby decreasing the feeling of hunger, and that food noise, which what we discussed, is significantly reduced, and it lowers the body fat mass, and there is a slight decrease in protein, lean mass, but for that people are recommending high protein diet with resistance training exercises, because sarcopenia remains a bit concern in our patients once they lose weight, whether it is because of diet and exercise or SEMA or tirzepatide. We have to be looking into that aspect, that sarcopenia should not be there. So for that we recommend our patients that they should be taking excess of, you can say, protein and resistance exercises. The drug is available as a subcutaneous injections, and one injection contains 4 doses, and we always start with a low dose, 2.5 milligram. We uptitrate it every month. So ultimately many of our patients are on 5 milligram. If not responding well, or you want more better results, then you can go to 10 milligram, and the full doses are 15 milligram. To start with, there is always nausea, GI side effects, nausea, vomiting, sometimes diarrhea or constipation. So we have to explain these things to the patient, and that is the cause for gradual up-titration of the doses. And once the patient starts taking it and reaches to more than 5 milligram, then the chances of GI side effects are significantly reduced. And our patients are reducing weight. What we say that most of our patients will be having very good metabolic and mechanical benefits once they lose something like 10 to 15% of their body weight in a obese patient. And in that scenario, you find that the drug will be having very good effect, even also in obstructive sleep apnea, in reducing hepatic fat, in addition to very good control of hyperglycemia, and as a weight reducing drug in our patients. So thank you very much.
Is there trials that the people are using semaglutide without diabetes?
Yeah. So, as I discussed that these drugs like GLP-1 receptor agonist semaglutide, and this is a dual agonist GLP-1 and GIP. So both these drugs are used in diabetes as well as a treatment of obesity. So if a obese patient is there and he is not diabetic, you can always use these drugs. And in diabetic patient, you can always use these drugs as an anti-diabetic drug. There you don't need that patient should be obese. For diabetic patient may be having normal weight or slightly overweight, but in obese patient, our recommendations are that patient should be having clear-cut guidelines that BMI should be more than 30. In Indian context, it should be more than 27. And if the patient is having other comorbidities like diabetes, hypertension, dyslipidemia, etc., then we can even start with more than 25. Our patients, when the fat composition in a normal person is less than 20 in male, less than 30 in female fat composition. So if it is more than that, we say that person is having adiposity, and there you can always use it. So the patients are of two types. One is indication for the diabetes, and other is indication for the obesity. And as these drugs do not cause hypoglycemia, so you can use it in obese patients without diabetes also.
About the cardiovascular benefit, you have said that semaglutide has quite a host of benefit, but it is in a summit study, it is found that in tirzepatide that has given tremendous benefit in terms of reduction of features of heart failure to preserve ejection fraction, and also worsening of heart failure.
Absolutely.
Because these are the two very tricky ways how to treat cardiovascular.
So you are right, sir, that studies were done in heart failure with preserved ejection fraction. So we know that there are two types of heart failure, reduced and preserved. And in obese patient, it is mainly the heart failure with preserved ejection fraction which is there. And this drug has been tried there, and it has shown very good response in reducing cardiovascular death and hospitalization for heart failure. You're right.
Thank you. So if there is any question from the audience. So as there is no question from audience, we can close this session. Thank you, sir, for a wonderful talk.
I would request the chairpersons and the speaker to proceed for felicitation. Now for the next session, I would like to invite the chairpersons, Dr. B.K. Agrawal sir, Dr. S.S. Chatterjee sir, and Dr. Harshvardhan sir to the stage.
I would invite Dr. J.J. Mukherjee to please come. Oh, sorry. Yeah. Please.
Good afternoon. Thank you, Dr. Santosh Kumar Singh. You dragged me, otherwise I wouldn't have come. And thank you to Lupin. This session is sponsored by Lupin. I'll try my best to be as practical as I can be. Slides are not Lupin slides, so they're my slides. And of course, thanks to the chairpersons for inviting me. So I'm going to wrap up the whole meeting. Dr. Santosh Kumar, congratulations. I think your first inaugural ESI Bihar chapter has gone really well. Very impressed by the crowd, very impressed by the questions asked by the crowd. So this is the last talk, so I can forget the clock. Anybody who's bored can leave. So I'm going, there's nobody else is going to speak after me. So mere ko pressure nahi hai bhai. So management of CKD in type 2 diabetes, pillars of therapy. I have to use this. So what are we treating type 2 diabetes for? We're not treating diabetes for glycemic HbA1c, not for fasting glucose, not for PP glucose. We are trying to prevent complications. And the complications which I grew up with, what I was taught was microvascular complications on the left-hand side, diabetic kidney disease, retinopathy and neuropathy, and the macrovascular disease which was coronary artery disease, stroke and peripheral vascular disease. But there's a whole new chunk of complications which we ignore. Even in 2026, we don't focus on them. There's increased risk of cancer in people with diabetes, increased risk of infections, increased risk of MASLD, MASH and cirrhosis, functional disability, cognitive deficit and affective disorders. There's high prevalence of diabetes in people with type 2, depression in people with type 2 diabetes. We should focus on that. But my brief today is only diabetic kidney disease, so that's what I'm going to focus on. The definition of CKD. When I was doing my MBBS, it was a very complicated definition, which was the top one. CKD is defined as abnormalities of kidney structure or function present for more than 3 months with implications for health. This means nothing. This is like a story. What matters to me as a clinician is the lower definition, which is classified based on the cause, the GFR category, and albuminuria category. So the cause, generally we don't focus because we are all practicing diabetologists. I'm sure there's some internists here as well. So those of you who are internists might be managing hypertensive CKD or primary kidney disease, all the glomerulopathies and causing CKD. But today we are focusing on diabetes as the cause of CKD. But generally we focus on this slide. This slide you should have it in your clinic if you're managing type 2 diabetes with CKD. Is based on GFR and albuminuria. Gone are the days when we used to say microalbuminuria, macroalbuminuria. Get over the terminology now. Please say A1, A2, A3. Even people without microalbuminuria can have progression of the kidney dysfunction if GFR is low. So A1 is what we used to know as normal albuminuria, A2 is microalbuminuria, and A3 is more than 300 micrograms per milligram or 300 milligrams per gram. GFR category, I think G1 to G5 we should know. From tomorrow, if even 2 of you in your clinic notes write CKD G3, A2, G1, A3, I think my coming from Calcutta to Patna would have been satisfied. Don't write CKD, just be a bit more proactive, right? You know, G3, A2 hai, ki G3, A1 hai. You have to spend another 30 seconds more in your clinic. But that will make your clinical practice much more evidence-based. So if you see, the green bars are no CKD. If you see on the top, GFR has to be less than 60 for more than 3 months. So to make it chronic, CKD. And your ACR has to be A2. So the first 2 green bars on the top, there's no CKD. Then if you see anybody who's got macroalbuminuria, that is A3 proteinuria, the colors pink and red, they say that progression of CVD or CKD is high to very high. So tomorrow if you see a patient with type 2 diabetes who's got an ACR more than 300 lasting over 3 months, this guy is going to die within your lifespan. So give this guy more respect, give this guy more time, treat him well, get his risks for cardiovascular death and renal death low by doing what? We will discuss, the 4 pillars of therapy. Also if you see, take somebody with G3A. If you see G3A, eGFR is say, let's say 50. Look at the colors there. It's orange, pink and red. So with the same GFR, if you get increasing albuminuria, your risk of CVD or progression of CKD and death is increasing from moderate to high to very high. So in a person with CKD, both things matter, EGFR and ACR. I hope everybody in this room now in 2026 is doing creatinine and ACR. But I can tell you that even in my hospital, which is a tertiary level hospital, I still don't see people writing EGFR in their prescription pad. So if you're not doing it, if some of you change, it will be nice. How to screen? I told you, it's very, very simple. A serum creatinine and an ACR. There's a lot of talk about ACR. Aise karna hai, waise karna hai, falana, dhikana, bhul jao. Any ACR, anytime. Generally, you should take it first urine in the morning. You should take it for a few times and take average. All that is not possible. So any ACR, if you get, if it is more than 30, you're duty bound to repeat it in 3 months' time. If it's still more than 30, then it becomes CKD. Somebody with a GFR of 95 and ACR of 35 lasting over 3 months is CKD. And you have to treat him with equal vigor, like you'll be treating somebody with GFR of 62 and ACR of 350. So now I come to my pillared approach, which is management of CKD in a person with type 2 diabetes. What is the first responsibility of physicians? Is primary prevention, right? You should not let your type 2 diabetic patient develop CKD. And we fail miserably. If you take the CKD prevalence in India, you can see from study to study, the largest study says almost 40 to 45% of your type 2 diabetic patients, adults, I'm not a pediatric endocrinologist, have CKD. There are socho, 4 out of 10. And people with CKD have a hugely increased mortality because of cardiovascular disease. We can keep talking about tirzepatide and semaglutide and all the other things. But if the guy develops CKD, you're already, 4 wicket गिर गए बच्चों और 16 ओवर में बाकी 6 बंदे लेके बैट करना है. I hope that doesn't happen today evening. 7 बजे का मैच है. So I hope you don't lose 4 wickets in the first few overs. But once you develop CKD, that's what's happened. You've lost your top 4 batsmen. So what you should do, good glycemic control. There's enough data. DCCT and UKPDS, you don't need any other data. UKPDS has shown you very nicely. If you can just bring the HbA1c down by 0.9% and maintain it over 20 years, your risk of developing CKD is reduced phenomenally, geometrically. Blood pressure control. Blood pressure control is very, very important, and it'd be a shame. I don't know, you go and audit your clinic tomorrow. I've done my clinic audit, and I'm ashamed. I don't get blood pressure below 140 systolic in quite a large number of patients. Reason, blood pressure control in a person with diabetes is difficult. They need 2, 3, 4, at times 5 drugs. If 3 drugs you're failing, take my advice, add a MRA, add a mineralocorticoid receptor antagonist without investigating. They probably have primary hyperaldosteronism. Treatment of dyslipidemia. Isme kya difficulty hai to treat dyslipidemia? Very simple. We have cheap statins in our country. But look what we are doing in India. This is the ICMR data 2022. This is the latest that you have. 1 in 7 person in our country does not have good glycemic control. That's why we are now chasing CKD management. Blood pressure, half of them don't have control. And if you take lipids, which I thought was the easiest to control by giving a statin, and lipid control in diabetes is not that difficult compared to blood pressure. Blood pressure management is difficult. Lipid management is very simple. I mean, partly the fault is with us, partly patients also, who stop their statins saying, Dr. Sahib, is zarurat hi nahi mere ko. But whatever it is, only 40% have the lipids control, LDL cholesterol below 100. So this is the sad state of affairs. Before you talk about tirzepatide and semaglutide and whatever sulfonylureas, get the basics right. If you just give a metformin and a sulfonylurea and whatever drug, you can get HbA1c under control. If you follow the patient up properly, do your job properly, and if the patient also listens to you properly. Hamare patients bhi to smart hai na, ab kya kiya jaye. So now what we have done, we have lost the game. We have not managed the glycemia and blood pressure well. Patient has developed CKD, whatever level, G3A2, G3A1, whatever. So now the patient has come to you. If you don't believe me, for the next 2 weeks, just audit your clinic. People with your type 2 diabetes, GFR and A2. Just write down in a sheet of paper. You will find that you are not seeing less than 30 to 40% of people with CKD. Don't go by the definition, na CKD aayega, anemia hoga, usko edema hoga, usko hum nephro ke baad bhej. That is not the definition of CKD. GFR 58 or ACR 32 for 3 months, that's CKD. Because these guys will progress very fast. So now that he's developed CKD, what we can do? So these are the 4 pillars which are listed there for you. ACE-ARB, SGLT2 inhibitor, non-steroidal mineralocorticoid receptor antagonist, finerenone, and the last one is GLP-1RA, of which semaglutide at present has the most data. So these are the 3 pathophysiological defects. I mean, there are more, but these are the 3 which are of importance: metabolic dysregulation, hemodynamic perturbations, and inflammation. So we have to manage all these 3. So the first one, so the basic pathophysiology, if you see on the left hand side, a normal glomerulus, you see the afferent artery, you see the efferent artery, the pressure gradient is not much, so there is no increased intraglomerular pressure, there is no protein leak, there is no kidney damage. When you come into on the right hand side, if you see the glomerulus, your afferent arteriole is dilated, so more blood is gushing into the glomerulus, and your efferent arteriole is constricted. So ज़्यादा blood आ रहा है, कम blood जा रहा है. So there is increased intraglomerular pressure, increased filtration, and that perpetuates your kidney damage. So if you see all the treatment, they will act on each of these pathophysiological defects. The first one is hemodynamic perturbations, and the first drug, if tomorrow your patient with type 2 diabetes who's got microalbuminuria or who's got hypertension, if he or she is not on an ACE inhibitor A2RB, please ask yourself why. There has to be a reason not to give. They must be on an ACE inhibitor in A2RB with ample data. How does it work? It decreases the efferent, the outgoing arterial toll, decreases hyperfiltration, decreases endothelial dysfunction, decreases cardiac remodeling. And these trials were done when I was doing my studying, long time ago. IDNT and renal trial, IRB-SARTAN, which is not freely available to us, and the other is low-SARTAN. These are the 2 which had the large randomized controlled trial data, which showed unequivocally improvement in clinically significant renal endpoints. That's 2001. So now in 2026, if your patient is not on an ACE-ARB and you're giving tirzepatide and semaglutide to somebody who's got CKD, ask yourself, क्यों इसको नहीं मिल रहा ACE inhibitor ARB? Because all the trials have been done on the basis of ACE-ARB. So don't get carried away by finerenone when they come and say, oh, ये current है इसको लो, level से इसको लो. They were all on ACE-ARB only then. Now the next molecule is, this is the when to initiate a RAS inhibitor. Up to eGFR of 15, you can still use your ACE inhibitor ARB. And if you see, it's only on the side of albuminuria. So if you have a normotensive type 2 diabetic with CKD without albuminuria, probably there's no evidence for ACE-ARB. I would still use it, but there's no randomized controlled trial data there with regards to prevention of progression of renal failure. Now let's come to the second molecule. The second molecule is SGLT2 inhibitor. Again, I will repeat myself. If tomorrow your patient with CKD is not on an SGLT2 inhibitor, type 2 diabetic patient, ask yourself why. You should have a good reason to say why the patient is not an SGLT2 inhibitor. How does it work? Now look, it goes on the other side. It's working on the afferent arteriole. It's increasing the tone. So afferent arteriole जो बिल्कुल खुला हुआ है, उसको तो रास्ता बंद किया. So less amount volume of blood is coming into the glomerulus. Your intraglomerular pressure is going down. Plus SGLT2 inhibitors other functions also. They improve the tubuloglomerular feedback, decrease oxidative stress, increase anti-inflammatory effect. Anti-fibrotic effects probably are at animal level data. Now this is, do we have any randomized controlled trial data supporting it? Yes. It all started with canagliflozin, the Credence trial, which came in 2019. Then came the DAPA-CKD, and then came the EMPA-Kidney. These are the 3 trials we have with the SGLT2 inhibitor in people with type 2 diabetes and CKD. In fact, DAPA and EMPA also have data in non-diabetic CKD as well, but I'm not going into that. My brief is type 2 diabetes. So for once, whenever you read any renal trial, unfortunately, they club 5 endpoints together. Like whenever you see a cardiovascular outcome trial, they club 3 endpoints, isn't it? Cardiovascular death, non-fatal MI, non-fatal stroke. So you can't go and tell this drug will prevent stroke. You will see all sorts of permutation combinations, all sorts of meta-analysis trying to say this works for stroke, this works for heart, but you don't have heart data. Why? Because it's impossible to do such studies. Not impossible, it's very, very expensive to do such studies. So what they have done, if you see renal composite, I don't think you can read it. What they have done is reduction in end-stage kidney disease, GFR less than 15 over 3 months, doubling of serum creatinine. Some trials have taken reduction in eGFR to below by 50%, or death from renal and CV cause. So 5 points they've taken together as the renal composite. As to whether they affect each individual component similarly is hard to say. This is the best data you have. And with canagliflozin, if you see, they were all people with type 2 diabetes. So 100% were type 2 diabetes, mean eGFR was 56, ACR was 927. So these are people with huge amount of proteinuria. But this was the first study. Whenever a company does a trial, doesn't want to lose the trial, so they took patients where they had the highest chance of having benefit. And yes, they had 30% reduction in renal composite, and the green means it's significant. The boxes are made by me. 31% reduction in hospital and heart failure or cardiovascular death. That was canagliflozin 2019. DAPA came soon after. DAPA had about 70% people with diabetes, 30% without diabetes. Here the mean GFR was lower, 43, and the mean ACR is still very high, 943. And here they also show, don't go compare the numbers, 39% reduction in the renal composite, almost similar renal composite, and 29% reduction in hospital heart failure and cardiovascular death. Then came empagliflozin. The beauty about the SGLT2 trials is each one complemented the other. You can't compare them. It's impossible to compare. Why? Because the people included in the trial were different. In the EMPA kidney, if you see, I think I have to pick stuff. There it is. The mean follow-up was 2 years. Type 2 diabetes was almost half of them were type 2 diabetic. Now see the mean eGFR is even lower, 37. And mean ACR has gone down, 329. Why? Because they had a chunk of people who had no albuminuria. So now this is the first time that you're having a drug given to people with type 2 diabetes with CKD without albuminuria. And despite that, it shows you a 28% reduction in renal composite endpoint. I think I can give you the reference later on. You can get hold of this paper, Clinical Medicine 2023. So this is where you can use SGLT2 inhibitors now. See, each complemented the other. If you had canagliflozin, you could not have used in people without albuminuria. With dapagliflozin, the albumin goes down. With empagliflozin, they included people with A1, that is albuminuria less than 30. So this is the indication. This is Alice Y.Y. Cheng. She does a lot of lectures on diabetic nephropathy. So you can initiate in people up to an eGFR of 20. Once you have initiated, suppose I have a patient with type 2 diabetes, eGFR was 35, ACR was 300, I started on empagliflozin, or for that matter dapagliflozin, and the condition progresses, eGFR becomes 15, 14, 13, potassium is still okay, no volume overload, does not need dialysis, you can continue your SGLT2 inhibitors until they start renal replacement therapy, which is either a transplant or going on hemodialysis. As to whether you can use them during hemodialysis to get the cardiovascular benefits, that's open. Trials are happening. So, sir, I have only reached 2 pillars. I have 2 more pillars to go. By the I'm the last one, na, so. So, the building, इमारत गिर जाएगी. दो ही पिलर हुए हैं. चलिए तीसरा पिलर आ रहा है. तीसरा पिलर, I'll finish very fast. Don't worry. So, third pillar is finerenone. Now, the other drugs, SGLT2 has glycemic benefit as well. Finerenone is primarily only for prevention of progression of kidney disease. And it's working on the inflammation arm. Decreases inflammation, decreases fibrosis, decreases endothelial dysfunction, decreases proteinuria, decreases renal modeling. And only basically 2 trials. It's called Fidelio DKD and Figaro DKD. Fidelity is not a trial. Fidelity is basically combining the data from Fidelio DKD and Figaro DKD and making a whole huge big database. And so you see everything about the kidney from 2001 to 2019 for 18 years. I think 6 companies spent, I don't know, $8 to $10 billion. 6 to 8 molecules were tried in people with type 2 diabetes to prevent progression of CKD. They failed. So this is when ball started rolling. When SGLT2 credence trial showed benefit, then comes finerenone. And these are the 2, Fidelio DKD and Figaro DKD. Fidelio, they were complementary. The inclusion criteria was almost similar. That's the beauty about Bayer. When they did this trial, they end up with total of 9,000 people with type 2 diabetes with DKD. And that's why they can give such strong data to you. in the Fidelio DKD, it was predominantly CKD stage 3-4, whereas Figaro DKD was predominantly CKD stage 1 and 2. Fidelio, they took renal endpoint as the primary endpoint, whereas with Figaro DKD, they took the cardiovascular endpoint as the primary endpoint. And secondary endpoint was just the opposite. And both trials showed that finerenone was generally well tolerated and that the increased incidence of hyperkalemia had, so basically they showed that it decreases the progression of CKD as well as reduces the cardiovascular, the 3P MACE. So if you using finerenone, I will leave that. When to initiate finerenone? Here if you see, it is only people with albuminuria. There's no data of finerenone as of yet in people with type 2 diabetes without albumin. They're doing a trial now. And you can use it up to an EGFR as of now, 30. So if you're using in a person with type 2 diabetes, mind you, they were all on ACE-ARB. Don't get me wrong, the first pillar has to be there. But in this one, the second pillar was missing, SGLT2 was missing. They used ACE-ARB and finerenone. That was the Fidelio DKD and Figaro study. So now your question will be, Dr. Mukherjee, what about combining all three? But data है क्या आपके पास? था नहीं, आ गया है. And that data came in last year, in June 2025. This was called the confidence trial. The confidence trial was basically people who were on ACE-ARB and they gave both finerenone and empagliflozin together. So all the three pillars, ACE-ARB, SGLT2 and finerenone. A little difficult to take you through all the data, but all you can see is if you are having ACE-ARB, on top of that if you are having EMPA plus finerenone together, your reduction, it was a surrogate endpoint. It was a reduction in ACR. It was not the 5P endpoint for renal that the other trials had, because it was a shorter duration of trial, only for 180 days, 6 months. But the surrogate marker, there was reduction in albuminuria. So, 3 pillars you have given. So from tomorrow, these 3 pillars must be there in all your patients. If you have somebody with CKD, diabetic, they should be on ACE-ARB, SGLT2 and finerenone, unless and until, of course, there are contraindications. The 4th pillar, I think most of our patients will be on after a month, I think. Because at the moment, the biggest problem of starting the 4th pillar is the cost. But the data is very impressive, and that is the FLOW trial. I'm sure you must have heard about FLOW trial many times. I can see Novo people smiling. So FLOW trial has been presented many a times. This was subcut semaglutide 1 milligram, and that is the latest data you have, 2024. 5 or 6 different mechanisms are still being studied. They are in phase 1, phase 2 stages. As to whether they will come into the market or not, we don't know. What was the FLOW trial? FLOW trial also came in NEJM about now 1.5 years ago. I think you attend one of the other FLOW meetings where they will take you through the entire detail of what semaglutide did to people with diabetic with CKD. Basically, composite kidney endpoint reduced, the GFR slope reduced, first time to MACE also reduced, time to all-cause death also was statistically significantly reduced. So, if you can put ACE-ARB, SGLT2, finerenone, and your patient can afford semaglutide, sone pe suhaga, you will have. But if you combine all 4, you get more benefit than only 3. We don't have that data as of now. So you will say, Dr. Mukherjee is injectable. Why not? What happened to the oral semaglutide? Oral semaglutide hasn't done a renal endpoint trial yet. They did the SOUL study. The SOUL study was basically the cardiovascular outcome trial on the top 3P MACE, which was statistically significant. What they had was a secondary outcome, which was the same 5P major, now it's called MAKE. We call MACE, major adverse cardiovascular event. Now it's called MAKE, major adverse kidney events. That's something called MALE, major adverse liver events. So MAKE, MALE, MACE, sab kuch aur kya aayega pata nahi. So here the secondary outcome in the SOUL trial, I just made this table for you, exactly like Fidelio and Figaro, which Bayer did. The difference in the FLOW and SOUL trial is the baseline population was not the same. So you can't compare them exactly, but FLOW trial, like the Fidelio trial, was primarily a renal outcome. It was primarily a cardiovascular outcome. The FLOW was renal outcome trial, and that's why you see renal benefit is in green. But in the FLOW trial, they also got cardiovascular benefit, reduced MACE and all-cause mortality. SOUL trial was primarily a cardiovascular trial. SOUL was oral semaglutide, and there they got reduced MACE. They did not get the secondary benefit, but there was numerically reduced renal events. So with that, this is the final take-home slide. When it comes to treatment of end-stage kidney disease, I know nothing. So I have some very good renal colleagues. Because I don't know anything about hemodialysis, peritoneal transplantation. So my take-home message is, first and foremost, try to prevent. Tomorrow, if you see a new onset type 2 diabetics, tell him your diabetes treatment is not glycemic control. Your diabetes treatment is to prevent retinopathy, nephropathy, neuropathy, and basically cardiovascular event and a stroke. Day one, you should tell the patient. Day one, you should tell the patient, आपको आगे चल के insulin लगेगा, डरना नहीं है. If you can tell this to your patient, then when you need to start insulin, it will be easy. Unfortunately, 40% people will already have CKD. If they have CKD, these are the 4 pillars which I have discussed. With that, these are the 4 pillars, and that is the timeline given to you. ACRB has got data from 1981. That was the type 1 diabetes, the Lewis paper. And then for type 2 diabetes, you have the IDNT and renal. SGLT2 inhibitors, you have 2019, you had the Credence trial. 2021, you had the DAPA CKD. 2023, you had EMPA kidney. I like the SGLT2 inhibitor trials. I don't know whether the companies, I don't think the companies spoke to each other, but the trials were so nicely done that they went from one spectrum of CKD to the other, increasing spectrum, and now you can use SGLT2 inhibitor in any type 2 diabetic patient with or without albuminuria up to a CKD, up to a EGFR of 15. Finerenone, you are up to EGFR of 20 you can use. Finerenone use, always be careful. All 2 ACE, ARB and finerenone, there's a risk of hyperkalemia. So if you're using these drugs, you're duty bound to monitor potassium. And if your patient can afford a semaglutide, I think they will be able to afford from next month. Then you should be able to add 1 milligram of semaglutide. And if you want real data, then you have to use the innovator because the others don't have renal data. With that, I'll stop. Sorry very much for exceeding by 5 minutes.
Thank you, Dr. Mukherjee, for an excellent presentation.
Thank you.
So as a nephrologist, I have few comments to make, sir.
Please, sir.
So actually, sir, 2001, as you said, by the IDNT and the renal trial, which was excellent trials, and they, for the first time, they showed that you can reduce the GFR progression by about 50%. But unfortunately, after 2001, till the SGLT2 came in, as a nephrologist, we had nothing to offer to the patients. And non-inclusion of CKD patients have been the major problem with all the trials. And the one reason was that they might be expecting some adverse events of inclusion. Other problem of inclusion was the renal endpoints which were selected. I mean, the classical selection in all these studies were doubling of serum creatinine or initiation of end-stage renal disease. Around 3 years back, there was a meeting, and now it was suggested that CKD patients should be included in all cardiovascular and diabetic trials. And the reason was that now they said that you can have surrogate endpoints. One surrogate endpoint was your UACR reduction at 6 months and GFR slope at 18 months. So this was one of the reasons, I mean, more and more trials was there. The one point which you said about finerenone, in fact, now finerenone. So now finerenone, we are also one of the investigators in the Captivate trial, and now we are recruiting a lot of patients, even non-diabetic CKD, and we have selected the criteria of 20. One interesting point which came out from this confidence trial, and even before that, was that if you use SGLT2 along with RAS inhibitors or finerenone, the chances of hyperkalemia is less. Yes. So in fact, that has given us confidence of using it more and more. And with now oral potassium binders now in the pipeline, probably let's say we can have more benefit of RAS inhibition. And the last point which I would like to make, sir, was from the stop ACE in the trial. Now as a nephrologist, we have the confidence of using, ACE inhibitors or ARBs even in dialysis patients, because stop ACE suggested that if you stop ACE, the harm is more. Thank you, sir.
We are waiting for SGLT2 also to be used.
So currently, sir, we are using SGLT2 even in patients on dialysis currently.
But that's off-label.
Right, sir. But we are using it. And in transplant patient, we have started using it now.
Again, gathering experience.
Right.
DAPA is doing a study, as you rightly mentioned.
This pillared approach is just like the pillared approach of heart failure.
Same thing, sir.
Same thing, yeah. In fact, I don't know whether you have heard about 1,000 pillar temple of Warangal. Have you ever heard? If you cannot hold a structure, you cannot stabilize a structure by 1 or 2 pillars, go on adding other pillars to stabilize the thing. So that is like that.
Yes.
So in future you might have 5 or might have 6 and things like that. As in heart failure now the digitoxin has been taken as probably the fifth. Yeah.
And the fifth pillar in CKD is now the sparsentan. We are now promoting as the fifth pillar. In fact, the Captivate has one of the arms as using this sparsentan. Let's see what happens.
So if there is any questions from the audience, yeah, please. Or any comment.
My humble request, from tomorrow, write G3, A2, G2, A1. कल से prescription लिखना शुरू करो. I will be very happy.
These pillars should be sequentially added or simultaneous.
So I told you, before confidence, I could not answer that question. Now with confidence, I can answer.
Yep,
ACE, ARB, SGLT2 and finerenone, you can add. As to whether you should start semaglutide also from day one, I don't have data for that. But if patient with diabetes, you want glycemic control, you want to lose, they are obese, most of them want to lose weight, you can combine all 4. But combining ACE, ARB, SGLT2 and finerenone should not be difficult. We don't have single pill now, as of now, all 3 together. Single pill nahi hai.
Those who do not have HER, I mean proteinuria, and still have CKD and diabetes.
You can use SGLT2. SGLT2 has got the data.
That's the only thing you can use at the moment.
That's the one data, but we also use ACE-ARB. Without hard data, we use it.
ACE-ARB is there.
Finerenone, you can use it once it is above 300. Yeah.
Sir, regarding starting of the sequential therapy, how long we should look for the response to come? Like first starting ACE inhibitor, how long we should keep the patient on this ACE inhibitor to see the maximum response?
Lifelong, सब कुछ lifelong.
Not, but if the patient is not responding to that medicine, then
I don't understand what you mean by not responding.
Okay, I'm just saying that if the patient is having diabetes with albuminuria A1 or A2, so most of the time they usually control with diabetic improvement. They reverse with improvement. If not improving, then we add ACE inhibitor. So how long and what is the maximum dose at which you should continue the patient on that treatment, and then subsequently second line should be added?
That's the whole idea of this talk. There is no second line. It's all, you start 4 pillars together if you can. Most likely we can't start 4 pillars together. One is an injectable, a little bit expensive. So you start with 3 pillars. Now question is if the patient is at risk of hyperkalemia. That is the only time when you might not start all 3 together. I did not show that slide, I rushed through. To start finerenone, your potassium has to be below 4.8. When you decide that I'm going to add finerenone, that potassium in front of you in the last 4 weeks should be below 4.8. And then based on the GFR, if GFR is less than 60, you will start with 10 milligrams. If GFR more than 60, you will start with 20 milligrams. You are duty bound to check potassium at 4 weeks. If you add finerenone, if it is more than 5.5, you are supposed to stop.
Okay, so we can.
So now if somebody is an ACE inhibitor and an SGLT2 inhibitor comes to my clinic, my main aim would be to start finerenone for this patient if potassium allows me.
Okay, sir.
Does it answer your question? So there's nothing called ACE fails, then I will add SGLT2 fails, and I'll add nothing like that. You should try to add all together.
There is no clear-cut timing till the ACE.
It's not the same thing with diabetes now. No? Diabetes is also combination therapy now. You don't give this is all sequential therapy which we studied. Give metformin 3 months, then fails. Give SGLT2 fails, then give DPP4. All that is gone now. Now it's hit hard from day one. Same thing, we have a nephrologist in the panel. He will also agree with me that it's all combination therapy now. Hit hard initially. Because once the GFR starts declining, same thing with diabetes, once the beta cell starts failing, it's very difficult to reverse it.
Thank you.
Not responding. If your patient is not responding and you are not giving this drug, that is okay. In spite of giving this drug, patient is progressing. What will happen if you are not giving these drugs and patient will be progressing very rapidly? So these drugs has to be there on board.
Despite giving these 3, you will not make the patient immortal. His GFR will keep going down. You saw all the curves. No? The GFR doesn't become parallel. GFR is still going down. No matter if you give all the 4 pillars, his kidney will still progress and fail at one time when we'll have to send to a nephrology colleague for RRT and renal transplant. All you're doing is buying time. maybe instead of going for dialysis in 8 years' time, he or she may go for dialysis in about 24 years' time. There's a very nice paper with empagliflozin. Google empagliflozin, delay in hemodialysis. You must have seen. You can delay it. It's a basically statistical calculation. I don't know how far to believe it, but they say if you start early, you can delay dialysis by almost 40 years. That's what they say.
Yes, in fact, to make a point much more stronger, in fact, after DAPA CKD study was published, a very big dialysis company, Davita, had to come out with a press conference suspecting the outcome of DAPA CKD, and they were suggesting that this trial has to be done again because this can't be true. So in fact, we are now in a position, let's say, we are very hopeful that probably the chronic kidney disease, diabetic chronic kidney disease is not as dangerous as it used to be. Probably we are much more hopeful.
Provided
all these things
use
are done.
the drugs.
Yeah.
The SGLT2 inhibitor use, sir, is so minimal in our country.
Right. In
GLP-1 almost non-existent.
Sir, in fact, RAS inhibitors use, even in a US survey, was only 32%.
ACE inhibitor, why your patient is not on SGLT2 inhibitor. Third is a bit costly drug, that is Fenrinon, but if patient affords, it should be there. But at least 2 drugs, and after 1.5 months, I think all our patients should be on 4th SGLT2 GLP-1 receptor agonist.
और अगर नहीं हुआ संतोष जी फिर बुलाएंगे, मैं फिर लेक्चर दूंगा.
JJ, from the clap you can assess. It was my deliberate decision to keep you at the end.
In the end.
Post lunch and the last session. Okay, a couple of comments.
Yes, sir.
We were talking about the time frame, renal replacement therapy. And if you institute SGLT2 inhibitor, that was the EMPA.
The EMPA, that paper, na?
30 EGFR, 60 EGFR, and 90. And it was 27 years you could delay if you start at 90 ml per minute. So if you start early, definitely you will be reaping greater benefit. The same has come up with Fenrinon in the combination trials, triple drug. And it has been able to delay by 12 years. So these are definitely strong data. Only problem is that, as the question was, whether it should be sequential or it should be on the go, on all the therapies at once. Definitely, if the patient is prone to have a rapid decline, and that we can assess from the heat map, that we can assess from the KFRE equation. We have an app for the kidney failure risk equation, and from that, if you can assess that there is a rapid decline, we need to go from day one. JJ was more focused on CKD. I had hinted him that there is also, this applies for heart failure. Dr. Chatterjee mentioned about that. Interesting thing is, there was ample data for heart failure preserved ejection fraction from mid-range to preserved ejection fraction for GLP-1. But in the obese category, it has also benefited patients with reduced ejection fraction. That was shown in the Swedish heart study and a study by Amrish Pandey from Canada. And they have shown the benefit of GLP-1 even in that reduced ejection category.
वहाँ पर data थोड़ा सा ढीला है उधर.
So that is there pillared across CKD and heart failure across the.
So I didn't realize he wanted me to speak on both. 20 minutes में it's impossible to speak on.
So that was it. I think JJ needs a standing ovation.
Thank you. Thank you.
I would request the chairperson and speakers to proceed for felicitation. So with this, we come to end of our 2-day event, and I would like Dr. Santosh Kumar sir to come on the stage. Sir.
So good evening, everybody. Whatever I say, it is on behalf of this team. So they will have to take the responsibility of what I say. Valedictory, I think I should not call it. Valedictory, literal meaning I was saying to say goodbye. I cannot say that. West Bengal में मूर्ति विसर्जन हम लोग करते हैं तो होता है कि आस्ते बछड़ आवर हवे नेक्स्ट ईयर फिर होगा, इसलिए everybody has to be prepared for that. So at the outset, my heartfelt thanks to my speakers. कश्मीर से कन्याकुमारी था इस बार, है ना? So across the spectrum from the north to south, east and west, we tried to incorporate everybody. My chairpersons, and as I said, along with my team, is there, and अगर नहीं कहेंगे तो जाती होगी. It is possible with the help of the pharmaceuticals. तीन चार नाम थे जो उत्सव हॉल में थे, और नाम मैं नहीं लूँगा. तो अगली बार उम्मीद है कि सारे लोग उत्सव में ही रहेंगे, और क्यों रहेंगे सो पता ही है. सो यू हैव टू बी प्रिपेयर्ड विद दैट, कि कोई आदमी लीड नहीं करे, तीन चार आदमी की वो हम प्रीमियम क्लास में जाएं. सो एवरीबॉडी हैज़ टू बी देयर इन द सेम ब्रैकेट. सो वंस अगेन माई सिंसियर थैंक्स टू द फार्मास्यूटिकल्स. Both monetary aspect to है ही, but everybody tried their best. It's very important to have delegates for our meeting, and I am blessed that I somehow had been associated with the different organizations over here, starting with Bihar Diabetic Federation. Sir is the founder member. RSSDI बिहार चैप्टर, तो ये दोनों में ही मैं प्रेसिडेंट रहा हूँ, तो थोड़ी सी हक बनती है इन लोगों को बुलाने की. एंड everybody has just cooperated, and as I said, the pharmaceuticals has been able to make people attend from the faraway periphery. So again, thanks to everybody, the delegates. They are the heart of any conference. Delegates सब कहें या फैकल्टी का है, एवरीथिंग स्टेम्स फ्रॉम देम. अगर स्पीकर्स भी यहाँ टॉक दे रहे हैं तो दे ऑलवेज लुक कि कहाँ तक लोग भरे हुए हैं, पीछे तक, एंड इट इज़ ऑल यू हु मेक इट अ सक्सेस. Not less important is the contribution of the people over here. There was not a single glitch कि कहीं हम लोगों को कुछ करना पड़ा कि यहाँ गलती हुई, वहाँ गलती हुई. And the whole team management which was there, headed by Raja's event management. Again, I would fail in my duty if I don't mention about my Karan Arjun. So Karan Arjun, anybody's guess? उसमें तो एक आदमी का दो नाम है. उस करण अर्जुन में एक है जो मैं होना भी है. इट्स शाहरुख खान टाइप, और कोई भी दिक्कत उनको पकड़ो. एंड दैट इज प्रवेश झा. Okay, and करण अर्जुन का दूसरा कंपोनेंट वाज रुपेश, और मैं कंपनी के नाम नहीं ले रहा हूँ. सो इट इज़ नॉट फॉर फार्मास्यूटिकल्स, दिस इज़ देयर. और it won't be excess to say that Endocrine Society की registration हो, GST हो, it was all possible by Dr. Dravesh ji, Mr. Dravesh ji, Dr. कर रहे हैं. So it was his effort. We always were there to goad him to do this. He doesn't even require goading कि ये कर लीजिए. So if you just assign कि आपको ये करना है, तो you are clear that it will be done. So once again, Dravesh ji, सबके तरफ से आपको भी, and I would ask anybody who can just want to come, and before that, श्याम को माइक देने के पहले मैं चाहूँगा कि बाहर के लोग कुछ आके कहें. जे इफ यू आ जाओ शर्मा जी पीछे हैं.
Energetically asking questions, and even our very old colleagues and very senior colleagues were also inquiring about many questions, and being first meeting, and it is a very successful meeting, so I hope next meeting will be far better. All the best.
आप सबों का सहयोग इतना रहा कि यह एक यादगार पल के रूप में जाना जाएगा. यह हमारी शुरुआत थी. संतोष सर के लिए मेरे पास एक लाइन है, शब्द है, हीरा है सदा के लिए. बाकियों के लिए मैं उनको किसी दूसरे, आजकल के डेट में मैं उनको तांबा चांदी सोना नहीं कह सकता, क्योंकि सबकी कीमत आसमान लग रही है. हमारे लिए सभी बहुमूल्य हैं. हमारे सभी साथियों का, फार्मा इंडस्ट्री का, लोगों का बहुत अपार सहयोग रहा है. और करण अर्जुन की बात को मैं भी कैसे छोड़ सकता हूं कि इतना रिलाई करना कि इस काम को होना है, बस उसके सारे इफ्स एंड बट्स को दूर करते हुए उन्होंने इसको दूर किया है. इसलिए मैं अपने दिल की गहराइयों से आप सभी को दिल से धन्यवाद देता हूं. आप आए और आने वाले दिन में बढ़ चढ़ कर हिस्सा ले, इसी अपेक्षाओं के साथ आप लोगों को सादर नमन.
और कोई दो लोग अभी और हैं, बाद में बुलाएंगे वेद को, क्योंकि मैंने कुछ नहीं किया. जो करना था वेद को ही था, जो भी होता था मैं भेज देता था वेद को. वेद विल कम इन द एंड. नाउ आई हैंड ओवर द माइक टू अनिल. वो हमेशा पीछे दिखेगा. हाँ चलो आ जाओ.
As I said, I was a mere foot soldier. The general was Dr. Santosh, and everything that we did was spontaneous. I mean, led by Dr. Santosh, there was an intrinsic desire to do it well, and with the help of everybody, as everybody talked about, it actually turned out to be good. Thank you very much, each one of you.
सो सब लोगों ने बोल ही दिया है. एक बार फिर मेरी ओर से भी सबको बहुत बहुत धन्यवाद. सबका पूरा सहयोग मिला है. जिस स्तर पे हम लोगों ने जिसको जो काम बोला है, सबने हमारी हेल्प मदद करी है. और सबके सहयोग से जितने भी लोग यहाँ से गए हैं, जो बोल के गए हैं कि बहुत अच्छा रहा है, एकेडमिक प्रोग्राम बहुत अच्छा था, बाकी सारा अरेंजमेंट भी ठीक था, इस सब के लिए आप लोगों का बहुत बहुत धन्यवाद. और पूरी टीम से, कोई एक आदमी नहीं, लीडेड बाई संतोष सर, देयर इज़ नो डाउट, बट सारे लोगों ने मिलकर जिसको जो रिस्पॉन्सिबिलिटी दिया गया, सबने अपना रोल निभाया, पूरी तरह से निभाया. और ऑर्गेनाइजिंग टीम की ओर से सबको बहुत बहुत धन्यवाद. थैंक यू.
So we come to the end of today's meeting at least, and with blessings of H.K. Singh sir. यहाँ जानबूझ के हमने ऊपर नहीं बुलाया सर को. सर ऐसे अंग्रेजी में पेट्रन टर्म यूज होता है, लेकिन जस्ट थिंक सर एज प्रेसिडेंट ऑफ एंडोक्राइन सोसाइटी ऑफ इंडिया बिहार चैप्टर. सो थैंक यू. So thank you once again. We can